Hello everyone, good morning to you all. So may I request you all to please settle down. We'll shortly start. We are waiting for DDG sir to come in. So as soon as he arrives, we'll start. So request you all to please settle down. I would request all the jury members to please take seat on the front table which is allocated for jury members. Uh, do we have in the audience some representative from NHSRC? Okay, okay. Yeah. Esteemed delegates from Ministry, Central TB Division, development partners, donors, representatives from state NTEP, patient provider support agencies working across country, NGO, and community representatives. Ladies and gentlemen, I welcome you all to this 2 days national conference for PPSA cross learning. Good morning and warm greetings to you all. Patient Provider Support Agency has been one of the strategic intervention being rolled out under National Tuberculosis Elimination Program. For the past few years, PPSAs have been effective in boosting private sector engagement and improving care among TB patients being treated in the private sector. There have been many learnings, innovations, challenges which goes behind successful implementation of PPSA model in different geographies which are worth learning. This conference has been convened by Central TB Division with support of IQIA to provide an opportunity to all the organizations implementing distinct PPSA models in different geographies under NTP to showcase best practices, innovations, and ways to remediate implementation challenges with us all to promote cross-learning. With this background, let us inaugurate the event by hearing from respected dignitaries and key speakers. I will take the privilege to invite all the dignitaries on stage. May I request Dr. Rajendra P. Joshi, Deputy Director General TB, to please be on dais, sir. Now I would request, thank you sir, now I would request Dr. Raghuram Rao, Assistant Director General CTD, to be on stage, sir. Now I would like to request Dr. Nishant Kumar, Joint Director TB, to please be on stage, sir. I would request Professor Venkat Raman, Professor HRD and Health Systems, Faculty of Management Studies, to please be on stage, sir. I would request Dr. Neeraj Raizada, Team Lead NTSU from IQIA. I would request Dr. Malik Parmar, sir, to please be on stage, sir. Yeah. So before beginning the keynote addresses from our dignitaries, I would request my colleague Divakar Sharma to greet the dignitaries with green welcome. I would request the audience to please give a joint hand to welcome the dignitaries.
Recording in progress.
Thank you, Divakaji. Now, may I request Dr. Raghuram Rao for his welcome address to the audience.
Thanks, Dr. Sandhya, and a warm welcome to all participants for this very important workshop and rather conference. It's been a wonderful experience in terms of the program to be able to work so closely with the private sector. I mean, I can't recall any other national program to be, working so closely with the private sector. And of course, the uniqueness of tuberculosis and the health-seeking behavior of our population and the strategies that have been adopted by the program is also a learning experience for many other national programs. And we have been guided by our development partners who first started off with pilot interventions in this arena around 5-7 years back. And then it's been tried, tested models which have scaled up across the country now with domestic budget through the PIPs. And it was high time that we also learn from each other in terms of the implementing agencies which are actually on ground, reaching out to the private practitioners and working towards achieving the objectives of the program. And it's a first of its kind workshop. Although it's quite delayed, we should have probably done it long back. We now have almost 2.5 to 3 years of strong experience of implementing these interventions through the domestic budget. And annually we have an NHM best practice workshop where across different thematic areas, and private sector was an agenda there, and we have presented it in that, but it's part of an overall thing, and with a time slot for tuberculosis program within communicable disease, and within that a small space for private sector. And as we have grown over the years, and almost 30 to 35% of the notifications that we have under the program are now coming from the private sector. And the drug sales data also indicates that we are close to reaching saturation levels, although it's still there is a gap in terms of the achievement. So I have a presentation that through the session I'll be probably discussing on that in details. But with this objective for this workshop, I once again welcome everybody for joining here, the implementing agencies, our partners, our I would say the pillars of implementation at the state level, the state NTEP and our WHO network of consultants who are hand in hand with the state governments in implementing these programs. So once again, thank you all for joining in, and I'll hand it over back to Sandhya for taking forward the proceedings. Thank you.
Thank you very much, sir. So now I would request Dr. Malik Parmar to say a few words at the occasion. Yeah.
Thank you very much, respected DDG sir, Professor Venkatraman, Rao, Nishant, Neeraj, all state TV officers, all developmental partners and technical partners, all NTSU staffs, STSU staffs, all the teams from the PPSAs from various states. I bring in greetings from the WHO country for India, and really pleased to be sitting here. You know, this whole urge of having, you know, equitable access to good quality care to any patient seeking care, irrespective of whether it is in the public sector or in the private sector, has been with the program for nearly 2 decades. For almost a decade, I remember there was an attempt to have, you know, some kind of a PPM model worked out. And then the first time, you know, we saw the birth of the something called as NGO-PP guidelines. That went through revisions after, say, 7-8 years, but then eventually in 2012, 2013, when the Universal Access to TV Care project was conceived, and which ran through, you know, it was a collaborative effort, CTD led it, and it was supported by the WHO Country Office, the BMGF, and 3 major partners, Mumbai, Mehsana, and Patna model, which kind of, you know, rang bells in the PPM arena at the global level, because the kind of demonstration that it kind of gave on how, the question of how was addressed there. And then we also saw the quantum leap, not just in terms of the quantity of patients getting, you know, access or getting notified to the public sector, but also at the same time, in parallel, improvement in the quality of the care is something that was necessary. So that gave a lot of learnings, and, you know, that led to the expansion of this now, and the Global Fund came in with the JEET project, and now the transitioning to the domestic budget is something which is absolutely necessary if India has to achieve or move towards the target of ending TV by 2025. And each one of you, believe me, each one of you play a very major role in, you know, achieving this at the grassroots level. My urge to you all is that as you learn more, as you expand more, as you kind of, you know, share your experiences more, there will be challenges, you know. If you are facing challenges, it means you are working. You are actually doing good work on the ground. That's why you are facing challenges. So let's kind of, you know, give the knowledge to each other as to if this a particular type of challenge has been faced in a particular state, if that has been solved by somebody in another state, let the other state get the benefit of it. But at the same time, you know, also look at the entire spectrum of the disease. That is something which I would like to, you know, open up now. Now that, you know, each one of you have started championing the early case finding and quality care and adherence and treatment completion for drug-sensitive TB, I would like to now open this challenge across to all of you to start looking at the entire spectrum of the disease, the contact tracing and the family and the protection of the family with TB preventive treatment. And on the other hand, if unfortunately someone does not get completely cured or moves towards drug-resistant TB, how can, you know, patients seeking care in the private sector access to these cares? The preventive treatment part at one end and the drug-resistant TB part at the other end. I will request each one of you to kind of deliberate on these things. Maybe I understand that there are, you know, these clauses in the contracts of the PPSA that, okay, you also have to look at these areas. But we need to also start thinking what kind of weightage can be given in terms of the DLIs that you have in these. So with that, I stop here and wish you all the best. Our team of consultants is with you on the table all across the house, as well as on the ground for any technical support that you need. I hope we together can, you know, work further towards scaling this up as much as we want to achieve the end result of, you know, improving access and care to all the patients seeking care in the private sector. Thank you so much.
Thank you, sir. Now I would request Dr. Nishant Kumar to please say a few words to, you know, pep the audience.
Thank you, Sandhya. DDG sir, my respected members who are sitting on the dais, all the stakeholders. In the interest of time, I'll be brief. but I have to echo what Dr. Rao has said. No other program has, taken all the stakeholders and not only just taking them, as a tick box or something. Actually, we have made mechanisms, we have made procedures, we have made SOPs, be it PPSA, be it engaging with the community, being, institutionalizing the engagement of all the important stakeholders. And we have done wonderful, initiatives on the ground, and who have done it, they are already here. The team is here. I really compliment Dr. Rao, Dr. Bhavin, Dr. Raman. I mean, the way we have, actually followed the patient and followed that approach of following the patient wherever the patients are seeking care, and then trying to, plug the gaps, be it supply chain, be it sample transportation, be it free diagnostics. So, the program has actually covered basic ground. But I think with today's deliberation, today and tomorrow's deliberation, when we learn from each other, we'll definitely take next step forward, how to take it further. That's the expectation which we have from this workshop, and I wish a very, very interactive, sessions and solutions. Because, time is something which we do not have. We are set to, 2022 is just ending, and about, 24, 30 months are left. So whatever we decide, we have to take it on ground as soon as possible. So thank you so much, and this is the right time to have these deliberations and quickly, take them on ground. Thank you.
Thank you, sir. Now I request Professor Venkatraman for his remarks.
For the sake of time, respected my colleagues on the dais, as well as the respected partners from different parts of the country. I'll try to be brief, although there is so much to say, but I am here only to listen to you, because it's been a very keen event that we have been thinking about for the last, I think, about 3-4 months or even more. There are a couple of messages that I just want to leave it with you. When we thought about this process in the last, ever since the UATBC, till now, we all knew that engaging the private sector is not a cakewalk, and it's going to be a lot of thorns along the way. But if you are running a marathon, if you don't sweat and if you don't get trouble, it means that you are not performing. So if you are facing that, as Dr. Parma mentioned, if you are facing the challenges at the field as well as with the bureaucracy or with the departments, it means that there is something that you are working on, and therefore there are certain barriers that you are facing. Number two is that we are all at the cusp of, within quote, history. What Dr. Rao mentioned is something that I want to also reiterate, that no other program within the Ministry of Health is working as closely with the private sector as we are trying to do now. This kind of a consultative, this kind of listening on both the sides is something that doesn't happen in many other programs. And maybe it's happening in Indonesia, Philippines, but not so much within the Indian countries. The third thing that I just want to mention, and I will close there, I think we have miles to go. This is only a kind of initial momentum that we got with your help, with your ideas and your partnership. I can assure that we want to listen to you, and we want to listen to your constructive criticism. We would like to take forward any of your thoughts that can help in strengthening the program and help in making this, this vision of TB elimination in this country as soon as we can, whether it is 25 or it's later. But as I said, that there is no other option but to become partners in hand. And this partnership offers enormous other alternatives, which we will discuss while the proceedings are happening in the next 2 days. So please come forward, give your candid views. Just because some of us from CTD are there, you shouldn't really be reluctant about saying what you are facing. But please make sure that you are giving us constructive criticism so that any gaps in the program we can try to plug in. And that is the purpose of this meeting. I don't think there is any other reason why we are meeting here. It's primarily to strengthen the existing mechanisms if possible. Thank you.
Yeah, thank you very much, sir. Now I would request Dr. Rajendra P. Joshi, DDG sir, to grace the audience with his keynote address. Thank you, sir.
Good morning, all. Respected dignitaries on the dais and off the dais. I'm very happy to be here for this very, very important meeting. Like it has been brought out by previous speakers, private partnership is one of the most important and unique to many great extent in the tuberculosis program. And I'm grateful to all of you for all your contribution. We have had quite a remarkable achievements. But I have got a steep goal. So to achieve it, we have to look back at what we have achieved, what are the best practices which can be replicated in other geographies, and what are the practices where it is not worth investing your effort and time. We may have to explore the new ones. So it is very, very important that we have a midterm review, look at the things which are working, and also share the best practices. And like Professor Venkataraman said, give us constructive criticism with solutions. If something is not working, there are some challenges. What is the solution? It is very easy to grumble. But when we have got workable solutions, then it is worth pursuing them. And on behalf of CTD, I assure you our full support for each one of you so that you can function in a easier, smoother way. One request is to look at tuberculosis in a whole spectrum. Dr. Parmar also brought out this. I want you to look at preventive aspects. If somebody is getting tuberculosis, new infection now, why? If I am breaking into tuberculosis, why? Is it because I have developed diabetes and it is uncontrolled? Or is it because I have developed HIV? Or is it because of something else? So please look at the preventive aspects and of course early diagnosis and treatment adherence, then follow up. As you know, quite a significant number of our patients, they have got a chance of recurrence when you see the past history. So it is worth following them up for at least 2 years and then rehabilitation. And we are going to launch one more program where there will be adoption of the geographies, all the patients in a geography by different stakeholders, where we have put, apart from nutritional support, vocational support also. So rehabilitation becomes important, both during the treatment and even after the treatment. But main thing is to learn from each one of you, because you are the people who are actually working in the field. You are implementing the program. However good my plan looks on the paper, it is the implementation which matters. So we are all very eager to learn from you on how you are working, how you have fared, and what are the best practices which can be replicated, and also what are the challenges which need to be looked at to solve them. So once again, I am thankful to all of you for coming here, and I wish this national conference all the very best. Thank you.
Sorry. Thank you very much, sir. So I would thank all the dignitaries and for your gracious presence and taking out time to be with us. Your valuable insights and remarks have set the right tone for the event. Now I would request you all to please join the audience and take your seats so that we can start with the subsequent presentations. Thank you, everyone. So at the outset, to appraise you all on the status of private sector engagement, challenges and possible solutions, Dr. Raghuram Rao from Central TB Division will make a brief presentation. So I'll request sir to please come over and make a presentation.
Yeah, so a very good morning to everybody. What I'll do is I'll just share in a few slides. Welcome, Christine. In terms of what has been the achievements of the program, and why did we do private sector interventions, what came out of it, and the challenges, because I want the rest of the 2 days to discuss the best practices and operational issues, and the challenges will always be there, because when we are working, like all the dignitaries on the dais said, that there will be challenges when we start working in the field, and it's a good sign, because once you identify a challenge, we will all try to find a solution towards it. So with that, I'll just brief you all in terms of the burden and the effort that is going to take for us to achieve our targets. Our SDG targets is something which the country has preponed from 2030 to 2025 and targeting to achieve. And it's a steep job, as you can see. And business as usual is not going to work in this. And we'll have to do something which is going to make an impact. And like Dr. Malik and DDG sir mentioned, that if we do not cover the preventive aspect, the new cases will keep on coming. The latent infection in the country will keep on breaking down to TB unless we prevent that. So fortunately now there are new drugs, there are shorter regimens, there are new preventive tools that are available in hand, and which should help us reach these targets. Although we did have a small impact because of the COVID challenges, but I'm sure the field has worked, and the mitigation measures that have been adopted by the program has made the systems resilient to handle any future epidemics in the future. So the why part of it, why private sector is important in the context of tuberculosis. One is that many studies have very clearly indicated that 50 to 70% of our population first knock the doors of the private sector before they go anywhere else. And average, they not just once, but 2 or 3 times they visit the private sector before they are finally diagnosed of tuberculosis. Almost 2 months it takes, the current data that suggests, before somebody is finally diagnosed of TB and put on the right treatment, and they spend a lot of money towards it. So our SDGs are targeted towards this, to reduce the incidence by 80%, to reduce the mortality by 90%, and to reduce catastrophic expenditure. So if we do not work with the private sector, we will just not be able to achieve our SDGs. And towards this, a lot of work has happened, from the program side since 2015. Like, the program has seen almost, it's been multiplying year on year, and we have seen 6 times increase in the private sector contribution, and a lot of both carrot and stick approach has been introduced, incentives, enabling environment for the private sector, access of free drugs and diagnostics to the private sector. And still there are challenges towards this, and a lot of NGOs and partners have been roped in to provide this support for reaching out to the private sector. And our the scope on the right side is to look at the landscape, right from medical practitioners to pharmacists to unlicensed providers to licensed physicians. It's huge numbers that we have to reach to. We have still not reached saturation levels in these aspects. So this is the landscape on which we have to work and try to reach us. And we have been like I said, the private sector is a little it's largely unregulated in India, be it the formal providers or the informal providers. Everybody uses their own tools for diagnosis, have their own combination of drugs for putting the patients on treatment, and the challenge of being able to follow up the patient and making sure that the out-of-pocket expenditure is limited. Now these are challenges which the private sector cannot do by itself. It will require the support from the public health system to reach to the patient's house, to do the contact tracings, to do the public health interventions, be it for comorbidity testing or for the incentives that we have under the program to try to reduce out-of-pocket expenditure. So this is the gamut of things that we are looking at in front of us. And the interventions that have happened, the patient provider support agencies, we first started off with 3 projects in Patna, Mehsana and in Mumbai with the BMGF, which BMGF and WHO support, which Malik mentioned. And with that, then the Global Fund project called the JEET project was its joint effort for elimination of tuberculosis through a consortium of partners, which was FIND, which was Clinton, and which was the third one? Clinton, FIND and PATH. The 3 of us together then started scaling up these models with Global Fund support. And we first started off in 48 cities, and then in 19, 20 and 21 through domestic budget we just multiplied that and scaled up, and you can see almost more than half of the country now actually being covered through some form or the other with private sector interventions through the development partners or through the NGO partners in the field. And the result of that, you can see the numbers, and year on year, the blue line is the total notification. We were doing wonderfully well till 2019, and then COVID came in. It did have an impact on the public sector more than on the private sector, although the delta seems to be less because of the absolute number. But you can see that in spite of 2020 was the first wave, which was delta, and then we had the Omicron wave in 2021, which was far severe, and you can see that, the delta in 21 and then Omicron in 22. But you'll see that towards the end also, the graph is only moving up, which means that, in spite of any setbacks, we are now putting in systems where we should be able to reach. And if you look at the last 22, the data, of course, we have analyzed it based on the half year's data, and we are, on track to surpass our previous peaks of 2019 levels. And you'll see that over the years, the interventions that have been put in, be it strengthening our Schedule H1 monitoring, be it putting additional investments by putting domestic or through the PIPs, district PPM coordinators, and the National Strategic Plan 17 to 25 when it was developed, then the access to free drugs and diagnostics for private sector patients, the Gazette notification which mandated notification and also at the same time provides for incentives. The NPY was launched in 2018, the domestic PPSA was scaled up, and now we have even NTSU and STSU at the large states to be able to support the states in getting these contracts done, and the results are there in front of us, where more than 35% of our notification is coming from the private sector, and we seem to be trying to bridge that gap of missing cases. And in terms of the notification, the private sector part, if you see, over the years, it's just multiplying. And with 7.21 lakhs, we estimate our total cases to be somewhere between 24 to 25 lakhs. So it will almost be, closer to 40%. And the drug sales data indicate that almost 50% of our patients are seeking care in the private sector. So we are almost there, probably in finding all the cases that are being treated in the private sector. An example, as we want to analyze and see what has happened in the districts where there is a PPSA versus a district where there is no PPSA. Very clearly we are able to see the difference in terms of the per lakh population notification that is coming from those districts. And you can always argue that the remaining districts need not have a full-fledged PPSA because there's hardly any private sector. But if you see that the districts, 437 districts, where we have 205 of those had a PPSA, and they are almost contributing to half of the population, and we still are seeing significant difference between the districts where a PPSA intervention is there, and we can see the stark difference between the two. In terms of drug sales, like I said, so if you see we just took in one quarter from the current year to see what is the drug sales and where are we vis-a-vis the notification that we are able to catch them. And per lakh notification, although in one quarter, but you'll see the proportion increasing from our private sector gap that we are able to bridge and find those cases that are being treated in the private sector. But still there is a significant number of cases in the private sector which we are missing, and that's the target that we need to take forward. Just a couple of state examples where you can see a very demonstrable impact of a private sector. In the midst of COVID, Bihar was able to contract and get those NGOs on board, and you'll see that they are notifying more number of cases from the private than the public sector, the only state in the country to be able to do so. And the numbers, otherwise, definitely, Bihar truly deserves this appreciation. But having said that, it is still, not fully completed in Bihar, and they are still scaling up their private sector interventions. The remaining districts also are getting an agency on board. But just an example, it's going to be very different when I look at the southern states where a lot of the health seeking behavior of the population is towards public sector and private sector. Bihar is largely private sector driven health seeking behavior of the population, and here we are able to see the impact of the interventions that have been put in by the program. And having said that, everything looks fine, but there are definitely challenges that we have faced, and more so by the implementing agencies in terms of payments, timely payments. That has been the biggest challenge that the NGOs who have taken the contracts and are delivering the results, but if they are not paid in time, it's very difficult to sustain, and that's a known fact. And there are some efforts that we have taken up trying to address this, including dashboards, trying to come up with alerts for the program officers that an invoice is due, invoices come in and the payments are due. These are the multiple dashboards that will be there in Nikshay. It's probably going to be ready in the next quarter, where we'll be launching it as a dashboard in Nikshay also. So this will help track, at least for the STO and the DTO, to see whether there is pendency at their levels. But dashboard is not going to help make the payments. That will happen only when the TSUs and the STOs and the district TB officers all work together to see that there is value in making sure that this intervention succeeds. And if we are not able to process payments for an NGO which is working so hard and giving the results to us, so for example, I had taken the example of Bihar. Now Bihar has a streamlined mechanism. There were initial challenges in the last 2 years where it was first centralized payment, then decentralized, and then again now centralized, and verification challenges. How does a DTO or the STO certify that yes, these numbers have come in, the payments are to be made, and the higher ups at the administration level finally authorizing the expenditure. So a lot of experience, and I'm sure in the presentations through the day also we'll listen to the challenges by the states and the PPSAs who are implementing, and we'll find solutions as we discuss more on this topic. Basically, if we are able to track and make sure that the payments are done and we are able to measure it, and we start using it as a review point in us when we are reviewing the states when they're reviewing the districts, this becomes an important agenda. Automatically, I'm sure we'll find ways to address this. The second challenge that we could identify was the DBT disbursements. Although it's something which is a carrot and stick approach, the stick gets done well by the government, but at the same time we are not able to deliver the incentives that is due for the private practitioners for the patients. So that's something which, although it's a scheme which was introduced in 2018 and scaled up, towards the size of scale up that we have done, it's highly appreciated. But still, when the focus of making sure that the payments which are meant for a purpose is paid on time, only then the desired results will be there, and the both parties, be it the patients or the providers, are interested in working with us. So that's something which we are going to micro levels in terms of state and district and even block levels to look at the pendencies across different levels. There are maker, checker, approver levels, and in terms of getting the bank account seeding in the first place, and then making sure that payments happen on a timely manner, and also ensuring funds are available with the states and districts. So a lot of financial reforms have happened. So there were disruptions in DBT in the current year because of these financial reforms, but going forward, I'm sure the single nodal agency, single nodal account will enable us to make sure that we are able to pay on time and to the beneficiaries on time. Also, we had this challenge where the agencies have been contracted, but we have just thrown them into the sea and let them swim, let them learn to swim. Our efforts in terms of sitting with them, so this exercise today is one of the steps that is being taken to work with the PPSAs, with the implementing agencies, to sit with them, understand their challenges, try to plug those gaps or the leaks, whatever is there. And so we have the technical support units from the WHO for the field consultants, that we have a vast network that has been literally doubled in the last couple of years, from 60 consultants to more than 140 consultants that we have in the field. Plus, in addition to that, we have the technical support units which are a part of our World Bank project, and our mandates the support extended from that side. We are able to have a technical support unit at the national level and in the 9 priority states for the World Bank. But in addition to that, the other high burden states, we are with the USAID support putting in another, taking over for providing TSU support for another 5 states. So by this 9 plus 5, these 13 states literally contribute almost 90% of our burden. So we should be able to provide this handholding support to the field NGOs and the implementing NGOs that is required going forward. And in terms of capacity building, day-to-day monitoring, handholding, trying to resolve all these challenges that we have been speaking. Another big challenge that we could face was the states in actually getting these contracts done. The PIP approval happens, and then states take almost 1 to 2 years, and there are states which are still struggling to get the first contract done. And we have at the same time states like Bihar and Jharkhand, which have been the first ones to get these contracts done. Because they had a technical support unit from the NHM side, and contract people experienced in contracting available in the system. Bihar was among the first ones. Bihar and Jharkhand were the ones where we were able to do that. But Tamil Nadu, Karnataka, Gujarat finally managed to get an NGO on board, the PPSAs on board. But we have challenges in the other states, and then we have newer models of interventions also being like Rajasthan opted for a different model. So there are very different kind of challenges in Rajasthan which needs to be addressed, and there's no interface agency. The government itself is directly reaching out to the private practitioners. So there are HR issues, there are capacity issues, and then there are otherwise it was one payment. Now there are thousands of practitioners for whom the state and district has to make payments and provide these incentives. So multiple challenges, but everybody is trying to do the best, and we are able to learn from those experiences also. For the states which are looking at different modalities, there are differential models. Otherwise, it's not a cast in stone model, PPSA. There are multiple ways of doing PPSA, and there are multiple ways by which insourcing of support or capacities from the private sector or from the civil society NGOs to help achieve the program targets in the public sector and in the private sector that can be done. So all these things, so again, apart from building capacity of the states, a lot of effort is going on in trying to create standardized RFPs, standardized scope of work, and share it with the states to be able to do that easily. We are also working with GEM to try to see if this can be a part of the government e-marketplace, and that will also help the states to do these contracts faster. Then we also had this challenge that if a state does an RFP, there were very limited people who were bidding into those RFPs. So how do you get more players to bid in those proposals that are being sought for by the states? So there again, we are with the support of our NTSU, we have been able to map all the NGOs, irrespective of the sector they are working in, health or non-health. Try to do that, sensitize them, explain them these contracts, explain them the scope of works, and so we have been doing that zone-wise, across the country. So we have been able to do 3 zones, and we are, in the coming months working on the other zones also to try to get more people to actually participate in these, in these RFPs and tenders when they are issued. Also trying to map these on a portal so that the states, once they are doing that, it gets easily circulated to all of these for making sure that everybody knows that an RFP is there and they can participate in that. So broadly, this was something which I wanted to share with you all, the efforts taken by the program to reach out to the private sector and to implement these models. But let's not keep this meeting in the review mode, and let's try to learn from each other during these 2 days and try to see which district or which state or which NGO adopted a particular strategy to overcome a certain challenge in providing quality of care to the patients who are seeking care in the private sector. We also have a follow-up presentation by Prashant from NHSRC, where we'll try to understand in terms of other health programs what has been the PPP interventions that is happening under NHM, which can also be learned from, so that the states can pick up different ways by which they can insource service and try to plug capacities in the public health system by insourcing something which is available in the private sector, and to the larger universe of patients who are seeking care in the private sector, where we can put in some interventions to reach out to them. So with that, I'll stop short here, and thank you all for the patient listening, and hope we have a good 2 days interactive workshop. Thank you.
Thank you, sir, for sharing the status quo and way forward for private sector engagement. Now, I would request our next presenter, Dr. Prashant KS from NHSRC, to make his presentation on public-private partnership experience under NHM. Over to you, sir.
Good morning, everybody. I am making this presentation on behalf of Dr. Himanshu Bhushan, who could not join today's workshop due to another commitment. As Rao sir said, how this presentation will fit into today's context will be to look at NHM scope of work, how PPP has been taken up by the framework for implementation, and what has been our learnings in the 11th and 12th plan period. The purpose of showing this definition is only just to highlight 3 points. Procure, implement, evidence-based. Once opportunity has been given to the states for engaging private partners, procurement was done at the state level. That was an easy thing done, but implementation there were a lot of challenges. And to what extent it was evidence-based was another question to be answered. What was the kind of opportunity the National Health Mission offered in 2005 at the beginning of the 11th plan? There was a recognition that private sector largely was unregulated. There was a lack of transparency and there was a lack of community involvement. Even before the NRHM was launched, there was already public-private partnerships under the RCH program going on. There were already learnings available. So based on that learnings, a lot of priority concerns were given to the state. So when they tried to engage the private sector. The engagements were supposed to meet public health goals on agreed cost and norms. It is expected that this will improve service guarantee and there will be larger involvement of Panchayat Raj institutions. Only very few states have devolution of powers, have rules defined by which the PRIs were able to govern and have engagement with the hospitals. But even in those states, our experience have been mixed. Partnerships have to be ethical partnerships, because at many instances, the kind of engagement that's happened have vested interest involved, and then the outputs were compromised. The ultimate objective was to improve utilization and reach, and to what extent we have been able to succeed in it. So once 11th plan and the NRHM was in implementation, there was a task force was appointed to look at the PPPs. So they have set out some mandates, some objectives, which said the PPPs will, on a broader scale, will try to meet these objectives. Skills are available within public sector as well as private sector. So they will be able to exchange those skills and expertise and resources, and efficiency will be improved. Improved coverage and equity, more accessibility, availability, etc. will be the outcome. The health system will be strengthened. A widened range of services will be available to the citizens. And there will be clarity and there will be clearly defined sharing of risks. And there is community ownership. A lot of kind of PPP arrangements possible. And then from the kind of range we have picked up some. And among these, the models that we have looked at in the NHM across various programs largely were in contracting in mode, with a combination of models, inputs coming from the other sector. I will give you one example. If you try to have laundry services outsourced, what all things can happen? Laundry is linked with every department of the hospital. It essentially should have linkage with the CSSD. It is possible that the laundry service do not have an SOP in place, even before PPP, after PPP. So what will happen? The way that particular activity was going on in the hospital, the same mechanism is expected from the private sector. Both do not have standards in place. There is a monitoring mechanism. Second instance, you know what is supposed to be done. You have SOP in place. But once outsourced, you have taken that liberty that now it is the responsibility of the agency to deliver. So you will stop monitoring those services. You will only look at what has been given to the agency and what will come from the agency, only input and output. As a result of which, what happens? The ultimate beneficiary within the hospital, the various departments, the interlinkages, and the citizens do not benefit from the program. We also try to look at what all areas TB program could benefit from the PPPs. So now, under the 15th Finance Commission, we have a lot of areas covered, one of which being the diagnostics. Medicines and treatment under the free diagnostics and free medicine facility. Screening, making human resources available from outside. community mobilization, monitoring and evaluation, specimen management, and public health actions. So we are yet to see the kind of deliberations that we have going to have in the next 1.5 days, but possibly the agencies who have come here today may be able to look at expanding the scope to other areas also, which we are not aware. But then this is a kind of thing that we look at, and these are possible areas that you may be able to engage further. What is our learning from this PPP experience in NHM? The agency engaged and the government, they are not having the same kind of power in that relationship. In that kind of a situation, what happens is the person who is in a better power position will be able to gain maximum from that. So they will not be able to share the risk. They will not be able to put much into that contract, but then we'll have certain MOUs shared by the GOI put into the contract mechanism without adding those clauses which will help you to monitor the progress. Why those clauses are not there? If those clauses are there, it will become transparent. A third policy also will be able to monitor it, and what you will see that undercuttings and vested interests will not be able to work. So balancing of power is an essential mechanism that we have seen to PPPs to work, including any disease control program, including TB. Objectives have to be shared, risks have to be shared, investments and participative decision making. Decision making, we have seen, is never participatory. Decisions are made ab initio, and then an agency is involved. So the agency do not have much say in that. So agencies are kept on board and that they are expected to deliver. We realized that from the beginning, the regulations were not in place, were hardly in place. So Clinical Establishment Act, Public Health Act is specifically mentioned in the framework of implementation and also in the task force recommendation. Still now only 11 states have these regulatory systems in place. 6 states for public health and 11 states for Clinical Establishment Act. Standard setting and accreditation. We have IPHS revised now, NQS already in place. So all these mechanisms are supposed to ensure either mandatorily or voluntarily standards so that you have inputs available for the agency as well as for the government sector so that the clauses can be appropriately put and deliverables achieved. Efficiency parameters relevant to the type of partnership. For every kind of partnership, so today's and probably tomorrow's engagement is largely on TB, but when we look at NHM, there's a wide range of activities in which partnerships are engaged. So the parameters defined are not very specific. So initially at the GOI stage, you will have some indicators identified. Every guideline will have some indicators identified. But when you engage an agency to do it, you may have to, for monitoring purpose, have to be specifically looking at the parameters so that outputs are monitored. Costing of services. For most of the services, we don't have this exercise and this information in place. What is the cost of running a health facility, of running a service, engaging it in the community, outreach within hospital? We don't have this information. In the absence of this information, how will you know for obtaining a service from a person what is amount that we are supposed to give? And against the amount that we are giving, what is expectation of the output? Decentralization versus capacity at local levels. Essentially, PPP engagements have to be decentralized. But the problem is, at decentralized levels, capacity is less. So monitoring from the lower levels, engagement from the lower levels to directly deal with the partner is very limited. And then we have a lot of setbacks. Transparency and accountability is something that is cutting across all these areas, and this is an area that is found to be compromising at all levels. Couple of activities which we identified will be critical for a successful PPP model. We need to have robust and transparent policies on PPPs. Selection of services on need-based assessment. So if there is an opportunity given by National Health Mission, particularly in this context and this presentation which is specific to NHM, the agencies should prioritize areas where you require an outside agency to work that. If you yourself have capacity and you are better off to present and do that activity, you would not be engaging an outside partner. If you are engaging an outside partner, that is to share resources and skills. So that need-based assessment and engagement of services and agencies is very critical. For most of the services, EOI, tender, MOU, drafts have been shared by the Government of India. So for those areas, we have some kind of parameters defined at larger level, uniformity across states, but then for specific locally contextual areas, you may have to customize at local levels. Transparent performance and quality indicators and its linkages to hassle-free and timely payments. Rao sir was just mentioning that the PPSA arrangements, this has been an issue and payments have been a problem. Yes. January and February, March, we have 24/7 meetings to ensure that ROPs will be released by March. It doesn't happen. For last so many years, it doesn't happen. And for some of the states, it's still pending. It's July, and now it's August. It's still pending. And now we will say that the state will make payments. I mean, for most of the continuing activities, yes. For the new activities, it's really a challenge. Verification and validation mechanism at district and state levels, yes. Because it is decentralized, this mechanism have to be available at decentralized levels, and they should be able to do it. The role of hospital development committees, JAS and RKS and all that. The primary mandate of the community within the hospital is to ensure that the hospital management committees is to ensure that it gives an overarching direction and performance for action for all activities relating to quality, improve quality. So all programs are running. You are only providing health system input in a hospital. The program runs across the country, the major areas, priorities for the program. So what is your role at the local level is to ensure that at local level, your quality is ensured for across the programs. This function is largely compromised because the function of community within hospital is not happening. It is again the hospital and the bureaucracy and the technical understanding that is prevailing. And Panchayati Raj we already talked about. Because of the 15th Finance Commission, the lot of areas in which PRIs are now getting lot of leverage because funds have gone to them, technical capacity is with the hospital, they both have to sit across table so that the action plan be devised. This is my last slide. For the rest of the day, next 1.5 days, we will be listening to you. So this is an all the best for all the agencies who have been working for it. And this is my thank you slide. Thank you very much.
Thank you, sir, for your insightful presentation. Ladies and gentlemen, as we'll venture through the event, we will not only be learning and applauding the PPSA presentations, we'll be sharing their innovations, best practices. We will also be acknowledging and rewarding some of the exemplary innovations amongst these agencies with the support of our eminent jury members. There are awards for best innovations across 7 categories. Innovation, the categories are innovation for private sector engagement, innovation for improving diagnostic access, innovation for free drug delivery management, innovation for health and system strengthening, innovation for treatment adherence, out-of-box model of service delivery, and any other innovation as deemed fit by jury members. So based on the presentations from various PPSA agencies, our jury members will assess the innovations around criteria like replicability of the model, out-of-the-box solution, innovative use of technology, leveraging resources from existing ecosystem, quality output in terms of provider engagement, impact on notification, and other key performance indicator. So I would like to take this opportunity to introduce and welcome our stellar jury members who are domain experts and carries years of public health and TB related experience. So our jury members are Professor Venkat Raman, who is Professor HRD and Health System, Faculty of Management Studies. Mr. Guy Stallworthy, Global Lead for Private Provider Engagement, Global Health, BMGF, will be joining us virtually. Dr. Ruben Swamikan, who is the Chief Infectious Disease Division, Chief of Infectious Disease Division, USAID, will be joining virtually. Dr. Sameer Kumta, Senior Program Officer, BMGF, who is present with us physically. Dr. Santosh Moses, Public Health Division, from Public Health Division, IQVIA. And Ms. Sapna Surendran, Consultant, World Bank. So Ms. Sapna is also joining us virtually. So may I request the jury members who have joined us physically, so please come on in front so that we can greet you with, so that all can get familiar and we can greet you with the green welcome. So Dr. Sameer Kumta sir and Professor Venkat, and is Dr. Moses, has Dr. Moses come? So anyways, I'll request my colleague Arun Singh Rana to please, sir, please come in front. Dr. Moses, Dr. Santosh Moses, please join us in front. Dr. Santosh Moses, who is from IQVIA. Thank you, jury members. So I would now request you all that after the tea break, you can take the seat over there.
Hopefully, all of you will get some reward in the process. Wishes, good luck.
Thank you, sir. So with the end of this inaugural and few key presentations, we'll now break for tea for 15 minutes and request you all to please, join back quickly so that we can start with the formal presentations. Thank you. So I request you all to please come back by 11:15. You can grab quick coffee or tea and join inside the room also.
Recording stopped.
2020 में मुझे पता चला कि गाँव में बैठे हुए बताया गया तो मैं इलाज के लिए तैयार हो गई। एक टीबी रोगी को बहुत संघर्ष करना पड़ता है। मैं बहुत भाग्यशाली हूँ कि मेरे साथ किसी भी तरीके का भेदभाव नहीं हुआ।
मैं आशा कार्यकर्ता भी हूँ और एक टीबी चैंपियन भी हूँ। मैं अपने फील्ड में जाकर टीबी के बारे में लोगों को बताती हूँ, प्रचार प्रसार करती हूँ और महिलाओं से मिलती हूँ। और क्योंकि मैं एक महिला हूँ, मैं समझ सकती हूँ कि ये एक संक्रामक बीमारी है। महिलाएं इस विषय में बहुत जो है झिझक उनको आती है बताने में। सरकार द्वारा जो हमें सामग्री दी जाती है, जैसे पंपलेट है और पोस्टर है, बैनर हैं आदि, बहुत सी चीज़ें मिलकर उनको दिखाते हैं, बताते हैं कि देखिए ये सब चीज़ ऐसे ठीक हो जाएगी बीमारी। उनको लेके जांच के लिए बताती हूँ, मुफ्त इलाज के लिए बताती हूँ, जांचें भी सब फ्री होती हैं। ये सब अपने क्षेत्र में मैं जाके लोगों को बताती हूँ।
महिलाएं कई स्तरों पर प्रभावित होती हैं, विशेषकर ग्रामीण इलाकों में भेदभाव का उन्हें ज़्यादा सामना करना पड़ता है। मेरे गांव में सन 2020-21 में टीबी से संबंधित 4-5 मामले सामने आए। एक सामुदायिक जनप्रतिनिधि होने के नाते मैंने जिम्मेदारी सुनिश्चित की कि टीबी के खिलाफ महिलाओं की इस जंग में हर संभव जानकारी उपलब्ध कराई जा सके। इसलिए मैं स्वास्थ्य विभाग के साथ मिलकर यह कार्य कर रही हूँ, जिससे महिलाओं को सही उपचार नेटवर्क, प्रोटोकॉल और उपलब्ध सेवाओं के बारे में पता चल सके।
सबसे पहले तो उनको घर वाले अभी भी ऐसा है कि बेटियों को प्रमोट नहीं करते हैं कि वो जांच कराएं, कहीं टीबी ना निकल आए। और कई बार ये देखा जाता है कि लड़कियां जिनके जो अभी शादी नहीं हुई है, उनकी शादी होने वाली है, तो वो खासतौर से बहुत डर जाते हैं कहीं शादी ना टूट जाए। आशा वर्कर्स को खासतौर से ध्यान पे बुलाया जाता है, को समझाया जाता है कि वो अपनी महिला समाज में खांसी को और बुखार को चिन्हित करें और उनको स्क्रीनिंग के लिए लाएं।
मैं तभी अपने बोर्ड एग्जाम्स दे रही थी और मुझे कॉफ हुआ था। आफ्टर अ पीरियड ऑफ टाइम एक्सरे करवाया और तब पता चला कि टीबी है। डॉक्टर्स ने कहा कि आई हैव अदर फॉर्म ऑफ टीबी, कि 1% चांस है सर्वाइवल के। सो आई जस्ट टोल्ड माई पेरेंट्स डोंट वरी, आई विल बी राइट बैक विद यू। टीबी हैज टॉट मी अ लॉट, इट हैज मेड मी ब्रेव।
खांसी 1, खांसी 2, खांसी 3, बच गई भैया देश की बीन। टीबी के कारण को जानो, खांसी हो तो मुंह ढककर खांसो। टीबी रोग हवा में फैले, रखो अपना औरों का ध्यान। घर में धूप रोशनी हवा मिले तो कीटाणु सब मर जाएंगे, रोग मुक्त हम हो जाएंगे। खांसी खो खांसी, बलगम में है भरे कीटाणु, रख कागज में इसे जला दो या डाल राख में इसे दबा दो, रहे न टीबी नाम मिटा दो। खांसी खो खांसी, टीबी मुक्त भारत बनाएं, खुद भी बचें देश भी बचाएं।
टीबी हारेगा देश जीतेगा।
वो देख पवन आ गया। पवन वहाँ क्यों बैठा है? तुझे उसे टीबी है। और भाई लास्ट बेंच को मजा अकेले अकेले।
पता है ना मुझे टीबी है।
चल चल, तुझे पता है ना इलाज का असर शुरू होने के बाद टीबी के इन्फेक्शन का डर नहीं रहता। टिफिन में क्या है? टीबी की दवाई के साथ खाना भी अच्छे से लेना है, समझा?
अपनों का जोड़ है टीबी का तोड़, तो फिर भेदभाव क्यों? टीबी के इलाज में अपनों का साथ दें।
बचपन से ही ना मुझे हारने का शौक था। कभी अपनी बहन से, ताकि उसकी वो खरगोश वाली हंसी देख सकूं। कभी अपने पापा से, ताकि उनका बचपन फिर से लौट आए। और अपनी पत्नी से तो मानो रोज का ही है। अपनों से हार जाने में ना एक अलग ही जीत महसूस होती है, लेकिन उन्हीं अपनों के लिए जीतना और भी बड़ी बात है। मुझे HIV है और मैं HIV से लड़ूंगा।
HIV संक्रमित मरीजों को टीबी की जांच जरूर करवानी चाहिए, ताकि HIV की लड़ाई में टीबी आपकी हार का कारण न बने।
आपके बलगम की जांच और एक्सरे रिपोर्ट के अनुसार आपको टीबी है। टीबी का पूरा इलाज है। बस 6 से 8 महीने का कोर्स बिना रुके पूरा कीजिए। 2 महीने के सघन इलाज के बाद आप अपने बलगम की जांच दोबारा कराना ना भूलें। मैं आपके केस के बारे में RNTCP को सूचित कर देता हूं। याद रखिए, टीबी के मरीज के उपचार की सूचना RNTCP को देना अति आवश्यक है। ये टीबी की लड़ाई का एक जरूरी हिस्सा है। एक छोटा सा प्रयास, लेकिन बहुत बड़ा कदम भारत को टीबी मुक्त बनाने के लिए। क्या हम इतना भी सहयोग नहीं कर सकते? नोटिफाई जरूर करें।
हेलो सर। सर, वो असिस्टेंट मैनेजर वाला पोस्ट आप मुझे दे दीजिए ना सर।
असिस्टेंट मैनेजर? अक्रम तो ऑलरेडी है विवेक।
अरे कैसी बातें कर रहे हैं सर। सर, अक्रम का तो टीबी का इलाज चल रहा है ना, तो फिर आप उसे वापस काम पे थोड़ी रखोगे।
जब टीबी का इलाज चल रहा है तो इन्फेक्शन का डर कैसा? अरे अक्रम, कैसे तबीयत है? ठीक है सर। लिसन, डोंट वरी। हाँ, तुम जब ठीक हो जाओ तब आराम से वापस ज्वाइन कर लो। तुम खाना ठीक से खा रहे हो ना? जी, सुना है जरूरी है। सिट डाउन। ये लो, अंडा करी लाया।
अंडा करी? सर, ये तो मेरा भी फेवरेट है, दीजिए ना। अरे लो ना।
अपनों का जोड़ है टीबी का तोड़। टीबी के इलाज में अपनों का साथ दे।
नमस्ते, मेरा नाम सिया है। मैं 12 साल की हूँ और मैं स्कूल में पढ़ती हूँ। मेरे को पढ़ना पसंद है और अपने फ्रेंड्स के साथ खेलना और बातें करना पसंद है। मैं कहानियाँ पढ़ती हूँ, घर पर गेम्स खेलती हूँ। सबसे ज्यादा तो मुझे भूतों की कहानी सुनना पसंद है। बहुत दिन पहले छुट्टी में मैं अपने गांव गई थी। गांव में मैं अपने दादा और अपनी दादी के साथ रोज घूमने जाती थी और फिर वहां जाकर मैं बहुत बीमार हो गई। मेरे गले पर एक बड़ा गोला जैसा बन गया था। अप्पा और अम्मा काफी डर गए थे। फिर वो मुझे गांव में डॉक्टर अंकल के पास ले गए। पता है, डॉक्टर ने टेस्ट करने के बाद कहा कि मेरे को तो ट्यूबरकुलोसिस या टीबी हो गई है। अब पूछो कि टीबी क्या होती है? ये बीमारी बैक्टीरिया से होती है। बैक्टीरिया पता है ना? ये बहुत छोटे छोटे कीटाणु जैसे होते हैं। ये नजर भी नहीं आते। वैसे तो ये हमारे फेफड़ों पर हमला करती है, लेकिन इसके कारण हमारे शरीर के दूसरे हिस्से में भी इन्फेक्शन हो सकता है। पता है, मुझे तो टीबी एक भूत जैसी लगती थी, बहुत डराती थी। फिर ना मुझे डॉक्टर अंकल ने समझाया कि टीबी तो किसी को भी हो सकती है, लेकिन सबसे अच्छी बात तो ये है कि इसका पूरा इलाज हो सकता है। तब मैंने फैसला किया कि मुझे इस बीमारी से लड़ना ही होगा। इसके बाद 2 साल तक मेरा इलाज चला, क्योंकि ये वाली टीबी ना कुछ अलग तरह की थी। इतने दिन तक इलाज चलने के बाद भी मैंने तो सोच रखा था कि टीबी से लड़ती रहूंगी। इसकी दवा मुझे इतनी कड़वी लगती थी, फिर भी मुझे जूस के साथ ये दवा लेनी पड़ती थी। कभी कभी तो मुझे उल्टी भी होती थी, लेकिन फिर भी डॉक्टर अंकल कहते थे कि अगर मुझे ठीक होना है तो दवा लेनी ही पड़ेगी। मैं रोज अपनी टैबलेट खाती थी और बहुत सारा अच्छा खाना भी खाती थी। मैं रोती भी थी, लेकिन हमेशा नहीं, सिर्फ कभी कभी, क्योंकि मैं बहादुर और स्ट्रांग हूँ ना। इसके बाद फिर कुछ ही दिनों में मैंने टीवी को हरा दिया। मैंने देखा कि ये भूत तो खुद ही डर कर भाग गया। मुझे बड़ा मजा आया। याद रखें, टीबी किसी को भी हो सकती है, लेकिन अगर हम अपना ख्याल रखें तो इसके बैक्टीरिया को फैलने से रोक सकते हैं। आप सब लोग टीबी के लक्षण ध्यान से सुने और याद भी रखें। आपको बहुत सारी खांसी होगी जो 2 हफ्तों के बाद भी ठीक नहीं होती। सीने में दर्द होगा, खांसी या बलगम में खून निकलेगा। इसके अलावा अगर खूब ठंड लगे, रात को पसीना आए, भूख ना लगे या बुखार आए और कमजोरी जैसे लगने लगे, तो समझ जाना कि कुछ तो गड़बड़ है और तुरंत डॉक्टर अंकल के पास जाना। याद रखें कि आप भी टीबी को रोक सकते हैं। हमेशा मुंह ढककर खांसें और यदि आपको टीबी के लक्षण दिखाई दें तो तुरंत ही टीबी की जांच करवाएं। टीबी की जांच एवं इलाज सरकारी अस्पतालों और कुछ निजी अस्पतालों में मुफ्त में करी जाती है। टीबी का इलाज पूरा करना जरूरी है। और हाँ, एक बात और, किसी भी टीबी मरीज के साथ भेदभाव कभी नहीं करना, क्योंकि उन्हें भी तो प्यार और देखभाल की जरूरत होती है। टीबी का इलाज हो सकता है। आप इस बीमारी को हरा सकते हैं, जैसे मैंने हरा दिया। अच्छा, चलती हूँ, होमवर्क का टाइम हो गया। बाय।
आपने अपनी टीबी की दवाई तो ली ना?
ले ली है मैंने। एक मिनट में।
क्या हुआ? ठीक। बेटा, तूने अपनी जांच करवाई?
हाँ माँ, टीबी निकली, लेकिन डॉट्स का इलाज शुरू कर दिया है।
जिंदगी के हर कदम पे आप डबल सावधानी लेते हैं, तो टीबी के इलाज में भी ऐसा जरूर कीजिए।
टीबी संक्रमित मरीजों को अपनी HIV की जांच जरूर करवानी चाहिए, ताकि आपके टीबी के इलाज में कोई रुकावट ना आए।
आज आखिरकार एमएलए साहब से मुलाकात करके ट्यूबरकुलोसिस या टीबी के बारे में बात हो रही है।
और हमारे गांव के बच्चों से भी मिलना हो गया
और पंचायत के मुखिया से भी।
लेकिन हम इनसे मिल क्यों रहे हैं? हम टीबी सर्वाइवर्स हैं जो अब टीबी चैंपियंस के रूप में कार्य कर रहे हैं।
अब टीबी चैंपियंस के रूप में हम अपने गांव शक्ति नगर के लोगों से मिलकर इस बीमारी को लेकर जागरूकता बढ़ाने आए हैं और एक टीबी मुक्त समुदाय की दिशा में बढ़ने आए हैं। मैं स्वाति हूँ।
मैं हूँ आसिफ।
हम शक्ति नगर के टीबी चैंपियंस हैं।
हम यहीं पले बड़े हैं। हम में से ज्यादातर किसान हैं जिनकी रोजी रोटी इन्हीं खेतों पर निर्भर है और हम काफी सादा जीवन जीते हैं।
हमें अभी गांव में सबके साथ एक बैठक बुलाकर टीबी की जानकारी देनी है।
टीबी या क्षय रोग एक ऐसी बीमारी है जिसका पूरा इलाज संभव है, पर क्या आपको पता है टीबी से हर साल लगभग 25 लाख से अधिक लोग प्रभावित होते हैं। आखिर क्यों?
हमें जब ये बीमारी हुई तो हम बहुत परेशान और घबराए हुए थे। हमें कुछ समझ ही नहीं आ रहा था। हम एक से दूसरे डॉक्टर के पास जाते रहे ये समझने के लिए कि क्यों हम ठीक नहीं हो पा रहे, और उस दौरान इलाज के खर्च बढ़ते ही जा रहे थे।
जब हमें सरकारी अस्पताल जाने की सलाह मिली तब हमें पता चला कि टीबी का इलाज सरकारी अस्पतालों और गैर सरकारी स्वास्थ्य केंद्रों में मुफ्त उपलब्ध है।
टीबी के कारण हमारे परिवार और दोस्त हमसे कैसा बर्ताव करेंगे ये सोचकर भी हम बहुत घबराए हुए थे।
टीबी की बीमारी ने हमें शारीरिक, आर्थिक, सामाजिक और भावनात्मक सब रूपों से बहुत बुरी तरह प्रभावित किया।
इन सब के बावजूद हमें बस ठीक होना था और हम उसी की ओर बढ़ते रहे।
हम नियमित रूप से अपनी दवाइयां लेते रहे और आखिरकार बिल्कुल ठीक हो गए। हमने अपने सामान्य जीवन में लौटने की कोशिश भी की,
पर तभी हमें पता चला कि टीबी के बारे में कई गलतफहमियां हैं और इस बीमारी के फैलने से संबंधित भी कई भ्रांतियां हैं। टीबी को आज भी लोग कलंक से जोड़ते हैं और इसके बारे में बात नहीं करना चाहते।
हम नहीं चाहते थे कि हमारी तरह दूसरे टीबी से ग्रसित इन कठिनाइयों का सामना करें। हमको इसके बारे में कुछ करना था।
जिनको जरूरत है उनकी मदद करनी थी और समुदाय को जागरूक करना था, लेकिन हमें पता नहीं था कि शुरुआत कहां से की जाए।
तब हम पहली बार एक ट्रेनिंग वर्कशॉप में अपने जैसे दूसरे टीबी सर्वाइवर्स से मिले।
यह अनुभव हम सबके लिए काफी भावनात्मक और शिक्षाप्रद रहा।
हमने इस ट्रेनिंग में सीखा कि टीबी किसी को भी हो सकता है।
टीबी हवा से फैलता है और जब कोई व्यक्ति, चाहे वो समाज के किसी भी स्तर से हो, उन कीटाणुओं के संपर्क में आता है तो वो बीमार पड़ सकता है।
इसके कुछ मुख्य लक्षण हैं। 2 हफ्तों से ज्यादा खांसी, बुखार, वजन का गिरना, रात को पसीना आना, भूख न लगना और छाती में दर्द।
जानकारियों से लैस हो हम टीबी सर्वाइवर से टीबी चैंपियंस बन गए।
हमने ट्रेनिंग में सीखा कि कई लोग नहीं जानते कि टीबी का मुफ्त इलाज उपलब्ध है।
इसलिए हमने ठान लिया कि हम लोगों को यह जानकारी देंगे ताकि उन्हें खुद के पैसे खर्च न करने पड़े।
ट्रेनिंग में हमने ये भी सीखा कि हम अपनी कहानियों के जरिए टीबी से जुड़ी भ्रांतियों को कैसे तोड़ सकते हैं
और कैसे स्थानीय स्तर पर टीबी को लेके मुद्दे उठा सकते हैं।
और तब हमने तय किया कि सबके साथ बैठक बुलाई जाए।
टीबी का इलाज संभव है। जब भी किसी को टीबी के लक्षण दिखे तो हमें जल्द से जल्द उनकी जांच करने में मदद करनी चाहिए। सरकारी अस्पतालों में जांच और इलाज की अच्छी सुविधाएं मुफ्त उपलब्ध हैं। महत्वपूर्ण बात यह है कि इलाज के समय बिना रुके नियमित रूप से अपनी दवाइयाँ बताए गए मात्रा में लेते रहें।
याद रखें, जब कभी आपको ये लक्षण नजर आए, 2 हफ्तों से ज्यादा खांसी, बुखार, घटता वजन, रात को पसीना आना, भूख न लगना और छाती में दर्द, तब अपने डॉक्टर से संपर्क करें। और इस तरह टीबी मुक्त शक्ति नगर का प्रयास शुरू हुआ। हमने न सिर्फ लोगों तक सही जानकारी पहुंचाई,
बल्कि हमने ये भी सुनिश्चित किया कि जिन्हें भी टीबी के लक्षण थे वे मुफ्त और अच्छी टीबी सेवाओं तक पहुँचे। आसिफ और मैं और हम जैसे कई लोगों ने साथ मिलकर देश के अलग अलग हिस्सों में टीबी सर्वाइवर्स और चैंपियंस के लिए नेटवर्क बनाया है। यदि हमें इस टीबी मुक्त भारत के सपने को साकार करना है तो हमें और भी कई टीबी सर्वाइवर्स की जरूरत है जो हमारी तरह टीबी चैंपियंस बनकर कार्य करें। हम टीबी से ग्रसित व्यक्तियों के जीवन में किस प्रकार परिवर्तन ला रहे हैं, ये जानने के लिए इस वीडियो का अगला भाग देखें।
क्या आप टीबी सर्वाइवर हैं? टीबी चैंपियंस बने और इस बीमारी से लड़ने में हमारी मदद करें।
चावल है क्या?
आज फिर से अकेले खेल रहे हो? अरे पिंटू, तुझे तो पता ही नहीं, जब तक मैं यहाँ हूँ और कोई नहीं आने वाला। आप पता है आपको टीबी है, पर आपका तो टीबी का इलाज चल रहा है ना, फिर क्यों?
अरे अतुल
दीदी,
मोहल्ले का कैरम चैंपियन अकेले? अरे मैं तो यहाँ इसे कैरम में हराने आई हूँ। अपने कॉलेज में मैं भी कैरम चैंपियन थी। अब पिंटू वैसे बड़ा मोहल्ले का रेडियो बनता फिरता है। तूने लोगों को नहीं बताया एक बार इलाज का असर शुरू होने पे टीबी के इन्फेक्शन का डर नहीं रहता?
अपनों का जोड़ है टीबी का तोड़। टीबी के इलाज में अपनों का साथ दे।
अब नहीं तो कब, अब नहीं तो कब टीबी की लड़ाई में साथ दे। ना तू कर अपनों को अलग, भेदभाव की बीमारी कब तक रहेगी तुम्हारी। दे प्यार भी, दवाई भी, चल साथ बैठ के चाय भी। इलाज का असर शुरू हुआ है तो इन्फेक्शन का डर कहाँ।
Recording in progress.
Sameer, please take your chair on the jury table. Shibu, please join the jury members on the table. Okay, just for the benefit of rest, Guy Stallworthy, another jury member of ours, is joining virtually, and so is Sapna from World Bank. They are joined virtually. Similarly, Ruben Swamikan from USAID is also joined virtually, and he is giving us updates on his feedbacks on a regular basis. So that's the eminent jury which we have. Apart from that, I think you already have been introduced.
Yeah, Dr. शिबू का बोल दे, ऐड ऑन करना है। डॉक्टर शिबू का बोल दे, अच्छा नहीं लगता ना, ऐसे ही बोल ना कि मैं कर रही हूँ। So welcome back everyone. So after the tea break we'll now commence the formal PPSA experience sharing sessions. So let me just brief you all about these sessions. There will be state-wise presentations wherein the PPSA agencies and the organizations which are operational in the state will showcase their implementation models, best practices and learnings. all these presentations will be given 30 minutes each, 20 minutes for the presentation and 10 minutes for the discussion and question and answer. There will also be presentations on innovations for which some of the speakers have been invited to, highlight innovative strategies under PPSA which are already being successfully implemented on field. So each session we have moderators who are experts from TB domain who will moderate the flow of presentation, will facilitate discussions and question answer rounds with the audience. So without delaying any further, let us proceed with our first session, and the moderator for our first session is Dr. Amar Shah, who is the Project Management Specialist, Tuberculosis Care and Control, USAID. So I'll invite Dr. Shah to please take over for the session 1. And under session 1, we have first presentation from Dr. Shweta, who is from Doctors for You and will be sharing PPSA implementation experience from the state of Bihar. So I'll request Dr. Shweta to please make your presentation.
Thank you, Sandhya. Good morning, all respected people around here and the jury members. First of all, I'm really thankful to Dr. Raghuram Rao, who appreciated Bihar's model and saying that Bihar is doing exceptionally well. I think itself it's one of our achievement before even I go further. So, coming on to the presentation, Doctors for You, we are a pan-India humanitarian organization. We have been working since 2007 in nearly 25 states. We have expanded to 25 states, 3 union territories, and our key thematic areas usually involve the communicable disease, specifically TB, which is the core area, then non-communicable disease, working with diabetes, HIV and cancer care programs, then maternal child health care programs where we work for 1000 days model and other maternal child health care program. Health system strengthening, we are into the infrastructure building and strengthening for the human resource support in various areas. Then environment and wash areas where we support the farmers in Punjab and Haryana for the biomass burning, and disaster management. We even started as an organization for the disaster management, working for floods and other kind of disaster which happen time and again in the country. Our experience working with NTEP in the Bihar as a PPSA agency, we started in June 2020, and also we are working for capacity building of the public sector staff, where we are supporting the various medical colleges for giving them the training of PMDT and the newer initiatives by the government. And we are also, time and again we also provide infrastructure support in terms of ECG donation, training for ECG, particularly for the drug-resistant TB patients, which is required for the pre-treatment evaluation. Then CBNAT cartridges, whenever, at times there were shortages, we tried to pitch in that. And then we provided with certain things like refrigerator, because we thought, we found out that there were issues with the sputum. Sputum was not up to the mark because there were delays in transportation. Then it required the cold chain mechanism. For the same, we did that. Regarding the Bihar, as stated by Niti Aayog, multidimensional poverty index 2021 is one of the most poorest state in India. It has nearly 100 million population by census. It lacks the quality public healthcare system, specifically in rural areas, and 90% of the OPD care in rural areas is given through the private and the informal providers. DFY, we as an agency started, as I mentioned, June 2020 in 6 districts, which is Begusarai, Siwan, Samastipur, West Champaran, Gopalganj and Vaishali, and we later expanded to 5 other districts in March 2022, which is East Champaran, Darbhanga, Madhubani, Muzaffarpur and Sitamarhi. In total, we have been covering nearly 4.1 million population in these 11 districts. Our scope of work basically involves, first of all, mapping and engaging the private providers. Then once we map them, we engage them. Once they become the active providers, we get the notification, we notify the patients, provide them with the free diagnostics in terms of HIV and diabetes testing, link them through the services like Nikshay Poshan Yojana, and ensure the treatment adherence through our call center and the home visits, and contact tracing to reduce the TB burden. And definitely it has to be supported by a clear documentation, validation, and the monitoring team, which I am a part of. And we have been working with the State Health Society Bihar for the same. Now looking at the time trends for the private sector engagement and the notification. If we look at the graph which is given here, we see that the year-wise there has been an increase in the private provider engagement. If you look at the green portions, like engaged were the mapped were the one which were nearly 1,000 and which increased up to 1,600 in past 2 years since we started working, and also the active providers has increased from 210 to 343 within 2 years. So the idea is the active provider is somebody who is giving at least one notification even in a year will be counted as an active provider. We are getting good notification because of our continuous follow-up with the doctors, engagement, and the, so that they become the active provider, because a lot of resistance comes during that time. Then if we look at the year-wise number of the notification for different sectors, I think Dr. Raghuram has already mentioned that Bihar is actually one of the state which has shown very good performance in both the total overall performance in notification and whether it's public or private. Definitely private has now overshooted the public ones, and we are able to now notify nearly 33,000 patients within a year. Now, how do we do the private provider engagement? So the private provider engagement is done first of all with the mapping. The PPSA program managers and the supervisor, they identify the medical hubs in the PPSA geographies through their field visits. We talk to the Indian Medical Association, we get the list from there. We talk to the districts, DTCs, get the list from there for each and every clinic. Try to visit the clinic, particularly tapping onto the chest physicians, explain them about the project and NTEP benefits for the TB patients and the providers as well. We provide the brochures, then the NTP IC materials to the doctors. Many of the providers during our visits, they deny. They state that they do not have TB patients, or they directly refer the TB patients to the government facilities. So, these are the points where the pilferage can happen. But, we continuous follow up, we try to engage them. And once the PPSA program is introduced, we try to create a HFID, and then getting the OTP, bank details, all those things are done, and the provider is being engaged into the program. But definitely that is not the time when he is the active provider. The doctor only becomes the active provider once the doctor or the private provider starts giving the notification. And continuous follow-up, as I mentioned, is a key to the success for more and more mapping and getting the more and more private providers on your list. When you look at the year-wise indicator performance, where before and after PPSA, if you look at in 2020, we started, as I mentioned, in June, the comorbidities, which is like HIV and diabetes testing. I'll be explaining the model again later on, and we do it at the doorstep. So that is the key where we are able to achieve almost 100% of our indicators in Bihar. Then next is the bank details validation. Definitely the call center helps, because day one you ask the person to give your bank details, nobody is comfortable. None of you will be comfortable giving your bank details like that. So it requires a continuous counseling, talking to the patient through the call center, through the home visits, and then the bank details are got, they get validated, and then they are being used. And after that, there is UDST. Now this has been a continuous challenge for us. When we started, almost only 54% were the indicators we were able to fulfill. UDST was the biggest challenge. I'll tell you how we actually innovated and came up with the model where we are actually able to achieve our 70% target of the UDST in Bihar. And definitely then there is Nikshay Poshan Yojana, where at least one payment has to be given, which has already been discussed by Dr. Rao, that there have been delays a lot because of system being transferred from central to the state to the central. Again, all those things are going on. So there was as I mentioned, for this UDST particularly, there was shortage of manpower which we saw in the government system. There were CBNAT cartridges shortage. There were a lot of indeterminate results which we were getting from the field. We then probed into it, why we were getting a lot of indeterminate results. So all those things led us to actually come up with a model where we supported the government through providing the lab technicians. Now we are providing lab technicians to all 13 lab technicians in almost 11 districts of ours where we are working. So in each of the DTC, our lab technician is working. We hire the lab technician, we train them. We train them for not just doing the test, but also to check whether the sample is fine, to check how to store the cartridges, because that has to be done in the proper temperature, which becomes a hassle in many times. And many a times also to know that whether the machine is also calibrated or not, because those are the challenges which we face every day on the ground. So training them to understand what are the ground challenges and then utilizing that. Then next is the free diagnostic services, which we provided the doorstep, as I mentioned. And in many districts, we face the issue, as I mentioned, for the NPY, there were local bank mergers, which was difficult, due to which there was difficulty in validating the documents. Regarding the FDC, if I have to talk about in Bihar, there is only 40 to 50% of the uptake, despite being repeated counseling to the patients. And we were able to achieve nearly successful outcome of 75 to 80% in all the quarters in all the districts. This is our modus operandi. We'll go by one, that is the patient seeking care in the private sector. We map the doctor, engage the private practitioner, then the private practitioner, in this case basically MBBS. The informal providers, what happens is we try to give them some incentive, and the informal provider then give us the notification, who is then sent to, the patient is sent to the MBBS doctor. So eventually the patient remains with the MBBS doctor only for the treatment. Then from the private practitioner, there is a hub agent called a person who sits within the hub or the medical hub where the doctors are there, chest physicians are there. He takes up the details of the patient, documents that in the Nikshay and the hub register. Also the data entry operator supports all these programs, because there is a huge data, as I mentioned, 33,000 patients are there. Then followed by, there is a treatment coordinator who coordinates the sample for home visits. Like I mentioned, that HIV and diabetes testing is done through the home visits. So every time this treatment coordinator goes to the patient's home, we'll ask for their details, give them the counseling for the HIV, we'll do the testing through the glucometer HIV kits there and then, take out the results, share it with Nikshay, share it with the doctor, with the LT, and then this is how the whole system works. Along with that, we have sputum transportation agents who take the sputum from the patient from the early morning sputum. So specifically, they will go to the patient's household, and then they will take the sputum and then transports it to the government facility. Now, as I mentioned, we were facing a lot of issue with the UDST. So as I mentioned, we already supported the government DTCs and various districts through the lab technician support. Along with that, we are also running our own DFY microbiological lab in Muzaffarpur, where we have our TrueNat machines, and thanks to Bihar government who is supporting us with the cartridges, and we have our LT who is doing the test. So, you know, with that gap of 54 to reaching to 70%, we were able to reach because of all these activities working together. Then the reports are shared with the hub agent, and then the hub agent then puts up the report in the Nikshay, and then finally notifies the patient, provides them with the FDC. The counseling is done through our treatment support center. We keep the FDC with us, and then DFI support at DFI support centers, and then it is given. Now the issue comes up with the treatment adherence. For that, we are running a very good call center in Bihar. Every patient, we ensure that once the patient is diagnosed, at least within first week, 3 times the patient should get a call initially. Then after that, next week 2 times, and then another week. So for intensive phase, basically the patient is getting the regular calls in case there is any ADR, because that is the high time that the patient will stop the treatment. So if there is any ADR, if there is any issue, the patient is being contacted upon and tackled upon that time only. Along with that, 99 dots and home visits, our monthly home visits definitely are done to ensure that the patient is taking the drug. This is our HR structure. We have, like, there is a project director, senior program manager, and a total staff of nearly 174 people in ground, including the M&E team, field facilitator, field officer, treatment coordinator, hub agent, DEO, lab technicians, as I mentioned. And we face a lot of high attrition rate, usually due to the staff incentive, which is we keep them motivated through our incentives. Otherwise, there is very high attrition. Now, what are the lessons we have learned through Bihar model? First of all, we keep a good licensing with the government helps us a lot. Timely payments have already been discussed with Dr. Rao, and providing the free diagnostics, as I mentioned, training the staff for the free diagnostics. Also, we try to assign our staff with the higher targets, nearly 30%, so they try to achieve high and high. We give them the incentive, nearly 30% as an incentive for doing good, and organization handles a lot of projects, other projects, so there are no delays to the payments to the staff, which normally most of the PPSAs face. Our challenges, as I already mentioned, we face the challenges for the UDST due to HR shortages, cartridge, mechanical breakdowns, AC breakdowns. There was hampering of the services because the TrueNAT machine, particularly during June to March, were shifted from CBNAT to TrueNAT. Again, a lot of shifting was going on. In Bihar, particularly, we face the issue we don't have trained pathologists because the extra pulmonary samples cannot be extracted. Then there is shortage of HR in the public sector for the validation of the results, which takes a lot of time, and the payment delays are there, and delay in the incentives to the doctors and the patients, which hampers the program. And definitely it's a huge challenge to manage such a huge staff of 170 people. Then there are transportation limitations of first line and second line samples. So in conclusion, I would mention that we have a good call center support. As I already mentioned, we get nearly 280 calls per day for requiring the queries related to the ADRs or the home visits or the patient existence. Then there is support office for the FDC distribution, lab technician support I already mentioned. Then training and compounder incentive is one of the major things, like we give rupees 150 for the compounder. Wherever we get the notification, we are having nearly 200 compounders paneled with us every month whom we pay. So informal provider incentives, which is not too much, but nearly 200 rupees notification is given to the informal provider like Ayush. We also started with the active case finding in the few of the villages, which helps us in identifying the newer cases, and infrastructure support, as I already mentioned. Then we have our lab, as I mentioned earlier, and we keep organizing the free awareness campaigns, medical camps, and a large number of HR is definitely required in Bihar with such a huge number of notification and the number of the people that we have to support. Our most important unique thing is monitoring and the evaluation system. So what we do is every day there is a call between the program manager and the ground team, and along with that, thrice weekly call with the senior program manager and the project director to understand the HR issues with the program manager. Then one weekly call with our district, whole of the district, 11 districts sit together along with other states. So we are working in 33 districts as a PPS agency, nearly 4 states. So we sit together, we try to do a lot of brainstorming. What is the issue? What is the solution to that issue? So we come up with those solutions through our weekly meeting. And then we have a central team which on the board, which identifies the newer team members and trains them, handholds them whenever there is a new PPSA state or district or cluster is added. So these are some of the activity pictures. This is our lab, as you can see. Then treatment distribution centers, training of the staff is done, monitoring activities done, geotagging of the patient, that it ensures that our field staff has gone to the household for the home visit. Then equipment donations that we did, then the active case finding. A small case story. I think I'm done with my time. Thank you so much.
So thank you so much, Dr. Shweta. I think we started with the Bihar state, who is the most experienced in this field. So thank you again for keeping in time. So we can have a 10-minute question and answer session. I would first give the opportunity for our jury members, both present in person and online. If they have any questions, please they can kind of ask the questions or any clarification, any comments. Yes, please, Shibu.
So what is the cost per case you kind of bidded to the NTEB? And whether that your costing had given enough flexibility to accommodate the LT innovation, because you kind of redesigned it. I was not very clear on whether the incentive was also budgeted in your cost per case, or you try to leverage it from the Government of India incentives. These are just clarifications.
So regarding the cost per case, when we actually bid it, we never thought we had to support with the LTs, because we were very new to this PPSA as an agency. But then later when we found out, we were facing a lot of issues. So when you look at the numbers, we are actually notifying 33,000 patients every year. And if you take at nearly 70% of that, which comes out to be nearly 28,000 something. In case you have to support UDST for 28,000 patients and you don't have a supporting staff and you are still, lying at 50%, no one can ensure that. So barring the cost, the whole idea was also how to give the service to the patient, because we never wanted that the patient, is left like that. So that is how we leveraged into that, and we tried to put in the LTs there because we thought that was the need of the hour, otherwise it couldn't have been possible.
Thanks for that. So did you find enough resources within your bidding cost, or did you source other resources to put the LT?
We have tried to, leverage the cost through the bidding only, because we have a huge manpower and the high numbers of notifications. So what we have learned from other states as well, where the notification numbers are low, we try to sustain with the smaller staff, because it's difficult otherwise for the cost. Where we have huge numbers of notification, then somehow we try to leverage with the additional manpower so that we can reach to those numbers.
More questions. What is the turnaround time for the sputum?
Sure.
And also, you mentioned that somewhere in your slide that you manage with your other projects to mitigate the payment delays, to pay the salary to your staff. Just want to clear.
Yeah, we do that. What to do? We have 170 staff. Every month you have to pay them. You can't say them, sorry sir, 6 months we don't have any payment from the state. We can't do that. Staff will leave. There will be a huge attrition. We have to do that. That is the only solution. Secondly, when you talk about the turnaround time, it's quite high in Bihar, because the areas in which people are living, they're very rural, very far off. One sputum transporter takes only 5 cases per day. It's very difficult otherwise to travel a lot in the morning time, or maybe in any case by the treatment supporter also to travel a lot, because the areas are very far off and 50 to 60 kilometers is the time range. And also because of the UDST cartridge shortage or something like that, those issues, the huge numbers of samples are there, particularly in private, and definitely a leverage is given towards the public sector. So there is a long waiting time. So turnaround times comes up to be 10 to 15 days. That's how it is. Yeah.
Hi, Dr. Shweta. Thank you so much for sharing this great story from Bihar. So I have a few questions about cost to the patients, actually before the diagnosis, because I think that also creates some of that churn that Dr. Rao had talked about before, how it takes many times before a person gets the diagnosis for TB. What was your experience with that? You touched on it a little bit with saying that there was a lack of pathologists for extrapulmonary TB, but I wanted to hear more about whether your program is able to address these costs for patients. Thank you.
Out of pocket. Okay. So regarding the out-of-pocket expenditure for the patients, definitely in the private sector, Bihar government is doing something good, as in they have the PHCs, primary healthcare centers, which have the X-ray support. So usually the patient is being transferred to the PHC to get the X-ray done, followed by we give them support through HIV and diabetes, so that they don't have to travel. FDCs kind of are supported. But quite an out-of-pocket expenditure in terms of if they have to undergo the CT scans or the things like that, that is always there, because considering the public sector is not performing well there, so the out-of-pocket is definitely high there. But I think we have to do a study to actually understand how much it is. That's a good question. We will probe into that. Thank you. Yeah.
So I just want to add regarding the question on staff salary. So actually it's the very difficult to manage with the kind of delay in payment release. So somehow I would say thanks to COVID we got lots of other, you must have heard Dr. Suryu name in COVID response in Delhi. So we cross-funded this staff salary from other projects. Another problem is this GST. So in Assam, they cut GST from the payment. In Bihar, we receive like additional. I don't know what is the situation in Mumbai and one more UP. So this I'm a little surprised that why this GST, if every like the whole country want to eliminate and Prime Minister want to eliminate TB by 2025, then all this I think we have to make this little simpler, and so that we as an implementing agency we should focus our time, energy, resources on finding the TB cases, getting treatment started as soon as possible, not on all these the GST and other related. Thank you.
Excuse me, ma'am, I have a question.
Yeah.
Thank you very much for the wonderful presentation. I just want to understand what are the process adopted to establish call center. Can you little throw a light on that briefly, please? Thank you.
So for the call center, we have the staff which works on ground. I mean, dedicated staff definitely who makes up the calling. And then there are specific devices, I think routers and all that. I'm not a technical person for actually establishing that portion. But definitely there are certain specific devices which are there to establish a good call center. And the staff which is working, we have nearly 8 staff in the call center which is working all the time, and now we are also trying to make up a central call center within Bihar only, because that is one of our state with the maximum districts and supporting the other districts as well. So that's how we're doing that.
Neeta Jha in next presentation will discuss detail about call center.
So there are some online questions as well. So maybe, yeah. So someone can kind of read out the questions also, online questions.
Thank you so much for giving me the chance to ask this question. And it was a wonderful presentation and a learning experience. I am STO Kashmir because we have to start with PPSA. I just want to know, like, since you are looking after at least 11 districts of Bihar, so how can you compare, like, how much, because PPSAs are basically to augment notification from private sector. So because I didn't see any data from your presentation, like how it has augmented the public sector. Because at least what we have learned that it has to be 50-50, like from private sector as well as from the public sector. So is it really making an effect, or what about the other districts, like where we don't have the organizations like yours?
So I think what I am sharing here is more of the model where we are linking up the private providers to the system, to the NTEP, how the program is running, and how overall total notifications have increased. Definitely in public, the different steps are taken. I think I am not the right person to comment upon that, whether the public is performing well or...
Not that. I'm not saying public is not. Like, if we want to seek it, okay, it has augmented this notifications and end-to-end services. That's my question for you.
So I think the graph itself explained that overall total notifications have increased, not just in the private. The overall notifications have increased. We are not saying we are taking notifications from the public sector and then we are giving it to the government. We are engaging the private sector. We are providing the notifications through the private providers only, and that's how we are augmenting the numbers to coming up to the total high. So that's how I think I was able to explain that.
So maybe we will have a last question.
Thank you very much, ma'am. Just you told 40% FDC given to private patient. So just I want to know, FDC is given through Niksha Aushadhi dispensary model or directly some other way?
So it's given through the Niksha Aushadhi dispensing model only.
Patient prescription is.
Yes, we upload that and then we give it through that one. Yes, sir. Yeah, sure. Yeah.
And the UDST is 70%. What
Yes.
was this percentage before implementation of PPSA?
So we can see here in the graph, sir. Before, I think it's not visible.
Challenging to get it back.
Yeah, it's okay. I'll just tell that. So before PPSA, the bank seeding was nearly, if we talk about, it was nearly 38, ranging between 38 to 65%, and UDST was nearly 11 to 26%. But these numbers are definitely for private. I'm not quoting anything from the public sector. This is what our observation is from the private sector. Before we started, that was there in the private sector, and then it increased in the private sector after we started.
Thank you. And one of the question which was asked by one of my colleague, the comparison between public and private. I think STO Bihar may answer that question.
Sorry, ideally she should answer, but these are the questions. Finally, the government comes into play. Here, if you consider the totally in 2021 WHP and Doctors for You 2 PPSAs, 8 districts are implemented through WHP and 6 districts through Doctors for You in the first phase. Then another 5 districts they have adopted. So altogether it is a 48 per lakh population TB notification from the public sector together, and 55 per lakh for 2021 through the PPSA, private sector notification. So 48 versus 58, 55. And a lot of things about the delays in the payment and the UDST. So I personally am very much motivated by George Orwell that somehow we have to acknowledge the mistakes. So nice presentations and slides and clappings, these are not going to help. Dr. Raman also told us that Venkatrapan about this constructive criticism. So if at times CTD also does some mistakes, maybe not Dr. Rao or DDG at the higher level. So what was the need of decentralization? Was it a right opportune that already there is a lockdown and everything is in mess? Then you want to a capacity building of the state to procure the CBNet? But that is past. Now it's good that government has reconciled. The same way, my ED, he was a nice person, but he was very much focused that validation should be 100% through the STS and personally. So how can you think about the 50% force of STS can validate 100% of the cases notified? And these are the deeper level of the mistrust. So government takes all the responsibility of being accountability, transparency, everything. So we cannot hold for everything. WHP or the PPSA Doctors for You cannot be blamed. I take the responsibility for many things that I have done wrong. But we have learnt one thing, that this financial criteria, that 4 crore or 5 crore rupees should be the annual turnover. So how can the smaller partners come into play? So there are many good NGOs better than WHP and even the Doctors for You, but they could not compete just because of the financial criteria that we include. So that I have learned. So we will do our course corrections. So it's not a very good success story. There are many things, and I'm very much lucky that there is a TB, what is called a TB PPM learning network exercise that's supported by the BMGF and WHO, and also Dr. Madhu is from McGill University. So lot of contracting mechanism and webinars and knowledge products are there. I think we should have dedicated in the agenda one of the things like that, how to, our colleague from STO Kashmir wanted to know. So I cannot give you the exact answer, but if you visit the TB PPM Learning Forum, there are a lot of things to learn. Thank you very much.
Thank you, sir. Thank you, Dr. Shweta. This was really good, and I think we had a really good some of the learnings, also some candid experience sharing. So we'll continue with State of Bihar. I'll request Dr. Neeta Jha from World Health Partners to share their PPSA experience for the state.
Thank you, Dr. Amar, and good afternoon, everyone. So I will be continuing with Bihar PPSA presentation. Doctors for you already have given a presentation on 11 districts in which they are working, and WHP was awarded for 8 districts. WHP is working for PPSA in 3 states. One is Odisha, one is Punjab, and one is Bihar. Bihar we have 8 districts. In Punjab we have 2 districts, and Odisha we have only 1 district. So Odisha and Punjab will be covered by my other colleagues. So I will be continuing with the Bihar. So district awarded was 2 clusters were awarded to WHP. Cluster 1 Patna, Nalanda, Gaya and Bhojpur, and cluster 2 Bhagalpur, Katiyar, Munger and Saharsa. Total population covered is 3.1 crore. Cluster 1 has a 1.9 crore population, and cluster 2 has 1.2 crore population. MOU we signed in March 15, 2020, but the project we could start only from June 2020 because of lockdown in the state. And the milestone indicator which was mentioned in contract was to notify TB patient, to validate bank account details of notified patient, which should be 80%. There should be UDST of notified patient 70%. HIV, DM comorbidity test should be done to the 70% of notified patient, and successful outcome should be 70% of notified patient. And all these indicators were payment linked, and what the amount we had quoted, which was 2495, and payment was based on that. The percentage was given to the different indicators what we could achieve. This is the simple PPSA model which we are following. There are the 4 players like we see in the middle. If there is a TB presumptive case, they have to go around either formal provider, informal provider, or chemist or diagnostic lab. And these, all the players 4 are supported by our field officers, treatment coordinators, sputum agents and call center. These field officer, treatment coordinators and sputum agents are present in the field supporting these formal providers, informal providers, labs and chemists. Field officers support the doctor, lab and the chemist for diagnosis, and also for comorbidity test, also UDST test, and ensure that patient receives FDCs or any private drug from the nearby chemist. Treatment coordinators helps in adherence counseling, go and visit the home, do contact tracing, and also they report outcome. Similarly, sputum agents are who collects the sputum from provider place, and they transport to CVNet lab, and their report is collected. And there's a call center which does the follow-up counseling call, adherence call, and other calls. So this is a simple way of patient pathway, how we do. If there is presumptive cases, it comes to a provider clinic, it is diagnosed with TB, they are given voucher for HIV and diabetes testing, and patient takes that voucher, goes to nearby lab, the test is done free of cost, and we reimburse the payment 120 rupees to the lab. And then the sputum, same time sputum person collects a sample and transport to UDST lab, which could be either WHP in-house lab or the private labs where UDST is done. Then after the patient is diagnosed, then the treatment coordinators, the same field officer follow them for drug voucher, and drug voucher generated, and patient is given drug from the nearby pharmacy. And public health action is done by treatment coordinator, counseling and contact tracing of that patient, and adherence is through call centers by outgoing call, and the unproductive calls are followed by treatment coordinators. This is an organogram. We have total HR 116 in place, and we have field team around 95. So if you see provider mapping and engagement, we had engaged 1,482. We mapped 2,927 doctors, 1,354 chemists, and 323 lab. And around 50% of doctors are engaged, and 20% of the chemists, and 39% of the lab are engaged. This is a dynamic process. Lists are regularly updated because some clinics are getting closed and new ones are added up in the facility. So 70% of our engaged doctors are active in the program. Active is definition is they have notified at least one TB case in 3 months, last 3 months. So out of 1,043 doctors are active in the program. If you see 8 district indicator achievement through private sector, first year achievement from June 20 to May 21, we had achieved only 53% of the target. Because of the COVID, there was lockdown, many clinics were closed and doctor was not sitting in the clinic. HIV and DM was 92%, DBT 87%, UDST 68%. But second year, we could achieve 102% of the notification of the target which was given, 95% of the HIV, 90% DBT, and 7% UDST. So we have giving the incentive to the compounder, ₹100 notification. Engagement for the lab for HIV DM testing, which is we are giving ₹120 for the test. This is covered in 2495. We are having regular interaction with the high notifying doctors and also inactive doctors, and we have set up our own laboratory for improvement of UDST. This is just to show a notification trend before and after PPSA. If you see in 2019, we had around 47% of the notification from the private sector, which has improved after June 20 to around 70%. And in the 2019, the major notification, 47% is coming from one district, Patna, which contributes to 65% of the notification. So if you see in overall the private sector notification, if we remove from the Patna district, it was very low, which has improved in coming years. Similarly, case notification rate, which is per lakh population, has increased from 206 to 511. 206 is in the public sector and 511 in the private sector. And the activities mostly are doing that regular follow-up visit to all the providers, building trust with the compounders, incentive payment, free test, medicine, and regular follow-up the patient through call center, which also had increased the caseload at the doctor's clinic. Referral from the informal and health camps at the clinic also helped in increasing the caseload. This is just to show that which formal provider, where we should focus. Like if you see, we had divided into 3 criteria: high notifying doctors, medium notifying, and low notifying. So out of 1482, which are engaged doctors, high notifying are the 4 doctors who are notifying more than 100 TB cases. 114 is the medium notifying, between 50 to 100 notification, and low notifying are the one who is giving less than 50 notification. So if you see, 78% of our notification are coming to 68 doctors, one high notifying and medium notifying. Informal provider role in case dissection, we started slightly late engaging informal provider in January 21. And if you can see, 1512 we had engaged, and notified patient is 3547, which is 7% of the total notification. But Saharsa, if you can see, it is 47%. Because Saharsa is highly rural, the formal provider is very scarce there, and they have referred a huge number of cases there, and it leads to 47% of total notification in the Saharsa district. This is showing just a trend that how we started engaging informal, and the case notification has increased. If you see in the formal provider, we had started with 1,000 engagement, and then we moved to 1,482 engagement and case notification and improved. Similarly with the informal, the cases notification has improved. So engaging the informal providers, I think we should be part of the program, because many people reside in the rural area who could not access the formal provider for their treatment, and the cases are getting messed up. This is trend of UDST achievement. Our total UDST is 61% of notified patient. There, if you see Q4 and Q1, there is a dip in the UST because of there was shortage of gene expert supply and TrueNet supply, cartridge supply in the state. So there was low DST has been achieved in that period. Also, getting sputum sample from pediatric and extrapulmonary samples for the UDST is also very difficult. So for UDSTW has set up in-house lab to support the privately notified TB patient. We have 3 CBNet machine and 2 TrueNet machine. 2 machine we received in November 21 from the government, state government. We have 2 lab technicians who can run round the clock when the sample load is high. And we did 55% of the UDST through our own lab. Out Patna district patient was 62%, and out of Patna district patient was 38%. So if you compare private public notification from 2 years, we have implemented the program. So total notification was 89,708, and 30% was done through public sector and 70% was done through private sector. For the FDCs, we are placing the government FDCs in the private pharmacies, and we have engaged 276 pharmacies. Patients are given referral coupon for accessing drug from the nearest store. Pharmacy dispense 1 month stock, and they create drug ID on the Niksha and validate on Niksha Aushadhi. Pharmacies, we pay rupees 30 per patient on dispensation on 1 month drug, and WHP field personnel verify regularly the stock register, so which is maintained by the pharmacies. So if you see uptake of government FDCs have increased. So it has become 59% of the patients are currently taking government FDCs, and the major part is in Patna and Katihar, which is around 70%. So first year successful outcome was 89%, and 5% was died, and 1% the treatment change, and not evaluated others is 5%. So some of the field visit reports, pictures are there, health camp we did at the rural center. So challenges, coming on challenges, one was earlier also mentioned, that delay in government reimbursement. But second part is that we have made changes in MOU on the contract MOU, because earlier it was mentioned 5% of the verification, but after ED had given that it should be 100% verified, but then thanks to our STO, we helped and negotiated against and brought it to 25%, and there has been also provision of 60% payments on the initial submission of bills. So because of delay in reimbursement, we are not able to release salaries, and it is leading to high attrition of trained personnel. Stock out in the cartridge also results in low DST. Delayed provider incentive and DBT under NPY impacts notification. So what lessons we have learned? Small incentive also supports the output of the indicators. Inclusion of formal provider for expanding coverage to rural area is required. We have set up in-house lab which has helped to achieve more UDST. Engagement of private laboratory for free testing of HIV and diabetes helped a lot in achieving the indicators. Setup of the call center, which I will talk in the second half, has helped to report adherence and outcome of the TB patient more fast way. Summary learnings from the PPIA, which was through Gates Foundation funding, a private provider interface agency, which we conducted in Patna district, and PPSA program. Though both learning had helped in engaging private sector, which is essential for TB elimination, as 70% patients are treated in the private sector. PPSA is required to support government for reaching missed out cases in the private sector. The agency and the government coordination is required to achieve the maximum result. Continuous visit to provider and monitoring visit is required in large scale program. Pharmacies should be engaged for dispensing FDCs, as most private patients do not want to visit government facility, and private doctors also don't want to send the patient to the government facility. Timely reimbursement is essential for sustaining both program and agency. for doing the work. Thank you.
Thank you, Dr. Neeta. So I'll request any questions from jury member or comments.
Dr. Neeta, a couple of clarifications.
Yeah.
This is again for a lot of you to perhaps think about this particular question. You have shown that there are doctors who are reporting, some doctors are reporting higher and some doctors are reporting very smaller proportion of patients. Were you able to really map whether this high volume doctors also get high volume patients?
Yeah, they get high volume patients.
No.
And they are made.
Just listen. For example, if there are 100 cases that they encounter in a month, do they refer, let's say 64 as you pointed out? Only that, and the remaining 36 they keep it with themselves. Or the doctors who are notifying very less in number, are they also getting more cases but they are referring only in smaller proportion of people to PPSA?
There could be both, because actually these high notifying doctors are mostly physicians and they have huge number of caseload. The low notifying could be other, like maybe a gynecologist, maybe neurosurgeon who have less number of cases. But this is also part that all doctors are not giving all notifications. They are to our partners, because if you see also the drug, private drug from the chemist, which is uptake from the chemist, that is much higher than our PPSA notification. So many patients are left out.
The second question again that goes to all of you is this. When you set up your own laboratory or call center or anything, somebody mentioned about GST. Have this been costed into the entire program before signing the MOU, or is it a post thought?
No, this was not the signed agreement. We have developed this because we were facing problem, and we found that it is better to have our own labs which can help to improve the indicators.
Okay. So how does it get costed? That's the,
So cost is built in 2495 because cartridge we get from the government. We have already got machine, only the lab technician call is that, and some rent and the electricity bill. So it is in the 2495.
Thank you. Can I take 1 more minute to give a little bit of couple of suggestions when you are making your presentation? Number one is that you give your challenges, of course. But also make an attempt to understand, make us understand how did you address these challenges yourself. That's number one. Number two, what are those kind of desired changes that you want to bring in at an operational level as well as at the policy level, that we must listen as people here, especially the CTD or people who are wanting to incorporate some kind of changes based on this learning that we are going to have for the today and tomorrow. So what are the kind of changes that you wish to be seen to be incorporated in the program? And number three, please highlight the innovation that you are following exclusive to the place where you are working. Because most of you, when you look at it, it looks as if you are following the template of your MOU. But just make sure that that innovation is highlighted, whether it is in these 3-4 areas, technology or private sector or optimal resource utilization. So just highlight a couple of points. Even though you may not have put it in your PowerPoint, but please highlight it in impromptu. That's also fine. Thank you.
Thank you. I think Ms. Sapna from World Bank also has a question, online question.
How is WSP tracking the FDC people and patient health, and do we have data to understand the trends?
FDC, yes, we are tracking that, how many vouchers they are taking, means every day, every month they are coming to take the vouchers or not, that we are tracking. And we have the data also that how many patients came to take the 6 vouchers, or second voucher, third voucher, and so we are tracking that.
Thank Please, Samir.
Thank you, Neeta, for a very interesting presentation. I had two questions. One was, you mentioned about informal providers being targeted, especially in Saharsa. So can you share a little bit more about what kind of a model is it? So what role they play?
Yeah, so Saharsa, because it was very rural area, it is, and very few doctors are available in the block and village towns. So we mapped them informal provider there, and we are paying 100 rupees incentive if they refer the confirmed TB cases to the doctor, the engaged doctor. And also we have done many health camps in those block level, village level, where our formal doctor who is engaged with us goes at the informal place, means informal clinic in the village or block level, and we pay 2,000 rupees for conducting this camp to the doctor, and the informal doctor collects all the presumptive cases in the clinic on the fixed day, and they go and they screen all the cases and they refer for the test, and then finally it is notified to the formal doctor.
So primarily informal doctors are providing referrals upwards?
Yes, referral.
Second question was on the call center, and I think this refers to both what you've been doing, WHP as well as Doctors for You. I was curious, how many patients is one call center agent able to deal with on a monthly basis? And when you bid for these contracts, right, was the call center an initial part of the thinking?
No, it was.
You brought it in later on?
Yeah, so it was not a part of contract. We brought it to establish a call center so that our the working is easy, so that it's not possible to follow up by household visit every patient, and we have 60,000 patients. And if you take out the first year outcome also 23,000, there are also 30,000 patients left who has to track for adherence and counseling. So that was a huge number. So we established this call center because we also had a call center in the PPIA program in the Gates funding when there was in Patna. So we established same system for following adherence and counseling of the patient. So I will talk about that in detail in the second half in the call center.
Any other question? Yeah.
First of all, I'd like to ask, since we have seen that the private sector notification is quite high number in comparison to the public sector. So what was the figure or the ratio before the PPSA, first of all? Second, in the last quarter, I suppose total number of around 233 odd private providers were active. And that too, they were contributing to around 60% of the notification overall from the private. So does it mean that, before the PPSA implementation, these high volume, providers were not notifying?
No, they were not notifying.
They're not notifying.
Yes.
So they have given the declaration.
Yes, so they were engaged by us and then they started notifying in the program.
Okay. But then at the same time, we see that the 59% of the patients are taking government FDCs. So, so is it that the patients have, prioritized or, changed their, preference to private diagnosis, but then, public treatment or, what is
No, it is not the changing of preference. The private sector patients who are going in the private sector also wants free medicine, free diagnosis. Although they want to go to the private doctor for their consultation, but they want that it is the pathology or whatever the test written to them should be given free, and medicine should be given free. So we made available the medicine to the nearby pharmacy where they already used to purchase the private drugs. So they go there and get the free drugs.
So have you also mapped the patients with key populations, because we see that most of the patients are from the marginalized society, right? So if the private sector notification is quite high, right, that means that the patients are capable to incur cost in the private sector.
No, it is not capable of not, but Bihar, if you see overall, 70% of patients are going for private sector. What means they pay, but they are paying from their pocket to the private sector, and in spite of public sector, they are going to the private sector. So in private sector, they find something free, they want to take that.
Okay. And my last question is, when did you start this compounder incentive? Which year?
Which provider?
Compounder incentive.
Same June 2020, or we started program, we started giving compounder.
Before the compounder incentive, was the private sector notification less?
Yes, I had shown that the private, yes.
So how do you pay them?
No, it is bank transfer, it is not cash, it is, we take all the bank account and we pay into bank.
Transfers. Okay. So do you think that if the compounder incentive is stopped, the private notification will again decrease?
If we stop the compound incentive, it will decrease, because most of the work in the formal provider clinic, in any doctor clinic, is done by compounder. Doctor is so busy that he will not do any work. So even notifying on next share or helping in the sending patient for HIV, diabetes testing, or for drugs getting from the nearby, all work is done by the compounder, although supported by field officer.
So we believe that there are patients coming from the public sector to the private sector, right?
It is not so that public, there is already patient in the private sector, huge number of patients in the private sector.
Fine, thank you.
Thank you. Any other question? Yes, sir.
So there are two questions. One is, what is the proportion of notifying providers where we are giving compounder incentive?
Where we are paying all compounders incentive.
All notifying?
All doctors, compounder, we are paying to all compounders.
Okay, and that's over and above 500, which is being provided as an incentive for notification.
This is 100 rupees notification is not to the formal provider, but it is to the compounder. We are not paying anything to the doctor. The doctor comes through the public sector incentive.
Okay, so that is over and above that, right? Got it. Got it. And the second question is about the informal provider to whom we are providing incentives. So it is for referring to any particular provider?
No, this is data is from our engaged provider where they have referred and the patient has been notified. And for informant, the current notification is from the government is that if they refer to a public sector for notification, they will get 500, but if they refer to private sector, they will not get any money. Yeah, so we pay 100 rupees to the doctor. So I think it will be better if we also make them give 500 rupees if they refer to the private sector.
Thanks, thank you.
Thank you. Yes, Parijat.
Just a quick clarification. I might not have seen this correctly, but was you're getting a lot of patients from Patna, right?
Yes.
Was the positivity of Patna around 40%? 38 or 40%, right?
The DST testing you are talking about, micro confirmation.
Yes.
No, it is 20%, 20-25%.
Okay, so in one of your slides, I thought you were showing 38% positivity with CBNAT. So I was worried, is there some selective referral happening? It's not,
no, it is not so.
Okay, so thank you so much.
Thanks. Thank you, everyone.
For sharing this. So I think we had really good kind of interactions for the state of Bihar. So before moving to next state, which is Chhattisgarh, I'll request Neeraj. There is a small announcement which he is going to make.
And good morning, everyone. So there is one aspect of PPSA implementation which we have not really explored thoroughly, like PPSA for engaging private providers and increasing notification from the private sector. You need special set of awareness material and activities to generate awareness over there. We have generic material available in the program, but you have special needs and special gaps which you need while implementing PPSA, you need to fill. So to capture that, we have devised a short online survey. My teammates will be putting some QR codes on your table. You can scan it using your smartphones or iPhones, and just give us some kind of feedback on these questions, on what are your practices that are being followed in your states when it comes to engaging private sector providers, and also what kind of material you have access to, and also what is your unmet need which you want to do. Apart from that, as a part of an initiative, we have requested Union to develop some material to support the PPSA in their awareness activities in the field. And I request Dr. Kuldeep Singh Sachdeva to kindly talk about that for a few minutes. Sir, over to you.
So, thanks, Neeraj. As a National Technical Support Unit, I think you are doing full justice to your state units and PPSAs and getting them more notification. The idea is coming from NTSU only, that you may need a specific set of communication material, context-specific communication, and your target audience is also different what ACS and people are actually designing. That's why this survey. So I said yes. We have worked together. So my team, our project director Anisha is here. She'll connect at some point of time with all of you, or maybe now, and we will try and develop a context-specific and your target audience-specific communication material, which can actually help you in getting more notification, getting more public health actions out of your notification, and also easing your facilitating your whole operations in getting more TB patients enrolled and successfully treated. If you have any other suggestions, etc., I don't think you can also give them separately, and our team will be collecting the same. Again, congratulations to the National Technical Support Unit, Dr. Rao, CTD, Dr. Venkatraman, for putting all this together, and we are there to support all of you. Do you want to add anything, Anisha, to this? Come and you can do that. Take 1 or 2 minutes, no issues on that. Thank you, Neeraj. Over to you. If you want to say, it's okay. Otherwise, you can interact during the lunchtime. That's okay.
Is there any mic there?
So the questionnaire, QR code has been just placed by my teammates, like government placed it on different tables. You can scan it through your smartphones and provide us your feedback.
That's a QR code enabled questionnaire. So once we sort of analyze all your responses, we will understand the need gap, and we will then create content specific communication interventions, which will be for private practitioners, both from a private practitioner as TG and the patients who walk into the private practitioner's office, clinic, etc. as TG. So request you to please take 2 minutes to fill that a need gap questionnaire on ACSL. Thank you.
So thank you so much to Dr. Sachdeva and Union team. So maybe now we'll go to the next state of Chhattisgarh, and I'll request Mr. Laukush Kumar from HLF PPT to present their fine experience. And so HLF PPT is like working since almost now 3 decades, and so love to hear their thoughts.
Hello, good afternoon all. Dr. Sangeeta Pandey along with lab course is presenting for the PPSA that we are implementing in the state of Chhattisgarh. A brief about the HLPPT. HLPPT is a trust promoted by HLL Life Care Limited, and our head office is Travancore, Kochi, with the vision of touching life with quality cares, compassion and emerging globally credible organizations. Mission is offer innovative, affordable and sustainable reproductive health solutions, and core value is a great. The patient provider support agency, the aim, as we all know, we will not go into it, but the footprint of HLPPT is in 5 states, covering 36 districts. Chhattisgarh, we are having 6 districts, Maharashtra 5 districts, Odisha 3 districts, Uttar Pradesh 10 districts, that we started in Uttar Pradesh, and Gujarat 12 districts, that is, we just signed the contract over there. Now coming to the Chhattisgarh, as we said, we are having PPSA in 6 districts, that is Raipur, Bilaspur, Dhamtari, Durg, Korwa, Raigad, and total population that we have is 1 crore 10 lakhs, and notification target is 13,000. And I just wanted to bring these 6 districts count for 80% of private sector notifications in the state of Chhattisgarh. That is, these 6 districts are very much important for the states. These are milestones. I will not go much about that. The achievement of TB notifications against the baselines pre and post. I have taken the baseline 20, and we can see the graph. We have achieved, in fact, when we started the implementation in the month of July 21 onwards in the state of Chhattisgarh, and gradually the blue bar is for the 20th and 21, and the orange bar is 21-22. And next, specifically because first year we have taken time for the mapping, engagement of doctors and sites and all these things. January 22, June 22, this is the figures, district-wise. Durga is a bit low because other agencies also implementing, working in the state, in the districts of Durg. Raipur is notifications, and we achieved 61%. Bilaspur 86%, Korba 86%, and Raigad is 95%. Notification. This is the public health action. When we started, July 21 to June 22, bank details validation 76%, UDS is 65%, contact tracing 86%, HIV testing 94%, sugar testing 90%, and successful treatment 79% for the 6 districts. And this is the achievement for the January to June, bank detail 82%, UDS is 73%. Contact testing 86%, HIV 94%, and sugar testing is 91%. Implementation plan, usually, as already our partners already said, this is more or less we do mapping. When we call about the mapping of any private health facilities, we do universe mapping. It's not only those practitioners who are notifying cases. So we have the list of all the doctors, labs, and pathologies over there. And then we build the capacity of that doctors. We do ask doctors to nominate one nodal person that we call the Niksha Mitra, so that our main focus in the institutional buildings, the capacity of that particular facilities, so that if we are not there, they can do their work by their own. The capacity building of doctors and Niksha Mitra that we do, and then after the engagement of that facilities, then we establish the linkages with the health facilities and labs. And once the lab, we get the diagnosis done, notifications, we ensure the notification of the lecture. Counseling, we do ensure the counseling, 3-tier counselings, one by the doctor, second by the Niksha Mitra, and third by our counselors, our field officers over there. Public health actions, we do ensure by all even the Niksha Mitra also plays an important role in that, and our officers plays at the field level. And we also address the comorbidity test. Because why I am taking the comorbidity, when any people who are HIV positive, we do ensure the ART linkage to that particular persons. That is we specially take care of that. Since we are working in the HIV also, so we know that is important in that way. Adherence support, we do provide the adherence support of all the patients, notified patients, social support system, Niksha Poshan Yojanas, and contract tracings. That leads to the successful treatment outcome. How do we map the facilities? Before PPSA's 19 data, it's around 1544 is that NHRA data. We do added 269, and the cumulative figure comes up 1813. Sorry, 1813. And same notifying facilities also. Before PPSA it was 554, and now after PPSA the 130 facilities started notifying also the cases, and that counts as 684. The strategy, one-point solution, we do provide, try to provide the one-point solution to the patient, so patient should not move here and then we do not lose the patient, and that too with the system strengthening. So first, as I said, whenever the patient comes to any private clinics, the doctors has to nominate one nodal persons for that we call the Nikshay Mitra, and when the doctors comes, I think take the patient first and then refer to the Nikshay Mitra. After the Nikshay Mitra, we take the registrations of that patient, complete the formalities over there, and we do offer at that time, if possible, sample collection at that point of time also, if possible. If not, the patient has been called next date, and so that they collect the samples over there. Our sample transportation collection agent take the sample from the hospitals and then move to the lab facilities for the sample testings. After that, we do also ensure the report goes back to the doctors and the patient also. So patient need not move anywhere. They get the report as well as doctor also get the report of the test done. And after that, our field officers also ensures within 15 days they should make visit to the facility home of that patient, notified patient. So that is the one point that we also take care of that. And second, we do also promote the government prescribed FDCs. So over the period of time, initially it was remarkable, I think, differences that we have noticed, because we do counseling to the doctors also, because there are some patients who cannot afford the medicines. So on that ground, we are not there to hamper the sometimes there is a challenge also. Some of the facilities don't want to, I think, give the government medicines, but taking consideration of the patient conditions, if they are not financially sound, we do advocacy that please keep medicines at your facilities and please prescribe government facilities. So gradually we, I think, able to penetrate that area also. And last, we do also go the chemist shops for collection of T-notifications. Labs, we also catered the information from the labs and chemists. So all points have been covered so that we can get, and we do also the triangulations of data. If the lab, we are getting any test report notified, positive from the labs, we do go back to the doctors also from where the patient has been prescribed. And similarly with the chemist also. How do we do? This is a process I just wanted to highlight here, everyone. Confidence, regular visits, and we do use the information toolkit here to sensitize the doctors, and that also help us, our officers, to maintain that same kind of information. The communication should not be, I think, misguided. Demonstration of services, what are the government services available there? We do demonstrate even the medicines that are provided. And this is the letter of engagement private providers. We do also ensure that doctors also agreed that we do share information to the government and to the Nikshay portal, notifications, we do ensure that after. These are information toolkits that we are using for sensitization of doctors and we do also ensure that what are the facilities and the test where they can refer the patient for the testing, and what are the government facilities available, FDCs and Nikshay Poshan Yojana is a more focus, and we do also pass that information to the facilities so that if the patient is sitting over there in the OPD, they can see they can get that medicines, government free medicines is there, and 500 rupees for the patient for the Nikshay Poshan Yojana. So that is very much, I think, helpful for rapport building with the patient, and patient also allow us to move into their home residence. The contract tracings. Where we do our best practice is the leveraging of existing resources of the hospitals or clinics. We are not, because we do, I think, ensure the systems, as I said, leveraging private provider staff as Nikshay Mitra, so that they can, over the period, they are sensitized, they take care of all the things, notification has to be ensured, and eventually the public health action, so all the tests has to be done on time, and real-time notifications has to be done into the Nikshay. We do establish linkages with the private providers and sample extraction labs, because we are facing challenges in the Chhattisgarh for the extraction of samples, especially for the extrapolary cases over there. We do also encourage private providers for prescribing government FDC and facilitating provisioning of the FDC. We do generate the indent from the private hospitals based on their caseload, and we do take the indent to the district drug store unit and then revert back with all the medicines to the private hospitals itself. And third one, we also ensure the self-monitoring system mechanisms through online platform that has been introduced by HLPPT, and regular monthly coordination review meetings with the state DTOs and PPM coordinator in the district level. And I just must share that we have received a very good support from the state level as well, all the districts. Even DTOs are very much supportive to the PPSA staffs, and the programs moves on very well in that way. This is already I said that we do ensure the Nikshay Mitra, one person, nodal person at the hospital levels. The benefit, this is the, and we do give incentive to the Nikshay Mitra for all the activities. This is because this, we can say that this is cost effective. Sample collections, real-time TV notifications, bank account details have been collected with the support of Nikshay Mitra also. And this is the template that we are using for the Nikshay Mitra. In Nikshay Mitra, that has to be nominated by the doctors. Doctors has to seal and sign in that, and all the details of Nikshay Mitra has to be mentioned. We do collect the Nikshay Mitra Aadhaar card and bank details. We do transfer the amount through the banks, and Nikshay Mitra is very much fully aware ki how much money they will get for which kind of services, and that has been posted to the hospitals also. So there's a, and once we that notification is entered into the facilities, then after that we do give money, release money to the Nikshay Mitra. Second, in Chhattisgarh, establishes linkage with the private providers and the labs for sample extractions, because we are facing, when we started in Chhattisgarh, the extrapulmonary cases, I think most of them, 80% is clinically diagnosed. Very less cases are referred for that UDST and sample extraction has been occurred at that period. Then we identify the labs in all the districts, and then we sensitize the doctors also, ki please refer and extract the sample so that we can collect the sample and get the UDST done with the support of the government as well as somewhere in the private also. And after that, on call collections, doctors calls our field officers over there, and our field officers go on the real-time basis, collect the samples and take it to the lab so that UDST has to be performed. So 2019, I'm just comparing it, UDST done is 573 out of 2382 notifications, while in 22, if you see, the figure goes on 3702, and UDST done is 1939. And in we also, I think for after that we had MTV cases, out of that is 322. Reformation testing and sensitivity cases also we ensured, that is the number 9 that I have not mentioned here, but we do also ensure that other testing has to be done in that case. Second, how do we do the contact tracing? We also ensure, as I said, ki within the 15 days of investigations, our field officer ensure the field visits of the patient that has been notified, and we prepare the list of all the PETV cases, and field visits has to be ensured. Sample collection from the patient home, if they are symptomatic in that case, we do collect the samples and get it as done by the labs. A report also delivered to the patient get back. 577 samples were collected during the contact tracings, out of which 17% were found TB positive and that were linked and notified in that case. So the 3% cases rejected in that case. How do we do the FDCs and the patient seeking care private providers? We do take the estimations of the private hospitals, how many cases they are taking care of, and we generate the indent at the district level also. After collecting and generate some at the district level, we do go to the district store unit, issue the FDC as per the demand of the PPSAs. Maintaining record of the PPSA app, we have one online app also where do keep record of the how many FDC, what kind of FDC has been given to the patient. And so that, and out of, in Chhattisgarh, in 6 districts, we have 144 FDC centers with 49% on FDC, but overall cumulative, ranging between 76% Bilaspur and 96% FDC we do ensure in Raigad. And this is the image where the private hospitals establish the FDCs. So we do ensure that the hospital itself keeps the medicines and prescribe the government medicines. That is the best practices that I wanted to. This is the format that we use, even how do we generate the indent. take the medicines, stores, issue vouchers, we do ensures, and then same has to be ensured in the Nikshay portals also. What kind of, we do also ensure the record in the Nikshay app. Self-initiated monitoring mechanism, I would like to say in that we also introduce a PPSA app developed by HLPPT. Daily attendance and staff activities has to be tracked. Fixing daily visit targets to each and every staff, and that could be seen by the state, districts as well as national level. If I want to see where is my staff, I can see through the support of the app. Record maintenance in the app, diagnostic reports, treatment card, bank details, provider in universe and FDCs. Then we do the authentication validation of data entered in the Nikshay with the help of this app. Online repository of patient-related documents, thus reducing the paper and loss of documents. Anytime if any can ask, we can give the details, no issues with that. And performance appraisal of the staff also we can monitor with the support of this app. This is just I just ask Lavkush to go quickly.
Okay, thanks. सो ये जो है PPSA का मोबाइल एप्लीकेशन है जिसमें फ्रंट पे हम अटेंडेंस डेली मार्क करवाते हैं, जिसमें वो अपना डेली शेड्यूल करता है कि उसको आज की एक्टिविटी क्या इंश्योर करनी है, एंड जिस फैसिलिटी में उनको विजिट करना होता है उस फैसिलिटी का नाम सिलेक्ट करते हैं. एंड इफ़ यू सी ओके, सो दिस इज़ द नंबर ऑफ विजिट्स. सो इन अ मंथ, करंट मंथ में कितनी विजिट्स हो चुकी हैं, कौन सी जगह पे विजिट करनी पेंडिंग है, यहाँ से स्टाफ अपना सेल्फ मॉनिटरिंग कर सकते हैं. एंड देन दे आर सेलेक्टिंग दोज फैसिलिटी एंड शेड्यूलिंग. इन द इवनिंग जब उनका काम ख़त्म हो जाता है, देन दे आर सेलेक्टिंग द पर्पस कि वहाँ पे क्या करके आए हुए हैं फील्ड स्टाफ. सो ऑलरेडी वी हैव पुट इट सम pre-filled purpose, so just selection करना है and they will put. And if they are visiting in non-scheduled facility जो उन्होंने मॉर्निंग में नहीं किया हुआ था बट इवनिंग में भी they can add. So this is the patient follow-up summary we are also capturing. So mode of follow-up, patient visit or neither telephonic, so they are putting and which indicator they have to did. So DBT, contact tracing, HIV, DM and patient outcome. So जो भी उन्होंने पूरे दिन में पेशेंट के साथ किया है यहाँ पे टिक करके they can add and they can add more number of patients. And this is the one another page. So staff can see their self KPI, key performance indicator and daily work report, patient follow-up summary, like that. So this is the patient registration portal. बहुत सिंपल है, नॉर्मल सी कुछ चीज़ें इसमें कैप्चर करते हैं. से रजिस्ट्रेशन फॉर व्हाट, सो सैंपल कलेक्शन के लिए पेशेंट को रजिस्टर कर रहे हैं, नाइदर दिस इज द कंफर्म पेशेंट. सो यहाँ पे सैंपल कलेक्शंस टाइप्स एंड नेम ऑफ सैंपल, नेम ऑफ टेस्ट वेयर सैंपल इज ट्रांसपोर्टेड, सो दे आर सेलेक्टेड एंड जस्ट सबमिटेड. सो इस टाइप का पेशेंट का एक पेज जनरेट होता है जहाँ से पेशेंट के डॉक्यूमेंट्स हम स्टोर कर रहे हैं, जिसमें नोटिफिकेशन फॉर्म, सैंपल्स की रिपोर्ट्स एंड डायबिटीज़ स्टेटस, HIV स्टेटस एंड आउटकम स्टेटस. एंड इस पोर्टल से ही पेशेंट को डायरेक्ट कॉल भी स्टाफ कैन डू एंड टेक्स्ट व्हाट्सएप भी स्टाफ कैन सेंड. सो दिस इज़ द डेली वर्क रिपोर्ट जहाँ पे स्टाफ ने पूरे दिन में क्या काम किया हुआ है, दे कैन सी देयर. and this is a key performance indicator. So exactly key performance indicators में they can get the line list कि उन्होंने कितने UDST कर लिए हैं, कितने पेंडिंग्स हैं और कितने पेशेंट्स का जो है उन्होंने बैंक डिटेल अपलोड कर दिया है, कितने लोगों का ट्रीटमेंट कार्ड या फिर नोटिफिकेशन फॉर्म की कॉपीज अपलोड की हुई हैं. सो दे कैन सेल्फ एनालाइज. एंड हेल्थ विजिट हिस्ट्री, जहाँ जहाँ पे भी उन्होंने विजिट किया है डे वाइज दे कैन सी. एंड सैंपल रिकॉर्ड, सैंपल एंट्री के बाद जब उनको 2 दिन बाद रिपोर्ट की कॉपी मिलती है, दे इंटर द स्टेटस एंड उसका फोटोग्राफ भी इसमें अपलोड करते हैं. सो वी आर कीपिंग प्रोवाइडर यूनिवर्स. सो दिस इज़ द रजिस्ट्रेशन पोर्टल जहाँ पे कि हेल्थ फैसिलिटी रजिस्ट्रेशन के बाद एक हेल्थ फैसिलिटी में मल्टीपल डॉक्टर्स भी प्रैक्टिस कर सकते हैं. सो दे आर एंटरिंग डॉक्टर्स नेम एज वेल एज स्पेशलिटी. सो वी आर गेटिंग अ ब्रीफ आइडिया कि डिस्ट्रिक्ट में कितने प्रोवाइडर हैं और स्पेशलिटी वाइज ब्रेकअप वी कैन गिव. सो वी हैव वन वैलिडेशन पोर्टल की जो भी बैंक डिटेल्स की कॉपी या फिर ट्रीटमेंट कार्ड की कॉपी हमारे पोर्टल में स्टोर हो रही है. सो डिस्ट्रिक्ट लेवल पे उसको वैलिडेट किया जा रहा है कि वो इन्फॉर्मेशन करेक्ट है या नहीं. अगर इन्फॉर्मेशन वहाँ पे इनकरेक्ट है सो दे कैन पुट द रिमार्क एंड स्टाफ कैन गेट वन नोटिफिकेशन. सो उस पेशेंट का अगर ब्लरी इमेज है या फिर इमेज क्वालिटी क्लियर नहीं है सो यहाँ पे जो है वापस उसका सेकेंड कॉपी अपलोड कर सकते हैं. सो इस तरह से नोटिफिकेशन में क्लिक करने के बाद यहाँ से दे कैन गेट द रिमार्क एंड दे कैन अपलोड. So this is the validation portal. If all our information is corrected, so all column will be green. और अगर कुछ another इसमें कुछ वेरिएशन है तो दे कैन another color. So this is the sample record. यहाँ पे variation wise, region wise sample we are also storing and specimen wise also we are storing the sample record. एंड सैम्पल रिकॉर्ड आल्सो वी आर वैलिडेटिंग बिकॉज की स्टाफ जो है पेशेंट्स की रिपोर्ट एंट्री तो करते हैं. सो वी आर क्रॉस चेकिंग फ्रॉम रिपोर्ट टू द एंट्री. सो इफ ऑल आवर इंफॉर्मेशन इज करेक्टेड देन इट विल बी ग्रीन. सो ये वैलिडेशन डिस्ट्रिक्ट लेवल पे डिस्ट्रिक्ट कोऑर्डिनेटर या फिर MIS के थ्रू किया जाता है. एंड दिस इज़ द प्रोवाइडर यूनिवर्स जो हमने स्टाफ से एंट्री करवाई है. दिस काइंड ऑफ प्रोवाइडर यूनिवर्स वी आर स्टोरिंग डॉक्टर्स नेम, स्पेशलाइजेशन, कॉन्टैक्ट नंबर एंड कैटेगरी. कैटेगरी सिस्टम ऑटोमेटिक डिसाइड करता है. अगर किसी भी डॉक्टर्स का सैंपल किसी भी डॉक्टर्स के यहाँ पे सैंपल कलेक्शन हुआ है या फिर केस नोटिफाई हुआ है देन कैटेगरी ऑटोमेटिक विल बी डिसाइडेड बाय द सिस्टम. And health facility allotment also we can change one staff to another staff. And this is the health facility visit outcome जो भी उन्होंने पर्पस सेलेक्ट किए हुए हैं. So this kind of health facility visit outcome also we are recorded with the date and with the number of output की number of how many cases are there notified and number of how much samples are collected. So this kind of KPI report is generated staff wise which will help us to appraisal and something and number of average visit per day also we are which we are giving the target. So we are also monitoring number of average visit की उसका below जा रहा है या फिर उनसे number of visits increase करवानी है. So this is the and this is the another our dashboard जहाँ से हम पेशेंट का अगर NTEP या NHM में हमें इनवाइसिंग सबमिट करना है तो उस वक्त अगर हमें कुछ वहाँ से रिक्वायरमेंट होती है कि हमें पेशेंट का ट्रीटमेंट कार्ड या फिर पेशेंट का बैंक डिटेल कॉपी सेंड करो. सो यहाँ पे हम उसको PDF में जनरेट करके सेंड कर सकते हैं. सेम अगर हम कुछ पेशेंट्स का ही उन्होंने रिक्वायर किया जैसे 10% या 20% पेशेंट का हमें वैलिडेशन के लिए डॉक्यूमेंट प्रोवाइड करें. सो वी आर यहाँ से सेलेक्ट करके उसको हम सॉफ्ट कॉपी जनरेट कर सकते हैं जो कि पेशेंट वाइज जो है एक फोल्डर की कॉपी जनरेट हो जाती है और वो हम सबमिट कर सकते हैं. सो दिस इज़ द इंट्रोडक्शन ऑफ PPSA एप्लीकेशन.
The main focus of PPSA app is कि we do monitor our staff कि what activities they are going to do, what is their plan and how much they performed in that. The real time monitoring could be done कि जो work assigned they have done or not, what are the pending tasks that they have to monitor, they have to do on time and all the data recording. In fact usually at the field level what we find the difficulties is to maintain the data. So we maintain the data so that that too in the good quality. If as and when the data is required, we'll do validate our record and submit it to the state. This is the structures, state organogram, state level, project lead is the state level. State level position, one we have the accountant, one is data analyst, project officers at the field level, or district levels, and we do have the telecounselors. I just forgot at that time, telecounselor ensures that call of the patient within the week, so that one level counseling done by the field officers then and there assets. After that, telecounselor do ensures within the week counseling has to be done. What are the anything, if any difficulties faced by the patient or not. After the concurrence, the consent of that patient, and the field staff, field officers, sample collection transportation agent, and Niksha Mitra, nominated by the private providers itself. In Chhattisgarh, we have 122 Niksha Mitra identified in 6 districts. These are the features. Challenges, one is delay incentive to the patient and private providers, thus losing confidence. So this is one of the challenges, but I think state has worked upon. There is some issues on that. One thing in Chhattisgarh, now we have to do the TPT, but doctors are less, I think, bothered. They are less aware, I can say, to refer for the TPT. So we are doing advocacy on that, and gradually we are getting success also. And we have collected TPT samples of around 995. How much? TPT mein? 577. Bank account sometimes is one is Chhattisgarh Rajya Gramin Bank is there, but we are not able to update, and so many patients have that account bank details of this bank only, but we are not able to update in the Niksha portal. So this is one of the challenges, and that reflected in our achievement also. And timely validation verification of documents submitted by the agencies also. Usually Chhattisgarh it is on timely basis, but if sometimes in some districts there is some changes, so that delay happens. Lesson learned is sensitization of private providers on the new guidelines of TPT way forward, and develop tracking mechanism of patient to reduce loss to follow-up that we are using. In fact, how to geotag the patient and map HF so that we can lose minimum and we can reach the patient as quickly as possible. Increase uptake of FDC, thus reducing the pocket expenditure of the patient, and timely validation and verification of documents submitted by PPSA agencies. So we are just working on that. Conclusion, we are working on all the 4 pillars of the NSPs, the detect, treat, prevent, and build. Thank you.
Thank you, HLF team. And questions from the jury?
Thank you. A very comprehensive presentation. The app is very interesting, especially to track the performance, the KPIs which you mentioned. Just one question regarding the privacy of the patient data. How do you ensure, is there consent sought? How do you store that data? How is that data used? And second part to that question is there an integration with the ABA ID which the Ayushman Bharat Digital Health Mission has brought in as well? Or are there any plans to kind of universalize that patient ID?
So for patient documents is concerned, it is with the concurrence of the patient, and this is only used for the validation. We are not, because we need to validate data to the Niksha portal, and we do ensure that avoid the duplicacy of the data also. This is one. And since we are providing reports to the patient, definitely we are having all these things. And bank details they are sharing whether they give the concurrence also. So it is, and our field officers and the PCs are, their names and numbers have been mentioned in the private clinics, and doctors recommend that these are our staffs and the you do here. So we, our main focus is the system strengthening. As you said, we strengthen the systems, whatever be the systems. With the private hospitals, labs, we do advocacy like that, and patient develop their confidence, and we do share. But we do not share any data to outside, to anyone. It's just for our purpose, because we do need that kind of data for the validation and reports invoice submission. That's it.
Just a quick add-on to his question. What about with the geotagging for the patients? Are you doing that already, and how do you ensure that?
No, that's way forward. We are in discussions, because just to tag, if sometimes and that we just thinking of if patient in concurrence, so that we can track if the patient moves outside the districts or the states. So that too we are just thinking there's a way forward. Can we, with the concurrence of the patient, can we do that?
Just one clarification. Did you budgeted this Nikshay app in your RFP?
Sorry?
It was costed in your RFP? Like
Yeah, PPSA app is costed in the RFPs.
Okay, that second thing is that you also said you kind of incentivize this Nikshay Mitra.
Yes.
Is that incentive, are you leveraging NTEP incentive or you are actually budgeted already in the...
We are budgeted that.
Thank you.
This is the budget.
Yeah, the question is the app connected to Nikshay at the back end?
Sorry?
Yeah. Is the app connected to Nikshay at the back end?
No. Yes, anyone can. Yeah, if they need to install the app in their mobile and they can do, no issues. They can do that.
Namaste. Office
Right, thank you. So thank you so much, for this nice presentation and the two speakers who did as well. With the permission of the jury, I'd like to make a few comments because I would not be, continuing in this meeting after lunch. In terms of the hub and spoke kind of an environment that we have been hearing from all the three partners and the geographical coverage that we've been hearing from all the partners, and also listening very carefully to our, State TV officer of Bihar and the ask that he has put across for, for the Central TV division to ponder around on reconsidering the reach of the NGOs and the inclusiveness of the kind of, ways in which things are for more and more districts and more coverage to be possible. Now let's think in terms of the penetration. I did see some of the slides, which spoke about, mapping, engagement, and then your actual active points. Most of the focus is around the last two pillars. As far as the mapping is concerned, I was only thrilled to see only one district in the previous presentation from WHP where the informal providers' contribution, is maximum. I mean, maximum in the sense the highest that I could see 47%, I believe.
Yes, sir, I think.
There have been patient pathway studies that we were discussing in the roundtables which we used to have in the BMGF offices during the UATBC era, where we were seeing, at least on an average 3 providers touched before they reach a proper, MBBS doctor kind of an environment, which essentially when you analyze the data of all the hubs that you have are MBBS doctors, most of them. Some of the spokes may also be MBBS. We have been in Mewat district last week, for this JSSM, where they just have about, say, 10 or 12 such. Rest of it are all those next door informal providers. To what extent is the penetration of mapping happening all the way till that next door provider is covered in all the districts is something which I would put across a question to each one of you. And where is the community, representatives' engagement in being able to map out those next door doctors and getting them linked to the hubs? Ponder around this. Number 2, the target setting which is being done, the drug sale data which was presented by Dr. Rao very efficiently, also is used as a proxy for estimating what numbers we have to reach. Are we looking at for those respective districts where the PPSAs and the STSUs are working, are we looking at to what extent are we able to reach out to those numbers which are estimated in terms of, and link it with that penetration of the last mile providers. Third important thing, we should keep our eyes open and ears open. If you have heard Dr. Rao, presenting on the World TB Day the National TB Prevalence Survey report, there is something to think around. Out of the 950 odd TB patients which were detected from 350,000 general population screened, nearly half of them did not have those typical symptoms of TB and were detected on X-ray alone. Do we have in our system mapping of the radiology laboratories? And can there be an effort to, request the radiologist or whoever is taking the film to kind of, share who had the abnormal chest X-ray and which doctor prescribed it? Can there be some kind of a reverse tracking of those individuals who have already accessed care but may have not come into our loop of the routine thing? You did mention about TPT, I'm thankful for that, but you all will require some bit of guidance on that. I would request you the national training modules on TB preventive treatment as well as the latest drug-resistant TB guidelines. They are all hosted on WHO Swasthya E-Gurukul. They are open, active. Any one of you can register and get yourself trained at a time of your convenience, but get yourself updated, please, and start thinking in the direction of the entire family. The shift in the NSP also is there to kind of think of the entire family now. It's not just that one individual TB patient. The whole household requires service in terms of contact tracing, testing for TB infection after ruling out active TB, and then providing the TPT necessary, for which will require local coordination as well. Last point is about the hub. A lot of hubs have been developed, but access to drug-resistant TB is very, very weak. We have seen even data presented that universal DST levels are significantly lower, particularly in patients seeking care from the private sector versus those seeking care in the public sector. But the care in terms of treatment is even poorer. All right. So there are, examples about 22 private hospitals have been, these are all the kinds of hubs that you all are talking about. They have been, engaged systematically as drug-resistant TB treatment centers. So from your mapping of the hubs in those respective districts, if you could pick up the one which has the highest number or which has the largest network and see whether they are in a position to at least start a clinic-based drug-resistant TB center as per the national guidelines. The spokes are already there. That entire network of doctors up to the informal provider can have access to drug-resistant TB services by just one action of engaging that one or two, high footfall hospitals in that respective district that where you all are looking at. Final point. Promise final point. Okay. Sir, with your kind permission. Districts which do not have PPSA, they too are, part of the target which the district or the state TB officer gets as far as the notification from the private sector is concerned. What is the role that the existing PPSA can play in terms of, keeping the general health staff of those respective districts where the PPSA is alongside you during visits, during reviews, so that some bit of ownership is passed on, and use them to kind of share with their peers of the districts, the health staff, the supervisory staff, the district TB officers of the districts where these kind of formal PPSA are not established, but still have some targets, still have some presence of informal providers, if not formal providers, like the classical case of Mewat that we spoke about. So these were the areas I would request each one of you to ponder around. Thank you so much for this.
Thank you, Dr. Malik. I think this is typical of signature trademark of Dr. Malik, but I think it was really brief on that. So maybe the team, you would like to briefly respond to any other queries?
In fact, in other states, we'll definitely focus on what you have said, ki we have the universe of the particular districts, PPSA implementation, not other districts, but we have that all the maps, and how we do leverage that, as you said, ki how do we ensure that H1 data and then cross-check with the doctors. We revert back on this, that is in my presentations. Second, we also have the Ayush doctors. They are also started notifying in other states. So in Maharashtra, we did all these things, but we just restricted them because of the timeline, so that we are categorized. And in Chhattisgarh also, so far that TPT is concerned, we have taken the data of Nikshay. 2880 is that total index patient that has to be reached, and we have tracked that family members of around 15,000, and we have able to reach up around 177 index member, and able to provide 711 members TPT. We're supposed to do 995, but we are able to get that successfully done for the 711 members. So we are gradually, because we have just started last 2 months back, so we are working on it. Definitely over the period of time we'll definitely able to track that. And second, as you said, how could we leverage the resources of nearby districts where we are not at the PPSA. That's why just if we can have some geotagging sort of things with the concurrence of the state and the CTD, so that we can find out the pockets where the cases are. The main idea is to and triangulate the data also, where we can have the maximum focus, so that we can intensify the cases. In other states also we have done the intensive drive for, if based on that need of the state, with the support of state also, intensive drive we have also launched. For mapping we did that, and continuously it is going on. So definitely I will take note of what you have said and try to implement more on that, implementing states and districts. Thank you. Thank you very much.
Thank you, team. So now it's 1:20, and maybe what we are targeting, let's at least have our lunch break at 2 p.m. So we have 2 presentations till remaining. And so now I think some change, in this PPSA experience sharing, where we are now having a presentation from Dr. Ravi Khan, who is from DFI, who will present on free diagnostic initiative, what they have done in Maharashtra. So over to you. Thank you. So your time is 15 minutes, sir.
Yes, मैं वही बोलने वाला था. I will just take 15 minutes or maybe less. I will move little faster. So first of all, I would like to thank Raghuram sir, Rao sir, to organizing this kind of workshop. In fact, जब से हम लोगों ने काम करना शुरू किया, तब से मैं वेट कर रहा था कि at least CTD organize this kind of meeting where we can come and share our experiences. So thank you so much, sir. So our my talk is on free this X-ray the services. So as you know, essential drugs are important. Similarly, now essential diagnostics are also important. Without having robust diagnostic services, as a doctor, I can't start any treatment. TB तो बहुत दूर की बात है. एक सेकेंड इसको. So what we did is in one line, if you say, we just distributed free X-ray voucher, so patient can get the X-ray done free of cost in any of the impaneled X-ray lab. And why it is required? So there are many studies which show that private practitioner or doctor, they follow lots of irrational diagnostic pathway or prescribe inaccurate diagnostic or omit them because they see patient करवाएगा नहीं करवाएगा, पैसा है नहीं है, many things. Like in Mumbai, typically in Govandi, Mandkhurd, many of the informal providers, they charge just 30 rupees or 50 rupees, and in that 30 or 50 rupees they cover the consultancy, free medicine also, and that is valid for 3 days, and after 3 days if you come again they'll charge. So suppose जो 30 रुपये 50 रुपये वो फिर diagnostic अब एक्सरे लिखेंगे वो 250 रुपया कहाँ से देगा. So that was the major problem why we like this program started. And you all know there are many studies that recent study that X-ray is even more sensitive and important than the simple microscopy. So that's why without strengthening X-ray services, if we are thinking we will eliminate TB, it's impossible. So what we offer these two, the free X-ray services and the HIV and diabetes testing. Both are free for our patients. So this is the simple diagram. So what we did, so once the patient visit any private doctor, we give these voucher to the doctor issue the voucher, and with that voucher patient can get the X-ray done in any of the X-ray facility available in that area, not necessarily the government, all the private lab, and then the X-ray get done, and patient receive the report along with X-ray film and visit the doctor again, and doctor evaluate the X-ray, and if it's the positive or doctor think that it's the symptomatic, then he start the treatment. So it's a very simple pathway. So what we did, you can see in 2019, 20, 21, we have issues these many voucher. These are the second bar is for X-ray done, and the number of X-ray positive in the third bar. So DFI began PPSA services in 3 districts of Mumbai. These 3 districts are one of the highest load of TB across India. इससे ज़्यादा I don't think any other Govandi Mankhurd, not only drug sensitive but drug resistant tuberculosis also. MSF is also working since long. So we impanel 22 X-ray lab, and nearly 82-85% of presumptive TB cases avail these free X-ray services, of which 25 to 34% were suggestive of TB on X-ray basis, and treatment were initiated. So this is we collect the voucher from these X-ray lab, we compile it, and every monthly we submit it to the district TB office, and they release the payment. They also do the verification. They know all the detail of these 22 labs, so they also do the verification, and after verification every quarterly they release the money, and it is running very well, I would say. In Maharashtra it's very good, and in fact this is the reason why we are able to notify large number of cases from Govandi and Mankhurd. So apart from that, the other challenge is getting this diabetes and HIV testing done, and in Mumbai तो it's easy, but even other state like Bihar, Assam, it's very difficult to get. even पेशेंट को बोलेंगे जॉट डायबिटीज और वो कर, उसके लिए भी फिर उसको 100, 150, 200 कुछ भी ले सकता है. So what we did, we train our lab technician as well as our treatment coordinators. So whenever they visit, they do the home visit, they only do the HIV testing and diabetes testing using glucometer and HIV testing kit. And if it is positive for either diabetes or HIV, we refer for the higher, like in case of diabetes we inform the physician, and in case of HIV we refer to higher center for further confirmation, because you know that this kit-based HIV testing is not sufficient to start the treatment. So that we do, and if the patient is positive, we notified in Nishchay and refer to ART center, and in case of diabetes, physician further do the other detailed test for diabetes, and if it's positive then start the treatment. This is the form, you can say, the voucher. The one part, the lab copy is this side, lab copy, and the same one copy we collect and submit to the TB district offices. So the free diagnostic insured tests are advised by private. So if the services are available, तो डॉक्टर फिर दोबारा सोचता नहीं है. He issues कि yes चलो एक्सरे तो हो ही जाएगा, it's free of course. So he also get कि yes ये डॉक्टर साहब के पास जाओ तो फ्री में एक्सरे होगा. So that is also very good incentive for the doctor, and as a PPSA partner our reputation also थोड़ा increase हो जाता है कि चलो अच्छा ये यहाँ से एक्सरे भी free हो जा रहा है. So they became much more supportive and compliant to our request. It reduces diagnostic delay जो normally 2-3 दिन लगता था या उससे भी ज़्यादा, अभी तो within week, like morning में prescribe किया, by evening we get the report. Avoid out of pocket expenditure, better accessibility, because now we have so many. So if you see in Govandi, Mankhurd, government X-ray facility just one, sir, is Satabdi Hospital for more than, I would say, 1.2 million population. 1 or 2 X-ray facility, but with this you have 22 X-ray lab available at your services. Then patient friendly X-ray positive rate help NTP in assessing TB case load also, because the more we do the X-ray we get to know the case load, and help PPSA agency to keep a check on presumptive cases. So now I'll discuss 2-3 points. You mentioned about that, what are the desired changes. So let's focus on the desired changes, what we want. So the first thing is, what I want is a strengthening of lab services, whether it's through the government or private, but this is urgent, sir. We have learned in the COVID how we expanded our lab services for RT-PCR from one lab. Within few months, we now have more than 2,500 RT-PCR lab. Without diagnosis, without prompt diagnosis, accurate diagnosis, we can never eliminate tuberculosis. So we have to spread this network of the X-ray and other diagnostic services on urgent and emergency basis. The way the government, all developmental agency work together for COVID, I feel the same kind of urgency is required for TB also. The second is desired changes is timely payment of private doctor and hospital, because our image get tarnished when we say कि अच्छा पैसा आपको मिलेगा, 500 रुपया अभी मिलेगा, 500 आपको ट्रीटमेंट के बाद मिलेगा, you will get 1000 रुपया. But if you have district where not a single doctor receive payment for more than 1 year, 1.5 years, then how can you face this? And as a implementing agency, we have to face, so our reputation get seriously hampered, sir. And I feel unless until we sort out this, it's a very difficult. We are talking about roping in more NGO, but NGO इतने बेवकूफ थोड़ी ही हैं. The people who are running NGO, I would say that they are the smartest one, because without selling any profitable product, they are providing the services. And so अगर कोई भी एनजीओ अगर अप्लाई करता है तो ही विल आस्क ना, अच्छा डॉक्टर रविकांत आपका एक्सपीरियंस बताइए पीपीएसए का क्या है. अगर मैं आज मेरे से पूछे तो मैं बोलूँगा कि पिछले more than 1.5 months से I have paid salary to all those staff who are getting less than 20,000 rupees, but all higher staff we have stopped the salary for last 1.5 months, because more than 2 crore rupees is still pending from the state TB office to be paid. So unless we start saying yes, PPSA is good and you must apply, and this is sustainable model, I don't think कि कितना भी कर लें, the more and more NGO will come. So that's the main thing, sir. The third is this kind of platform where we can come and raise our issues and somebody listen. I must appreciate the initiative by Dr. Vijay Sri from Niti Aayog, the TB PPM. At least हर 2 महीने पे and on the WhatsApp group we are able to share our problem, and in some of the issues she helped us a lot. The next is GST. I have already So we need to have uniform rule whether you are charging GST or not. Similarly, GEM portal. Now I'm the founder of Doctors for You, but since last 2.5 years I'm into Department of Atomic Energy, Government of India. I'm in charge of Tata Cancer Hospital establishment in Bihar. GEM portal वो बोलने में बहुत अच्छा लगता है, but GEM portal पे purchasing the thing is very difficult. If I want कि गोदरेज का टेबल चाहिए, वो कभी गोदरेज L1 आएगा ही नहीं. So I seriously flag this कि अगर ये सोच रहे हैं कि जेम पोर्टल कोई ब्रह्मास्त्र है एंड प्रॉब्लम सॉल्व हो जाएगा, तो ये बिल्कुल वैसा नहीं है. द थर्ड इज सिंप्लीफिकेशन ऑफ टेंडरिंग प्रोसेस. बिहार में 6 महीना लगा, 2 बार टेंडर के बाद ये हो गया. ये नेशनल पब्लिक हेल्थ इमरजेंसी है एंड इफ यू टेक 6 मंथ टू कंप्लीट द टेंडर. यूपी में तो फिर इलेक्शन आ गया, वो उसमें तो और भी आई थिंक मोर देन 6 और 9 मंथ लगा ये है. सो दीज आर द डिजायर्ड चेंजेस आई वांट. Now coming to innovation, as I said, the X-ray is the key. So the one thing which we are planning is this is the Mind 2 X-ray developed in South Korea. It's just 1.8 kg. Approved by AERB, ICMR. We have purchased 5 and in fact we are launching this on 3rd of August. Tomorrow we'll give a small demo also. It's backpack. आप लेकर के जा सकते हैं कहीं भी पहाड़ पे, कहीं भी, and once you charge this, it can give 100 film without the required charging. We have tested this for last 3 months and that's why the only thing it's a little costly, almost 32-33 lakh rupees. We are working on it to reduce the cost by 10 to 12 lakh rupees. The next thing we want to do is the voucher system for extra pulmonary and pediatric cases. Sir, हम लोग कुछ भी कितना भी भाषण दे दे, but the getting at least the state like Bihar, UP getting extra pulmonary TB cases diagnosed is very difficult. Pubblic like government hospital में तो है ही नहीं. Any other, even simple biopsy is not possible. So some sort of voucher system where we can borrow these services from the private provider is very, very important, sir. The third thing I would say that as a new agency, whenever you like now we Doctors for You, Alert India, they are very good partner. We working, but 3 years back when we started, we were very new. We expected कि कोई तो train करे, at least the agency, but of course the kind of the hand-holding support which we expected from the Alert India or the DTO, वो उस समय नहीं मिल पाया. So what I feel that if you enrolling any new PPSA agency, then at least 1 महीने का ना hand-holding or field visit with somebody like 2-3 मॉडल जो है वहाँ that भेजना is very important. ये बोलने में लगता है PPSA बहुत आसान है, but when you it's not that easy and वो समझने में ही 6 महीना लग जाता है and तब तक पेनल्टी काट लेते हैं सर कि ये तो भाई. अब बताइए कोविड महामारी है, उसमें भी पेनल्टी लगा है सर. And we have paid penalty, not only we, the WHO, Neeta Jha madam. So कभी-कभी मैं वही लगता है कि ये means TB को eliminate करना है या PPSA partner के life को complicate करना है. So and the last is genome sequencing. एक्सरे आया, स्पुटम माइक्रो, अब बोल रहे हैं यूडीएसटी में सपोज 2 ड्रग ही पता चलता है, रिफेम्पिसिन, INH, एंड इफ यू और फॉर इफ आगे LPA करना है देन 6 months or 2 weeks, 2 weeks in Mumbai, in MP 6 month wait to get the LPA. Isse how we can eliminate it. So and the cost if you combine it much more than getting this the straightforward gene sequencing and you get that detail about 14 antibiotics. We have established first such lab in Bihar, Muzaffarpur district, and I'm trying to start something and see the result of doing genome sequencing directly. Thank you.
Thank you, Dr. Ravikant. Yeah.
Sir, in case you want to make a demonstration of this X-ray, I request you to today, end of the day.
I will try. I think Vaisali ने कल का time लिया है. If you ask Rajat if he can come.
Yeah, I think logistically it will be more better if we do it tomorrow.
So इसमें मैं एक और just एक आधा मिनट लूँगा. That सबको लगता है कि this is very dangerous and ये. Have you visited any dentist for RCT extraction? उसमें भी वो लोग एक्सरे करता है ना. And if you see that X-ray machine is उतना ही small रहता है. The key is that the plate is super sensitive. So even if you use that the dental X-ray machine focus on chest, but वो normal plate pick नहीं कर पाता है. The key is this is super sensitive. So even it pick a small X-ray and give the clarity is just like digital X-ray, and that's why I invited Dr. Rajat Jain, who is one of the most famous radiologists here in Delhi, to answer any question.
Yeah. So just one question received from Sapna World Bank. She wants to know whether this X-ray scheme basically is it funded by MCGM over and above PPSA?
No. So it is funded by us only, Doctors for You only. Doctors for You never worked for money or we are really want to focus and on eliminating TB. So we have almost 1.6 crore rupees may we have purchased these 6 machines. Fortunately last week ही ये आया है, so I'll give. This is our own money from some other CSR funds. Yes, sir. So we are working on that probably in 1 or 2 months. Our target is around 12 lakh rupees because below that is not possible, but we are trying to bring it 12 lakh and develop it indigenously. अभी क्या है वो साउथ कोरिया से आता है तो काफ़ी टाइम लगता है.
Yeah, Samir.
So just one clarification. I think the question that came was probably for the voucher system or the
voucher system.
Yeah, so I think that is funded by the corporation.
Yeah, the voucher system is funded by your, but this machine is like new. This is separate. Yeah. This is from our own money.
So that voucher system is part and parcel of PPSA?
Yes, sir, and funded by MCGM. They give the money. So other state also can follow the. Yes, sir.
Yeah, it's a wonderful presentation and exciting. You have excited a lot of thoughts, I guess, ideas. I have one core question. Would you consider that the staff working under any PPSA would be able to reduce a considerable delay in the diagnosis, especially on HIV testing, diabetes, and X-ray?
Yes, sir, 100%. We have seen this.
So if you can give us some kind of a thought that this can become replicable for other PPSAs also, right? And it can be added into your procurement cost or tender, bid price. Is that feasible?
Yes, sir. In fact, we can get it done in Bihar only because WHP is giving 120 rupees for the private lab to get this HIV, and we are not paying a single rupees. We are just purchasing our that kit. The kit is, of course, costing I think 5 or 6 rupees per kit for HIV testing and diabetes का भी उसी type से है. हाँ बताओ.
Just wanted to interrupt here. So in Maharashtra, what we are doing in Mumbai, this is with the MDAX. So through the MDAX, we are getting the kits, and the MOU how we have with them is that on a monthly basis, after the positive line list is created, we have to share a monthly report with them. So this we are getting for free of cost with the MDAX. But similar such project we like in Assam also. We are purchasing the HIV kits and our staff is only doing the HIV testing, including the diabetes and the HIV. Both are done by the staff. So there is a training. In the first month, the whole of the training happens for the ground staff, wherein they are trained how to use this and how to report. Also, what happens is that whenever a patient is found to be HIV positive, he or she cannot directly tell it to the patient. There is a process which is followed.
Yes.
So there is a counselor, then an ART center.
Yeah. Get the point. Dr. Ravikant, my request would be, can you make a 2-pager on what you are going through and give it to the TB Learning Network and also to NTSU, so that it can be widely circulated to other PPSAs to ideate about it.
जी sir, बिल्कुल.
Right? So it can trigger much more innovation from each one of the PPSA to really.
And it's very cost effective also, sir. Very cost.
Hopefully, so.
Yes.
As it
Because once you purchase the kit in bulk, now it's actually very cheaper, less than 10 rupees per kit.
And this is a question to all the other PPSAs. Right now, a lot of your perhaps costing happens on the basis that there is a public sector that you need to really rely upon for CBNAT or X-ray and things like that. Is it possible in an area where you are bidding to know how many of your patients are likely to be in the public sector and how many you can get it optimized through the private sector and put it under the costing exercise, so that the patient gets a faster diagnosis rather than only relying upon the public sector and then you going through that supply chain issues in terms of cartridges not available, some other regions are not available. Is it possible for you to apportion certain proportion that this is, let's say 40% in the public sector, remaining 60% I want to do it through the private sector? If that can be thought through, right, then I am taking liberty from Dr. Rao to think about this, right? So also this is a food for thought.
Thank you.
I just want to add one comment here. So in the places where we are working, because the staff is trained to do that, like the HIV testing and the diabetes testing, as soon as the patient comes for the first visit, that is the time when he or she, or both the testing is done. So it kind of saves a lot of time.
Yes.
So that is very important for starting the TB treatment.
So, last comment from Dr. Malik.
Right, thank you so much, and really wonderful work, and it's a collaborative effort, as you mentioned, not just Doctors for You, but MSF and MCGM, and a number of partners are working in that hotspot of MDR TV in Mumbai, which is Govandi. You did mention about using chest X-ray as the starting point. It is definitely a good starting point because it's more sensitive than even your 2-symptom screening to identify, but it should follow. It should follow an algorithm to get you the quality diagnosis and then the cascade of diagnosis. I'm not saying cascade of TB treatment. In a pocket like Govandi, this may be true in some pockets in UP and Bihar and other places also where MDR is kind of coming up big time with you testing more and more individuals. A chest X-ray should be followed by a doctor's intervention, maybe an induced sputum if they don't have the symptoms. Get that sputum to NAT to get you at least RIF resistance levels, immediately followed by that to LPA as he mentioned, for which your specimen transportation is something that you need to kind of think through and leverage on. You are transporting specimens for diagnosis of TB. But the specimen also has to transport for diagnosis of FQ resistance or pre-XDR or XDR TB, which is more simpler because your specimens are already coming to the NAT sites. So that technician at the NAT site should know that as soon as your first specimen is throwing up an MTB detected, irrespective of whether it is resistant or susceptible to rifampicin, the second specimen has to go to the linked laboratory. And in a turnaround time, the 6 months is absolutely not acceptable that you mentioned about MP, which may be, not an average per se, it may be one odd case. But there is a table now given for turnaround times of each of the technologies from the time specimen is collected till the time patient is put on treatment. That has to be monitored, for every technology. The last point that you mentioned about, the dream of gene sequencing coming into picture, let me just alert you all. Some of the private practitioners have started prescribing gene sequencing tests and they are getting reports and patients are walking with those gene sequencing reports into the DRTB centers in the entire country, to the extent that one of such patient came to the difficult to treat TB clinic which the NITRD is organizing on a monthly basis. That okay, here I have a gene sequencing result, batao kaise treatment dena hai. All right, let me be clear on the strategic positioning of this technology across the world. This technology has been recommended for surveillance purposes for now. WHO headquarters, Geneva, has requested the world that whoever is doing research with gene sequencing and are trying to manage patient using these results, there needs to be studies and data of clinical correlation between these gene sequencing results and the actual patient management, which needs to be evaluated globally, which has not yet happened. The call is open for anybody who has this data of utilizing gene sequencing and correlating it with the treatment of the patients up to the treatment outcome and long-term follow-ups. Once this global meta-analysis is done and there is some global consensus, there will be guidance coming in on whether we can or we cannot use the gene sequencing technology as a decision-making tool for individual patient management. I hope I am clear and loud on this, right? So what is recommended currently, what the national program is following is that you do a NAT, of course following an X-ray and your sputum collection and induced sputum, whatever. And for children especially, you know, the pediatricians that you have in your network as hubs need to be made collection centers for pediatric specimen collection, which is difficult. And the medical colleges and the high-end tertiary institutions for collection of extrapulmonary specimen, which is also difficult. There is an SOP in place, but these needs to be stimulated and ignited to start doing those kind of functions, specialized functions also, so that people with extrapulmonary children where collecting a specimen is difficult, the network of PPSAs and the hubs that you have can be leveraged on. But after your NAT, you have either for now you have an LPA. Of course, the national experts are looking into the expert XDR and the other new technologies which are around the corner. But right now it is LPA. Okay, first line, second line LPA, for which there is a network of about 84 culture and DST laboratories, and every district knows where to send it. So your NAT sites also know where to send it. Please monitor that they send it, right, with the turnaround time. And follow the national guidelines for management. Thank you.
Yes, thank you, sir.
And one last point on the culture follow-ups, please. Do not miss out on the culture follow-ups. Thank you.
Christine?
Yeah, thanks. Just one quick comment. I want to thank you, Dr. Malik, so much for clarifying that. It's really important because there's not the clinical correlation yet with the gene sequencing. So we don't really want to jump the gun like that. I do want to say I like your innovative thinking, though, very much about the fact that we really need that DST and need it quickly and in a timely fashion so that people are not finishing their treatment and then getting the result or something like that.
Correct.
Other thing to think about is pyrosequencing, right? Which has been done clinically in other parts of the world and is rapid as well. But it is this, the lab logistics really need to be taken care of. So
Yeah.
I just wanted to support that statement. Thanks.
Thank you.
So thank you. I think this is really insightful, and I think lots of candid ask, and I think program is also kind of working on that. So I think this was really good, and I think lots of areas where we also now learning that the overall information asymmetry can be there. So as pointed out by Dr. Malik also, let's say we want to also see that how gene sequencing will go. Also the universal DSC definition is also getting changed. So I think we all need to be kind of on, and this kind of platform are really useful.
Thank you. Thank you.
Thank you so much. So it's actually now almost 2 o'clock, and my BMI doesn't allow that I go hungry beyond 2 o'clock. So as a moderator, I take a liberty that we actually go for a lunch break now, and Punjab presentation we will do after the lunch. So please, yes, 2:30 I think if. Okay, thank you so much for patient listening and active participation. Please reassemble at 2:30 sharp. Thank you so much.
Recording stopped.
वीडियो डाल देना सर। हाँ वीडियो नीचे वो कर रखी है चलानी है बस। प्रेजेंटेशन ही अपलोड करना है। हाँ क्लिक नहीं हो रहा है।
आसाने में क्यों अनकानी, ये सोच है तेरी पुरानी। भेदभाव की बीमारी कब तक रहेगी तुम्हारी, टीबी तो ठीक हो जाएगी तो रिश्तों को ना कर तू भारी।
अपनों का जोड़ है टीबी का तोड़, टीबी के इलाज में अपनों का साथ दे।
और भाई शुक्ला, तेरी टीबी के क्या हाल हैं?
अरे भाई 2-4 हफ्ते का इलाज करवाया और टीबी की हो गई हजामत।
ये लीजिए हुजूर, आपकी ये हजामत भी पूरी हो गई।
ये क्या आधी दाढ़ी? भाई कर क्या रहे हो?
कमाल करते हैं आप, आधी दाढ़ी मंजूर नहीं, टीबी का आधा अधूरा इलाज मंजूर है आपको। हाँ? याद रखिए, टीबी का आधा अधूरा इलाज करवाइएगा तो टीबी आपको दोबारा हो सकता है। इसलिए टीबी से मुक्ति पाने के लिए टीबी का पूरा इलाज करवाइए, फुल कोर्स। इंडिया वर्सेस टीबी, टीबी हारेगा, देश जीतेगा।
सिद्धार्थ से मिलने नहीं जाना?
नहीं जाना।
अरे पर क्यों नहीं जाना? तुम दोनों इतने दिनों के बाद मिलने वाले हो।
यार उसके साथ जाऊंगी तो सब क्या सोचेंगे? उसे टीबी है मंजू।
शारदा, टीबी तो इलाज से ठीक हो जाएगा, पर एक बार रिश्ता टूटा तो वो दोबारा नहीं जुड़ पाएगा। ऐसे में तो और भी ज्यादा जरूरी है कि तू उसका साथ दे।
अपनों का जोड़ है टीबी का तोड़, टीबी के इलाज में अपनों का साथ दे।
सरिता उम्र से पहले बड़ी हो गई है। किताबों से ज्यादा किताबों पर लगी धूल उसे नजर आने लगी है। घर की पूरी जिम्मेदारी उसने अपने नाजुक हाथों में ले ली है, क्योंकि सरिता की मां को टीबी है। न जाने कितने बच्चों का स्कूल छूट जाता है टीबी की वजह से। टीबी कोई ऐसी बीमारी नहीं है जिसे हराया ना जा सके। जरूरत है तो उसे पहचानने की और पूरे इलाज की। टीबी हारेगा, देश जीतेगा।
ओ भाई, ऊपर क्या कर रहे हो?
साहब ये तो और भी ऊपर चले गए थे।
क्या हुआ था?
हुआ तो टीबी था। इलाज के दौरान जब खांसी में कमी आई तो मैंने दवाई रोक दी। अब इसी कारण मैं डीआरटीबी का मरीज बन बैठा।
ये डीआरटीबी क्या होता है?
डीआरटीबी मतलब ड्रग रेसिस्टेंट टीबी। 6 से 8 महीने का उपचार अगर आप बीच में ही छोड़ दें तो कुछ दवा का असर होना बंद हो जाता है।
तो साहब क्या इसका पूरा का पूरा इलाज संभव है?
थोड़ा लंबा है लेकिन नामुमकिन नहीं है, और आधुनिक जांच और इलाज हर सरकारी स्वास्थ्य केंद्र में मुफ्त में उपलब्ध है। क्यों भाई?
बिल्कुल पैसा नहीं लगता।
टीबी हारेगा, देश जीतेगा।
नमस्ते, मैं हूं आसिफ और ये स्वाति है।
आज हम आपको बताएंगे कि टीबी सर्वाइवर और चैंपियन के रूप में कैसे हम ट्यूबरकुलोसिस से ग्रसित लोगों की मार्गदर्शन और सहायता कर रहे हैं,
और बताएंगे कि टीबी से ग्रसित लोगों को क्या करना चाहिए और क्या नहीं करना चाहिए।
चलिए हम गीता से शुरुआत करते हैं और बताते हैं कि उससे हमारी मुलाकात कैसे हुई। ये है गीता, हमारी तरह शक्ति नगर की निवासी। गीता बीमार है और 1 महीने से उसे लगातार खांसी हो रही है।
उसने पास के डॉक्टर को दिखाया, जिन्होंने उसे टीबी की जांच करवाने को कहा।
ये पता चलने पर कि उसे टीबी है, गीता को सदमा लगा। उसे चिंता होने लगी कि इलाज में ना जाने कितना खर्च होगा। डॉक्टर ने उसे नजदीकी सरकारी स्वास्थ्य केंद्र में विशेषज्ञ से मिलने की सलाह दी और गीता को भरोसा दिलाया कि इलाज मुफ्त है। सरकारी स्वास्थ्य केंद्र में डॉक्टर ने गीता को पूरे इलाज के बारे में समझाया और 6 महीने तक उसका पालन करने को कहा। डॉक्टर ने देखा कि गीता घबराई हुई थी और इसलिए उन्होंने गीता को मुझसे मिलने बोला। टीबी चैंपियन होने के नाते मैं टीबी के लक्षण वाले और टीबी से ग्रसित लोगों को सहयोग देती हूँ। मैं आपकी सहायता के लिए ही हूँ। मैंने गीता को समझाया कि टीबी एक ठीक हो जाने वाली बीमारी है और इस बीमारी से संबंधित उसके सारे सवालों के जवाब दिए। मैंने उसे इलाज के दौरान अपनी देखभाल के बारे में भी सब समझा दिया। 6 महीनों तक नियमित रूप से अपनी दवाइयाँ लेना, खांसते समय सावधानी बरतना और हाँ, उसे प्रोटीन युक्त पौष्टिक आहार लेने को भी कहा। सब समझ लेने के बाद भी गीता लंबे समय तक चलने वाले इलाज को लेकर काफी चिंतित थी और घर वाले क्या कहेंगे इससे घबरा रही थी। मैंने गीता के साथ उसके घर चलने की इच्छा जाहिर की। हालांकि हम अभी मिले थे, वो मुझे अपने परिवार से मिलने के लिए ले गई। गीता ने बड़े साहस से अपने घर वालों को टीबी होने के बारे में बताया। गीता की सास उसके और उसके छोटे बच्चे को लेकर चिंतित थी। मैंने उन्हें भरोसा दिलाया कि इलाज शुरू होने के कुछ ही हफ्तों में गीता से टीबी का संक्रमण नहीं होगा। मैंने गीता के HIV और डायबिटीज की जांच के बारे में भी बताया ताकि तसल्ली रहे कि वो ठीक है। मैंने उन्हें भरोसा दिलाया कि मैं हर कदम पर गीता की मदद करूंगी। बस अब उसके घर वालों को उसका साथ देना था। चिंतित होने के बावजूद गीता के परिवार वालों ने उसका सहयोग किया। गीता को किसी बात की चिंता करने की जरूरत नहीं थी।
कुछ और भी लोग थे जिन्हें इलाज के दौरान दूसरी तरह की परेशानियां हो रही थी, जैसे कि संजय। संजय शक्ति नगर के ही एक विद्यालय में पढ़ता था। उसे भी टीबी हुई थी, पर उसने दवाई लेनी बंद कर दी थी क्योंकि दवा लेने से उसे उल्टी होती थी। संजय दुखी था क्योंकि वो अपने दोस्तों के साथ खेलने नहीं जा पा रहा था। उसे घर पे ही रहना पड़ता था। मैंने संजय को समझाया कि उसे अपनी दवाइयां बंद नहीं करनी चाहिए। मैंने उसे बताया कि दवाओं के दुष्प्रभाव कुछ ही समय के लिए होते हैं। अगर ये दुष्प्रभाव होते रहे तो हम उसके डॉक्टर की सलाह ले सकते हैं। मैंने उसे समझाया कि मुझे भी ये दुष्प्रभाव हुए थे, लेकिन वो दुष्प्रभाव जल्दी ही खत्म हो गए और नियमित रूप से दवा लेने से मैं ठीक हो गया। मैंने उसे पौष्टिक आहार का महत्व समझाया और कहा कि अगर वो ठीक से खाए तो इनाम के रूप में वो बाहर जाकर खेल सकता है। संजय ने मेरी बातों का पालन किया। उसे फिर से भूख लगने लगी और धीरे धीरे उसका खोया हुआ वजन भी लौट आया। संजय के साथ और समय बिताते हुए हमारी अच्छी दोस्ती हो गई। मैंने उसकी सेहत बेहतर होते हुए देखी।
अब जब मैं बेहतर महसूस कर रहा हूँ, तो क्या मैं ये दवाइयाँ लेना बंद कर सकता हूँ? इनका स्वाद बहुत कड़वा है।
मैं समझ सकता हूँ कि दवाइयाँ कड़वी हैं, पर तुम्हारे शरीर के अंदर जो टीबी पैदा करने वाले कीटाणु हैं, उन्हें खत्म करना बहुत जरूरी है। उसके लिए तुम्हें डॉक्टर के परामर्श के अनुसार दवा लेना जारी रखना होगा।
और अगर मैंने बंद कर दिया तो?
जब तुम किसी दौड़ में भाग लेते हो तो जीतने के लिए हमेशा अंतिम रेखा तक दौड़ना पड़ता है। टीबी भी बिल्कुल वैसी ही है। अगर तुम दवाई लेना बीच में ही बंद कर दोगे तो जीवाणु और शक्तिशाली हो जाएंगे। ये दवा प्रतिरोधी टीबी भी बन सकता है, जिसका इलाज और ज्यादा कठिन है। पूरी तरह ठीक और तंदुरुस्त होने के लिए तुम्हें दवाई की एक भी खुराक छोड़े बिना दवाइयों का पूरा कोर्स खत्म करना होगा। क्या तुम ये कर सकते हो?
हाँ, मैं कर सकता हूँ। मैं हमेशा विजेता होना चाहता हूँ।
संजय आजकल अपनी दवाइयाँ नियमित रूप से ले रहा है और उसकी सेहत में सुधार आ रहा है। मैं खुश हूँ कि मैं टीबी चैंपियन के रूप में उसकी सहायता कर सका।
मुझे ये सुनिश्चित करना है कि गीता 2 महीने बाद डॉक्टर के पास अपनी जांच करवाने जाए। अब तुम कैसी हो गीता?
अब मेरी सेहत पहले से बेहतर है।
अरे वाह! लेकिन कल जाकर अपनी जांच करवाना मत भूलना। मैं तुम्हें कल वहीं मिलूंगी।
अरे हाँ, याद दिलाने के लिए धन्यवाद। तुम्हारे सहारे के बिना मुझे नहीं लगता मैं इलाज के इस चरण तक पहुंच पाती। मैं तुमसे कल मिलती हूँ।
गीता को टीबी का इलाज शुरू किए हुए अब 6 महीने हो चुके हैं। उसने अपने घर वालों की सहायता से डॉक्टर के सारे निर्देशों का पालन किया और उसकी टीबी ठीक हो गई। और इस तरह हम सुनिश्चित करना चाहते हैं कि किसी और को हमारी तरह कठिनाइयों का सामना ना करना पड़े। हमारा उद्देश्य है कि हम ज्यादा से ज्यादा टीबी से ग्रसित लोगों की सहायता करें और उनको भी टीबी चैंपियंस बनने में मदद करें।
हमने दूसरे टीबी चैंपियंस के साथ मिलकर देश के कई हिस्सों में नेटवर्क बनाए हैं, जिनका नेतृत्व हम जैसे टीबी चैंपियंस ही करते हैं।
टीबी हारेगा, देश जीतेगा।
क्या आप टीबी सर्वाइवर हैं? टीबी चैंपियंस बने और इस बीमारी से लड़ने में हमारी मदद करें।
वो देख, पवन आ गया। पवन वहाँ क्यों बैठा है? तुझे उसे टीबी है। और भाई, लास्ट बेंच का मजा अकेले अकेले।
पता है ना, मुझे टीबी है।
चल चल, तुझे पता है ना, इलाज का असर शुरू होने के बाद टीबी के इन्फेक्शन का डर नहीं रहता। टिफिन में क्या है? टीबी की दवाई के साथ खाना भी अच्छे से लेना है, समझा?
अपनों का जोड़ है टीबी का तोड़, तो फिर भेदभाव क्यों? टीबी के इलाज में अपनों का साथ दें।
नमस्ते, मेरा नाम सिया है। मैं 12 साल की हूँ और मैं स्कूल में पढ़ती हूँ। मेरे को पढ़ना पसंद है और अपने फ्रेंड्स के साथ खेलना और बातें करना पसंद है। मैं कहानियाँ पढ़ती हूँ, घर पर गेम्स खेलती हूँ। सबसे ज्यादा तो मुझे भूतों की कहानी सुनना पसंद है। बहुत दिन पहले छुट्टी में मैं अपने गांव गई थी। गांव में मैं अपने दादा और अपनी दादी के साथ रोज घूमने जाती थी और फिर वहां जाकर मैं बहुत बीमार हो गई। मेरे गले पर एक बड़ा गोला जैसा बन गया था। अप्पा और अम्मा काफी डर गए थे। फिर वो मुझे गांव में डॉक्टर अंकल के पास ले गए। पता है, डॉक्टर ने टेस्ट करने के बाद कहा कि मेरे को तो ट्यूबरकुलोसिस या टीबी हो गई है। अब पूछो कि टीबी क्या होती है? ये बीमारी बैक्टीरिया से होती है। बैक्टीरिया पता है ना, ये बहुत छोटे छोटे कीटाणु जैसे होते हैं। ये नजर भी नहीं आते। वैसे तो ये हमारे फेफड़ों पर हमला करती है, लेकिन इसके कारण हमारे शरीर के दूसरे हिस्से में भी इन्फेक्शन हो सकता है। पता है, मुझे तो टीबी एक भूत जैसी लगती थी, बहुत डराती थी। फिर ना मुझे डॉक्टर अंकल ने समझाया कि टीबी तो किसी को भी हो सकती है, लेकिन सबसे अच्छी बात तो ये है कि इसका पूरा इलाज हो सकता है। तब मैंने फैसला किया कि मुझे इस बीमारी से लड़ना ही होगा। इसके बाद 2 साल तक मेरा इलाज चला, क्योंकि ये वाली टीबी ना कुछ अलग तरह की थी। इतने दिन तक इलाज चलने के बाद भी मैंने तो सोच रखा था कि टीबी टीबी से लड़ती रहूंगी। इसकी दवा मुझे इतनी कड़वी लगती थी, फिर भी मुझे जूस के साथ ये दवा लेनी पड़ती थी। कभी कभी तो मुझे उल्टी भी होती थी, लेकिन फिर भी डॉक्टर अंकल कहते थे कि अगर मुझे ठीक होना है तो दवा लेनी ही पड़ेगी। मैं रोज अपनी टैबलेट खाती थी और बहुत सारा अच्छा खाना भी खाती थी। मैं रोती भी थी, लेकिन हमेशा नहीं, सिर्फ कभी कभी, क्योंकि मैं बहादुर और स्ट्रांग हूँ ना। इसके बाद फिर कुछ ही दिनों में मैंने टीबी को हरा दिया। मैंने देखा कि ये भूत तो खुद ही डर कर भाग गया। मुझे बड़ा मजा आया। याद रखें, टीबी किसी को भी हो सकती है, लेकिन अगर हम अपना ख्याल रखें तो इसके बैक्टीरिया को फैलने से रोक सकते हैं। आप सब लोग टीबी के लक्षण ध्यान से सुने और याद भी रखें। आपको बहुत सारी खांसी होगी जो 2 हफ्तों के बाद भी ठीक नहीं होती। सीने में दर्द होगा, खांसी या बलगम में खून निकलेगा। इसके अलावा अगर खूब ठंड लगे, रात को पसीना आए, भूख ना लगे या बुखार आए और कमजोरी जैसे लगने लगे, तो समझ जाना कि कुछ तो गड़बड़ है और तुरंत डॉक्टर अंकल के पास जाना। याद रखें कि आप भी टीबी को रोक सकते हैं। हमेशा मुंह ढककर खांसें, और यदि आपको टीबी के लक्षण दिखाई दें तो तुरंत ही टीबी की जांच करवाएं। टीबी की जांच एवं इलाज सरकारी अस्पतालों और कुछ निजी अस्पतालों में मुफ्त में करी जाती है। टीबी का इलाज पूरा करना जरूरी है। और हाँ, एक बात और, किसी भी टीबी मरीज के साथ भेदभाव कभी नहीं करना, क्योंकि उन्हें भी तो प्यार और देखभाल की जरूरत होती है। टीबी का इलाज हो सकता है। आप इस बीमारी को हरा सकते हैं, जैसे मैंने हरा दिया। अच्छा, चलती हूँ, होमवर्क का टाइम हो गया। बाय।
2020 में मुझे पता चला कि मुझे टीबी है। पहले मुझे पता चला तो मैं डर गई थी, फिर हमारे गांव में बैठक हुई, बताया गया तो मैं इलाज के लिए तैयार हो गई। एक टीबी रोगी को बहुत संघर्ष करना पड़ता है। मैं बहुत भाग्यशाली हूँ कि मेरे साथ किसी भी तरीके का भेदभाव नहीं हुआ।
मैं आशा कार्यकर्ता भी हूँ और एक टीबी चैंपियन भी हूँ। मैं अपने फील्ड में जाकर टीबी के बारे में लोगों को बताती हूँ, प्रचार प्रसार करती हूँ और महिलाओं से मिलती हूँ। अब क्योंकि मैं एक महिला हूँ, मैं समझ सकती हूँ कि ये एक संक्रामक बीमारी है। महिलाएं इस विषय में बहुत जो है झिझक उनको आती है बताने में। सरकार द्वारा जो हमें सामग्री दी जाती है, जैसे पम्फलेट है और पोस्टर है, बैनर हैं आदि, बहुत सी चीज़ें मिलकर उनको दिखाते हैं, बताते हैं कि देखिए ये सब चीज़ ऐसे ठीक हो जाएगी बीमारी। उनको लेके जांच के लिए बताती हूँ, मुफ्त इलाज के लिए बताती हूँ, जांचें भी सब फ्री होती हैं। ये सब अपने क्षेत्र में मैं जाके लोगों को बताती हूँ।
महिलाएं कई स्तरों पर प्रभावित होती हैं, विशेषकर ग्रामीण इलाकों में भेदभाव का उन्हें ज़्यादा सामना करना पड़ता है। मेरे गांव में सन 2020-21 में टीबी से संबंधित 4-5 मामले सामने आए। एक सामुदायिक जनप्रतिनिधि होने के नाते मैंने यह जिम्मेदारी सुनिश्चित की कि टीबी के खिलाफ महिलाओं की इस जंग में हर संभव जानकारी उपलब्ध कराई जा सके। इसलिए मैं स्वास्थ्य विभाग के साथ मिलकर यह कार्य कर रही हूँ, जिससे महिलाओं को सही उपचार नेटवर्क, प्रोटोकॉल और उपलब्ध सेवाओं के बारे में पता चल सके।
सबसे पहले तो उनको घर वाले अभी भी ऐसा है कि बेटियों को प्रमोट नहीं करते हैं कि वो जांच कराएं, कहीं टीबी ना निकल आए। और कई बार ये देखा जाता है कि लड़कियां जिनके जो अभी शादी नहीं हुई है, उनकी शादी होने वाली है, तो वो खासतौर से बहुत डर जाते हैं कहीं शादी ना टूट जाए। आशा वर्कर्स को खासतौर से ध्यान पे बुलाया जाता है, को समझाया जाता है कि वो अपनी महिला समाज में खांसी को और बुखार को चिन्हित करें और उनको स्क्रीनिंग के लिए लाएं।
मैं तभी अपने बोर्ड एग्जाम्स दे रही थी और मुझे कॉफ हुआ था। आफ्टर अ पीरियड ऑफ टाइम एक्सरे करवाया और तब पता चला कि टीबी है। डॉक्टर्स ने कहा कि आई हैव अदर फॉर्म ऑफ टीबी कि 1% चांस है सर्वाइवल के। सो आई जस्ट टोल्ड माई पेरेंट्स डोंट वरी, आई विल बी राइट बैक विथ यू। टीबी हैज टॉट मी अ लॉट, इट हैज मेड मी ब्रेव।
सांक्रमिक टीबी अगर परिवार में किसी एक सदस्य को हो तो बाकी सभी सदस्यों और खासकर बच्चों को इसके होने की आशंका बढ़ जाती है, जैसे कि सुजीत और उसके परिवार में भी हुआ। आइए जानते हैं उनकी कहानी।
और सुजीत कैसे हो?
बस बढ़िया सर। ये एक्चुअली एक बात पूछना था, जैसे डॉक्टर साहब ने टीबी का रिकॉर्ड किए हैं, ये पूरी तरीके से सही हो जाएगा?
टीबी का इलाज पूरा अवेलेबल है, ये ठीक होने वाली बीमारी है, इसमें घबराने की कोई बात नहीं है। ठीक है, सारी दवाइयाँ हमारे पास फ्री अवेलेबल हैं, सारी जांचें फ्री अवेलेबल हैं। आपको सिर्फ इतना करना है, जैसा हम बताएं आपने वैसे दवाई खानी है। बलगम अगर आपको आती है तो आपने जाके बाथरूम में थूकना, ऊपर से पानी डाल देना है, और जब भी जो है छींकते और खांसते मुंह पे कपड़ा लगा के रखना है।
सर ये परिवार में तो कोई दिक्कत नहीं होगा ना?
सुजीत घर में किसी को दिक्कत नहीं होगी। बाकी हम आपके घर पे आएंगे, आपके घर पे आपके फैमिली वालों को समझाएंगे किस तरह से आपके साथ वो रहेंगे। ठीक है, और घर में किसी और को दिक्कत होगी तो उसकी हम देखेंगे। जैसे स्पेशली आपके घर में छोटे बच्चे हैं तो हमने उन छोटे बच्चों को जरूर देखना है कि उनमें किसी को दिक्कत तो नहीं है।
सर जैसे आप आओगे, आस पड़ोस में लोग होंगे, मैं भी शायद ना मिलूं।
सुजीत नहीं, घबराने की कोई बात नहीं है। अड़ोसी पड़ोसी रहें चाहे ना रहें, हम आराम से आएंगे, किसी को पता ही नहीं लगेगा, फैमिली मेंबर की तरह आएंगे। और आप चाहे ना भी मिलो तो आपके घर पे जो आपकी मिसेज मिलेंगी और उन बच्चों से मिलकर उनको बात कर कर आप उनको समझा के हम वापस आ जाएंगे। कल सुजीत जी आए थे, आपको पता उन्हें क्या परेशानी है?
हाँ, उनको टीबी हो गया है।
आपको तो कोई तकलीफ नहीं है ना?
नहीं, मुझे कोई तकलीफ नहीं है।
आपके घर में और कितने मेंबर हैं आपके अलावा?
हाँ, मैं हूँ, सुजीत है, और ये 4 साल के है और एक 5 साल के है, अभी है नहीं, खेलने गई है वो।
बच्चों को तो कोई प्रॉब्लम नहीं है ना?
नहीं, बच्चों का तो नहीं है, लेकिन इसका थोड़ा खाना पीना थोड़ा कम हो गया पहले से।
नहीं, सिम्टम ऐसे के बच्चों में जो है, अगर पल्मोनरी टीबी है तो खांसी और बुखार से पता लग सकता है। अगर पल्मोनरी टीबी नहीं है तो उसके लिए डॉक्टर के पास जाना पड़ेगा।
सुप्रभा अपने बच्चों को लेकर आज मेरे पास आई थी। वो बहुत चिंतित थी। पिछले कुछ दिनों से उसने देखा कि उसकी छोटी बेटी प्रियांजलि बहुत थकी सी रहती है, चिड़चिड़ी हो गई है, खाना कम खाती है और उसका वजन भी कुछ कम हो रहा है। इस वजह से उसको वो हमारे पास लेके आई। मुझे एक बात कहनी बहुत ज़रूरी है कि जब भी किसी परिवार में किसी को छाती की टीबी, लंग्स की टीबी होती है जो कि इन्फेक्शियस है, तो उस परिवार के सब लोगों में ये पता करना कि किसी को टीबी के लक्षण तो नहीं है बहुत ज़रूरी होता है, क्योंकि एक सांक्रमिक रोग है और एक से दूसरे को लग सकता है।
और जो इससे बड़ी है थोड़ा 5 साल के, उसको तो है नहीं कुछ सिम्टम वगैरह।
कई बार ऐसा होता है कि अभी आपको टीबी के सिम्टम नहीं लग रहे, लेकिन महीने 2 महीने बाद वो सिम्टम डेवलप हो जाएंगे, तो उसके लिए आपको डॉक्टर दिखाना पड़ेगा।
ठीक है जी।
सुप्रभा अपने साथ एक और बच्चे को लेके आई थी जो कि प्रियांजलि की 5 साल की बहन है, शशि। शशि को किसी भी तरह की कोई तकलीफ नहीं थी, वो ठीक से खा पी रही है, उसको कोई बुखार खांसी कुछ भी नहीं है। और जब हमने उसको पूरी तरह से चेक किया, वो संपूर्ण रूप से हृष्ट पुष्ट थी, उसको कोई बीमारी के कोई लक्षण नहीं थे। तो मैंने सुप्रभा को बताया कि हमको शशि को भी कुछ दवाई देनी पड़ेगी। इस संदर्भ में ये समझना बहुत ज़रूरी है, जो छोटे बच्चे 6 साल से कम उम्र के किसी भी संक्रमित टीबी के मरीज के साथ रहते हैं, खासकर घर में, जैसे यहाँ उनके पिता को टीबी थी, तो उनको ये संक्रमण लगने का एक बहुत बड़ा चांस होता है। हर बच्चा जिसको ये संक्रमण, या बड़ा जिसको ये संक्रमण लगता है, उसको ये ज़रूरी नहीं है कि बीमारी हो। तो मैंने सुप्रभा को समझाया कि हमें शशि को आईएनएच की दवाई 6 महीने तक देनी पड़ेगी। क्योंकि ये एक अकेली दवाई है, ये काफ़ी सेफ है, इससे साइड इफ़ेक्ट्स नहीं होते और बच्चे इसको आराम से ले पाते हैं। और 6 महीने तक इसको लेने के बाद कम से कम इस संक्रमण से टीबी की बीमारी बनने के चांसेस ऑलमोस्ट ख़त्म हो जाते हैं।
इस प्रोसेस को हम कॉन्टैक्ट ट्रेसिंग कहते हैं। स्पेशली जिस घर में टीबी फैलाने वाली टीबी जिसको होती है, उस घर में हम 6 साल से छोटे बच्चे का, कितने भी 6 साल से छोटे बच्चे, सबकी हम जांच करानी अनिवार्य है। और उसमें जांच कराने के बाद अगर किसी को टीबी निकलती है बच्चे को, तो हम उसकी टीबी की दवाई शुरू कर देते हैं। अगर टीबी नहीं भी निकलती है तो हम उसे प्रिवेंटिव थेरेपी देते हैं।
इस बार मिले थे, कल मिले थे।
अरे यार फिर पिट गया। बिल देना। इसको आउटसाइड द ऑफ टाइम डालना चाहिए था। इसकी यही प्रॉब्लम है।
कब से?
जब से क्रिकेट खेल रहा है तभी से।
अरे भाई साहब, क्रिकेट की नहीं हो, आपकी खांसी की बात कर रहे हैं बुड़बक।
खांसी? हाँ। इसको तो 1 महीना हो गया।
खुद की खांसी को 1 महीने हो गए हैं और यहाँ क्रिकेट पर अपने ही गुगली फेंक रहे हैं आप। चलिए चलिए चलिए।
डॉक्टर, खांसी तो है।
देखिए भाई साहब, इसे हल्का मत लीजिए। 2 हफ्ते से ज्यादा अगर आपको खांसी रहे तो टीबी हो सकता है।
टीबी?
हाँ, तुरंत डॉक्टर से मिलिए और बलगम की जांच कराइए।
ठीक है।
टीबी किसी को भी हो सकता है। अगर हो गया तो बिना भूले पूरा कोर्स करिए और फिट हो जाइए। नहीं किया तो इसका इलाज बहुत मुश्किल है। समझ गए भाई साहब आप? आइए। 2 हफ्ते से ज्यादा खांसी, तुरंत डॉक्टर से मिलिए और बलगम की जांच कराइए। टीबी हारेगा, देश जीतेगा।
खांसी 1, खांसी 2, खांसी 3, बच गई भैया देश की बीन। टीबी के कारण को जानो, खांसी हो तो मुंह ढककर खांसो। टीबी रोग हवा में फैले, रखो अपना औरों का ध्यान। घर में धूप रोशनी हवा मिले तो कीटाणु सब मर जाएंगे, रोग मुक्त हम हो जाएंगे। खांसी खो खांसी, बलगम में है भरे कीटाणु, रख कागज में इसे जला दो या डाल राख में इसे दबा दो, रहे न टीबी नाम मिटा दो। खांसी खो खांसी, टीबी मुक्त भारत बनाए, खुद भी बचे देश भी बचाएं।
टीबी हारेगा, देश जीतेगा।
अरे क्या हुआ चाचा, आज काम करते वक्त गाना नहीं गुनगुना रहे हैं आप?
क्या गाएं, क्या गुनगुनाएं भैया।
क्यों, क्या हुआ? बैठिए।
छोटे भाई को टीबी हो गई है।
हर सरकारी स्वास्थ्य केंद्र में टीबी का जांच और उसके इलाज दोनों ही मुफ्त में उपलब्ध है।
पर चिंता तो अन्य खर्चों की है।
RNTCP नोटिफाइड जितने भी टीबी मरीज हैं ना, सरकार उन्हें आर्थिक सहायता उपलब्ध करा रही है। इलाज की समाप्ति तक सरकार हर टीबी मरीज के बैंक अकाउंट में हर महीने 500 रुपए दिया करेगी। इससे सही पोषण और अन्य खर्च दोनों में सहायता मिलेगी।
ये तो टीबी के मरीजों के लिए बहुत बड़ी राहत है।
बस ऐसे ही गाना गुनगुनाते रहिए चाचा।
टीबी हारेगा, देश जीतेगा।
सोनू के घर पे चाय के कप से ज्यादा इनाम में जीते हुए कप है। घर का हर एक कोना गवाह है उसकी काबिलियत का, उसके जुनून का और शायद उसके इरादों पर लगने वाली उस धूल का। क्योंकि सोनू के पिताजी को टीबी है। न जाने कितने बच्चों के सपने टूट जाते हैं टीबी की वजह से। टीबी ऐसी बीमारी नहीं है जिसे हराया ना जा सके। जरूरत है इसे पहचानने की और पूरे इलाज की। टीबी हारेगा, देश जीतेगा।
अरे सुनिए भाई साहब, जरा गाड़ी चेक कर लीजिए प्लीज, कई हफ्तों से आवाज कर रही है।
हाँ अभी देख लेते हैं। मुन्ना मैकेनिक हाथ लगाते ही बता देता है गाड़ी का हाजमा। आप बैठिए। आपकी गाड़ी को टीबी हो गया है, ट्यूबरकुलोसिस।
क्या कमाल की बात कर रहे हैं भाई साहब, गाड़ी को भी कभी टीबी हो सकता है क्या?
इतना जानते हैं कि गाड़ी को टीबी नहीं होता है, लेकिन ये नहीं जानते कि कोई भी इंसान अगर 2 हफ्ते से ज्यादा खांस रहा है तो ये टीबी के लक्षण हो सकते हैं। इसलिए मैं कह रहा हूँ, याद रखिए, 2 हफ्ते से ज्यादा अगर आपको खांसी हो, बुखार हो, पसीना आ रहा हो, अचानक वजन कम हो जाए तो ये सब के सब टीबी के लक्षण हो सकते हैं। इसकी जांच करवाइए और सरकारी स्वास्थ्य केंद्र में जांच मुफ्त है, एकदम फ्री। इंडिया वर्सेस टीबी, टीबी हारेगा, देश जीतेगा।
Sometimes the truth can be hard to face.
पता चलेगा ना टीबी है, दोस्ती बुद्धि सब जाते हैं भूल।
But speaking out gives us the power to fight. 2019, MTV Staying Alive Foundation partnered with Johnson & Johnson to bring change around this issue with MTV निषेध।
जितना ज्यादा इग्नोर करेंगे ना, उतना ज्यादा रिस्क बढ़ेगा, आपके लिए भी और आपके आसपास के लोगों के लिए भी।
टीबी ना हवा से फैलता है, केक से नहीं।
पर ये ठीक हो सकता है। यू कैन विन।
आई विल डॉक्टर।
With the 15-part radio series, The Radio Show with Megha on Red FM. A 13-part TV series, MTV Nishedh on Root, Colors Rishte and MTV India with Bollywood star Bhumi Pednekar on board as ambassador.
ये बदलाव लाना बहुत ही जरूरी है और ये बदलाव तभी होगा जब हम इन चीजों के बारे में बात करना शुरू करेंगे।
We reached millions. Spoke about issues.
टीबी को कलंक ना बनने दें, इसके बारे में खुल के बात करें।
We learned about issues.
खुशी है कि मैं इस MTV निषेध पीयर एजुकेटर की भूमिका पे रह करके युवाओं के साथ मैंने काम किया।
खुद को भी और दूसरों को भी जितना हो सके पॉजिटिव करना चाहिए, नकारात्मकता हटा देनी चाहिए।
We found that we are less alone than we think. Even during COVID-19, we didn't stop. We made the conversation more relevant than before with MTV Nishedh Alone Together.
यार मेरा जो टीबी है ना, वो MDR टीबी है, हाई रिस्क है कोविड का।
Along with tennis star Sania Mirza making her acting debut.
पर उनको आइसोलेटेड अकेले ना छोड़ें, क्योंकि उन्हें आपकी ज़रूरत पहले से कहीं ज़्यादा है।
Together, we take one step closer to eradicating TB forever.
अरे यार, मैंने तुमसे कहा था रजनीगंधा लगाओ, कहाँ गेंदा लगा चले तुम?
अभी लगा देता हूँ साहब।
और ओ भाई, ऊपर क्या कर रहे हो?
साहब ये तो और भी ऊपर चले गए थे।
ऊपर चले गए थे मतलब क्या हुआ था?
हुआ तो टीबी था। इलाज के दौरान जब खांसी में कमी आई तो मैंने दवाई रोक दी। अब इसी कारण मैं डीआरटीबी का मरीज बन बैठा।
अरे
डीआरटीबी? ये डीआरटीबी क्या होता है?
डीआरटीबी मतलब ड्रग रेसिस्टेंट टीबी। 6 से 8 महीने का उपचार अगर आप बीच में ही छोड़ दें तो कुछ दवा का असर होना बंद हो जाता है।
तो साहब क्या इसका पूरा का पूरा इलाज संभव है?
हाँ हाँ, पूरा का पूरा इलाज है। थोड़ा लंबा है लेकिन नामुमकिन नहीं है। और आधुनिक जांच और इलाज हर सरकारी स्वास्थ्य केंद्र में मुफ्त में उपलब्ध है। क्यों भाई?
बिल्कुल पैसा नहीं लगता। मैंने इस बार डीआरटीबी का इलाज पूरी गंभीरता के साथ करवाया है।
गंभीरता से इलाज करवाया है तभी ऊपर है?
पहले आपने में डालिए उसको डालिए।
जब से माँ को नानी के यहाँ भेजा, कितने चिड़चिड़े हो गए हो।
बेटा टीबी है उसको।
टीबी का इलाज तो यहाँ भी हो सकता है, फिर क्यों भेज दिया?
अगर वो यहाँ रहती ना तो लोग कन्नी काट रहे होते हमसे।
मुझे लोग नहीं, मम्मी।
अरे क्या अर्जुन, उठेगा तो सरप्राइज देंगे। हाँ?
अर्जुन,
बहुत मिस कर रहा था तुमको। और मैं भी टीवी रिमोट का सर पर समझ नहीं पा रहा था।
अपनों का जोड़ है टीबी का तोड़, तो फिर भेदभाव क्यों? टीबी के इलाज में अपनों का साथ दें।
बचपन से ही ना मुझे हारने का शौक था। कभी अपनी बहन से, ताकि उसकी वो खरगोश वाली हंसी देख सकूं। कभी अपने पापा से, ताकि उनका बचपन फिर से लौट आए। और अपनी पत्नी से तो मानो रोज का ही है। अपनों से हार जाने में ना एक अलग ही जीत महसूस होती है, लेकिन उन्हीं अपनों के लिए जीतना और भी बड़ी बात है। मुझे HIV है और मैं HIV से लड़ूंगा।
HIV संक्रमित मरीजों को टीबी की जांच जरूर करवानी चाहिए, ताकि HIV की लड़ाई में टीबी आपकी हार का कारण न बने।
हौसला नया भर लिया है, फैसला ये कर लिया है। टीबी से सबको बचाएंगे, खुद से ये वादा कर लिया है। इंडिया जब जोर लगाएगा, टीबी हारेगा, देश जीतेगा। इंडिया जब जोर लगाएगा, टीबी हारेगा, देश जीतेगा।
आज ही सब लेते हैं एक संकल्प, भारत को टीबी मुक्त बनाने का। तभी तो टीबी हारेगा, देश जीतेगा।
टीबी हारेगा, देश जीतेगा।
अरे हिंदू को हलाल से क्या दुश्मन प्रॉब्लम है? कुछ प्रॉब्लम नहीं है। जाग उठा हिंदू सारा।
आपके बलगम की जांच और एक्सरे रिपोर्ट के अनुसार आपको टीबी है। टीबी का पूरा इलाज है। बस 6 से 8 महीने का कोर्स बिना रुके पूरा कीजिए। 2 महीने के सघन इलाज के बाद आप अपने बलगम की जांच दोबारा कराना ना भूलें। मैं आपके केस के बारे में RNTCP को सूचित कर देता हूँ। याद रखिए, टीबी के मरीज के उपचार की सूचना RNTCP को देना अति आवश्यक है। ये टीबी की लड़ाई का एक जरूरी हिस्सा है। एक छोटा सा प्रयास लेकिन बहुत बड़ा कदम भारत को टीबी मुक्त बनाने के लिए। क्या हम इतना भी सहयोग नहीं कर सकते? नोटिफाई जरूर करें। ये लीजिए चाचा। अरे राजेश भाई, दीपक, बहुत दिनों बाद दिख रहे हो तुम। हाँ, और बताओ।
बस मेरी बेटी का कल जन्मदिन है और आपको आना होगा।
हाँ, क्यों नहीं भाई, नेकी और पूछ।
और सूरज भाई, आपको तो निमंत्रण मिल ही चुका है। चलो चलता।
अरे राजेश भैया, आप उससे हाथ क्यों मिला रहे थे? उसे पिछले महीने से टीबी है।
2 हफ्ते तक लगातार दवा खाओ ना तो टीबी फैलने का खतरा तो बिल्कुल ही खत्म हो जाता है। और रही बात हाथ मिलाने की, गले मिलने की, शौचालय इस्तेमाल करने की, बर्तन खाना बांटने की, उससे टीबी नहीं फैलता।
हेलो सर। सर, वो असिस्टेंट मैनेजर वाला पोस्ट आप मुझे दे दीजिए ना सर।
असिस्टेंट मैनेजर? अक्रम तो ऑलरेडी है विवेक।
अरे कैसी बातें कर रहे हैं सर? सर, अक्रम का तो टीबी का इलाज चल रहा है ना, तो फिर आप उसे वापस काम पे थोड़ी रखोगे।
जब टीबी का इलाज चल रहा है तो इन्फेक्शन का डर कैसा? अरे अक्रम, कैसी तबीयत है? ठीक है सर। लिसन, डोंट वरी। हाँ, तुम जब ठीक हो जाओ तब आराम से वापस ज्वाइन कर लो। तुम खाना ठीक से खा रहे हो ना? जी। सुना है जरूरी। सिट डाउन। ये लो, अंडा करी लाओ।
अरे अंडा करी? सर, ये तो मेरा भी फेवरेट है, दीजिए ना। अरे लो ना।
अपनों का जोड़ है टीबी का तोड़। टीबी के इलाज में अपनों का साथ दें।
आया गया?
नहीं पापा।
चाची, कब से खांसी है इनको?
महीने भर से होगी।
टीवी तो चल जाएगा लेकिन टीबी का क्या? 2 हफ्ते से ज्यादा अगर खांसी हो ना तो अपने बलगम की जांच स्वास्थ्य केंद्र में करवाइए। हो सकता है आपको टीबी हो।
टीबी? और हमको?
किसी को भी हो सकती है, लेकिन 6-8 महीने का इलाज है बस। अगर दवा बीच में रोक दी तो टीबी बिगड़ भी सकती है।
बहुत पैसा लग जाएगा।
देश के हर सरकारी स्वास्थ्य केंद्र में इसके इलाज और जांच दोनों मुफ्त होती है। आया क्या?
आ गया।
टीबी हारेगा, देश जीतेगा।
कल भी नहीं आएगा, परसों भी नहीं आएगा, थर्सडे को आएगा।
ले जाएगा ना तुम्हें पिक्चर? चलो बैठो बैठो। बढ़िया। फर्स्ट डे फर्स्ट शो। ऑनलाइन बुकिंग भी नहीं किया है। पूरे टाइम लाइन में धूप में खड़े थे। और पता कितना टाइम?
कितना टाइम?
अरे पूरे 2 घंटे।
अरे तुम्हारे टाइम के बारे में नहीं पूछ रहे हैं बुड़बक, इनके खांसी के बारे में पूछ रहा है।
खांसी? ये तो 2 हफ्तों से हो रही है।
2 हफ्ते? पिक्चर ले जाते हैं फर्स्ट डे फर्स्ट शो और खांसी को हो गए 2 हफ्ते। ये तो बहुत केयरलेस है। चलिए हमारे साथ।
डॉक्टर? अरे आप तो बड़े सीरियस हो गए।
और नहीं तो क्या, 2 हफ्ते से ज्यादा अगर आपको खांसी होगा तो टीबी हो सकता है।
टीबी?
हाँ, तुरंत डॉक्टर से मिलिए और बलगम की जांच कराइए, क्योंकि टीबी जो है
वो किसी को भी हो सकता
है। और अगर हो गया तो बिना भूले पूरा कोर्स करिए और उसके बाद बेफिक्र हो जाइए। और नहीं किया ना तो इसका इलाज करना बहुत मुश्किल हो जाएगा मेरे हीरो हीरा लाल।
चलो।
2 हफ्तों से ज्यादा खांसी, तुरंत डॉक्टर से मिलिए और बलगम की जांच।
Good afternoon.
Recording in progress.
Welcome back. Requesting all participants to take their seat, please. We will start the session ASAP. ये बंद करवा दो ना दरवाजा। नहीं दरवाजा ही बंद कर दो। वो रह गया कोई issue नहीं। लोगों का यार थोड़ा इंटरनल थोड़ा बातें करना है तो कोई नहीं।
मेरे क्वेश्चनर्स का कर रहे अदरवाइज वो आएगा नहीं। ये जो स्कैन करके क्वेश्चनर्स वाला अनाउंस कर तो दिया था वो तो कहाँ थी अच्छा मैं
हो गया
अच्छा
डॉक्टर नीरज ने बोल दिया, डॉक्टर सदेवा सर ने बोल दिया, लोगों ने थोड़ा कर भी रहे थे।
अगर चाहे तो अनाउंस कर देंगे दोबारा कि ही डिडंट टेल कि कभी भी कर सकते हैं। मे बी दे आर एक्सपेक्टिंग कि टाइम मिलेगा हमें।
स्टाफ को बंद कर देने के लिए स्टाफ है इधर, दरवाज़ा बंद ही कर दो। Okay, good afternoon. In the interest of time, we'll be starting the session now. So, now, दरवाज़ा बंद ही कर देते हैं. That will be good. Excellent, thank you. So, we'll continue with the session 1, and in that we have a presentation from Mr. Sukhwinder Singh from World Health Partners, who will share the experience from the PPSA experience from the Punjab. So, welcome, Dr. Sukhwinder. Over to you. Yeah, we are now good to start. Jury members are also here. Please.
Good afternoon, all of you. Yeah. Good afternoon, all of you. I am Sukhwinder Singh, project lead, working with World Health Partner and looking for PPSA project in Punjab. So, yeah, I am audible. Dr. Vaibhav, yes. So, today I will present about the PPSA project which we are implementing in Punjab. So, starting with World Health Partner. So, we were established in 2008 as a non-profit organization, and we are working with different government and private donors
on different health related projects. And for TB, we have long experience of different TB projects. We have successfully completed many projects in past, and currently we are also working on some projects with the help of private organizations and government agencies.
Somebody has started the presentation.
Loud. Okay. Thank you. So, thank you, Neeraj. So today I will talk about the PPSA project which we are implementing 2 districts of Punjab, Amritsar and Patiala. So our project was started from 1st April 2021, and we are covering these 2 districts, nearly 48 lakh population we are covering here, with the objective to improve the TB case notification, and we are also providing the free diagnostic services to the private sector providers and to the patients. We are following the key activities for the successful implementation of PPSA, as we are covering all type of private provider in the districts for TB notification, and we are also providing the sputum free sputum transportation services to the provider. We don't have any setup of private UDST labs. We are offering the government services to all the providers here, and yes, we are ensuring the HIV, diabetes and UDST of all notified patients, and with the help of, we are also supporting the government for the updation in DBT. And FDC is really very important. We will discuss more about in the later slides that in private sector FDC is really helping us to keep the patients on treatment, and it is really helping the private provider for a good repo in the society. And for all the notified patients within district, we are doing the counseling. We are giving the counseling services through home visit, and for out of district patient, we are regularly following them through the telephone, and we are also meeting them when they visit to the concerned facility, and we are following the patient till the treatment continues. As you know, in private sector, the treatment goes up to more than 1 year. So we are following all the patients, and we are regularly updating all the outcomes on the NICSHA. So here I'm presenting the baseline data. This is the data of March 2021 when we were not here. So as you can see, at that time, nearly 375 providers were registered on NICSHA in both the districts, and nearly 15 chemists and less than 50 labs were engaged in both the districts. So as you see the key indicators in both the districts, so nearly below than the 30% TB notification target was achieved by both the districts at that time, and for DBT and UDST it was below than the 30%, and for HIV and diabetes and successful outcome, the patients were being followed up the district team. So this is the current data. So you can see on the upper side in the graph, so now we have engaged nearly about 900 providers in both the districts, and we have in which we are getting the active notification from more than 225 providers. Active notification means the provider who at least give 1 notification in the last quarter. And we have, you can also see in the graph that now we have more than 200 chemists and labs which are engaged with the NTP program in both the districts. And here I also want to show the involvement of informal provider. Like before our intervention, there were no informal provider engaged with the program in both the districts. So now you can see we have engaged nearly 180 provider in both the districts, and they are actively referring us the TB patients. And if you will see the data from April 21 to June 22, so we got nearly 1,000 notifications from these informal providers, which we got through the referral system. We refer the patient to the nearby formal provider, and then we updated their notification. So the role of informal provider is very important, as you can see in our slide. So these are the key indicators. Like you can see, after our intervention, this is data from April 2021 to June 22. We have achieved more than 100% TB notification in both the districts, and our DBT and HIV diabetes details are also more than 90%. UDST was low at that period because state don't have the CBNet cartridges for more than 10 months, but now this issue has been resolved, and I'm happy to share in the last quarter we have achieved our UDST target. This is really very interesting data of notification trend in private sector in last 3 years. As you can see in the 2020, in private sector, both the district have achieved nearly 1,300 notification, but in 2021, you can see we have achieved nearly 4,000 notification, which is 3 times higher than the previous year. And you can also see the data of 22, which shows that we have achieved nearly 3,000 notification within 6 months. And this data also shows that in private sector, from Jan to June, the total notification of private sector of Punjab was nearly 6,500, in which these two districts have contributed nearly about 45% notification. So we are supporting the state to achieve the target, and hopefully we will get, in 2022, we will get more than 6,000 notification from these two districts. This is the private sector outcome data. We have taken the period of April 2021 to September 2021, in which we have given successful outcome to 76% patient, and we have the LFU and treatment regimen change less than 1%, and currently our 13% patient are on treatment, and hopefully we will get the more than 90% successful outcome for this period. So I want to share the involvement of lab, chemist and informal provider in PPSA project Punjab, because these are the key champions for our notification trend in Punjab. Earlier, as per the previously data you can see, earlier there were only less than 80 labs and chemists were engaged with the program. But when we started our intervention, I would really like to thank our district team and state team for giving us the opportunity, and the DTOs of both the district have issued the support letter to all the organization to give the regular TB notification to the PPSA team. As you can see, DTO Amritsar has written letter to all organizations, including chemists, Ayush, labs, IMA, NEMA. So they started giving us the notification, and we have also coordinated with the zonal licensing authorities so that we can get the notification and H1 schedule register detail from the chemist also. So now the drug controller of both the district Amritsar and Patiala are regularly sharing the TB notification detail with DTO and PPSA team. So, and as the result of this intervention, from the April 21 to June 22, we got more than 2,000 notification from the informal provider, lab and chemist in these two districts. These are the necessary reporting formats which we have shared with the chemists and labs, and labs are also maintaining the details on their own record. But we have, they are sharing all the details, including the name of patient, referring facility. Everything is there, and we are our field team is regularly coordinating with all these providers. So this is our modus operandi, similar to we are following as previously presenter also shared, like we are engaging with all the private, all type of providers in the districts, including formal, informal, Ayush, chemist and labs. And we are also providing the free sputum transportation services to the provider. And we have the field team in which FOs are regularly coordinating with the providers, and they are collecting the TB notification details, sputum samples, and reporting to the provider on regular basis. And FO is responsible for UDST, HIV, diabetes testing, counseling, everything. And then once a patient get notified on Nikshay, then a treatment coordinator follows the patient within 7 days through telephonically call, and we also do the home visit to all the patient, and TC is responsible for DBT, counseling, adherence part, which he or she is regularly following. And we have also the field team, operation lead and MIS, which are regularly validating our data and doing the monitoring part at the district level. So this is our organogram. We have the team of 33 professionals working in both the districts, and we are regularly monitoring them on the key indicators of the PPSA. And we have experience of implementing the JEET project in Punjab also, but in that project we were only covering the city areas, but now in PPSA project we are also covering the neighboring towns of the districts like Rajpura, Samana, Nabha. So we are covering the whole district, where as you can see in city area there are more formal providers are available there, but in the local towns we get the informal providers. That's why we build this network of our informal provider. So we are covering all the district in this project, and we are weekly monitoring the performance of our team members, and we, at headquarter level also we are connecting on weekly basis and sharing our performance. We are also giving the incentive to the good performer at the field level, so that it can give a positive message to the team member that we are appreciating the good work. So now we have the free medicine available at 38 private clinic in both the districts. I would like to thank the district team for this, and we are regularly dispensing the drugs through Nikshi Oshadhi. And because when we started this project, we saw that especially in Amritsar, our patients were getting transferred to the public sector after 1-2 months. And then we do more research work on this, and found that private sector patient also need FDC medicine, free medicine basically. So now we have FDC medicine available at 38 places, and more than 550 patients are getting benefit of this. And it also really encouraging for the provider also, that it is giving a positive message to the community about the provider, that free CBNA testing is available at this clinic and free FDC is available. So providers are also very happy to keep this FDC medicine. So as mentioned earlier, we are getting very good support from the district authorities, and we got the appreciation letter from both the districts. And district team is really very helpful to us, and we are regularly participating in all the key meetings at district and state level. We have also started the MRM technology in Punjab. So we have launched this intervention with the help of state authorities in the month of March 2022. And currently we are providing the MRM technology adherence help to 60 patients of private sectors. We have distributed the 30 boxes to both the districts, and we are getting the good result. We are regularly monitoring the treatment adherence part through this and sharing the report with the district and state authorities. Learnings. So coming to the learnings, the support of the competent authorities is really very helpful, and the letters issued by doctors really helped us to make a good rapport with the providers. And CBNet, despite of the crunches at a district level and due to pandemic, the upfront CBNet testing help us to get the good notification from the providers, and FDC medicine is really helping the poor patient to link with the private doctors. And informal provider role is really very important in the program. Involvement of chemist is really helping us to reach the untraced patient. We are getting the notification from the chemist, and then we are coordinating with that provider. So it is helping us to map and link new provider in the district on regular basis. And MA boxes are really helpful for the for some patients, so they can take their medicine on time. Challenges. I think we have discussed Challenges are similar, you can say. We have discussed more about this, but yes, I can say if the payment release mechanism will be smooth, then we can do better work than this. Conclusion, so PPSA intervention really helped to increase notification in both the district, as you can see the trend, and UDST is also very helpful for the private provider. As you know, in private sector, the UDST test is really very costly. So if we are providing free CBNA testing to the private provider, it is really helping us to give them the better outcome, and they are also really very happy for this service. And public, as you can see in the data, public health action increased in both the district due to regular home visit and follow-up. And PPSA project really helped help to sensitize private provider for molecular testing. As in the starting, we have seen that the prime source of TB diagnosis was X-ray in both the district. More than 90% patients were diagnosed through the X-ray only. But as now we have seen that our providers are sensitized, and they are also referring the patient for CBNAT, TrueNAT testing and microscopy testing. And now we can say that 30% patients are at least now getting diagnosed by the molecular testing. The linkages of informal providers is really very important for the successful of PPSA program, and availability of FDC medicine at a private facility really helping the poor patient to link with the private providers. Thank you. Any questions?
Thank you, Sukhwinder, completing the presentation in time, and yeah, I think very insights. So any questions? First from the jury member. Question, comments?
I think some of the efforts that all of you are putting together is worth highlighting globally. I think there is a lot of learning platforms that at least if Vijayashri is here, she should be able to tell you. Please write half a page or maybe 1 page of what you are doing, which can be an example for others, which is something that you are doing with your local contextual solution. It will be an information for ECTD, which we can highlight somewhere. It will be an information for other PPSAs or potential PPSAs. So if we don't tell the story, neither we are going to learn this across, nor we are going to showcase that India is doing something different in compared to some other parts of the world. It's possible that other people, whether they are in Pakistan or Bangladesh or in Philippines or in Indonesia, they will also be looking up to and also will counter-share their own experiences. So it would be, I would request all of you, please put in that 1 page as an effort and write it to Dr. Vijayashri. I'm sure there is a method we can use this platform to share it globally. That's my request. So, because MERM, if it is working very well, then it can be a wonderful example that can be showcased. So even if that 60 cases that you are talking about, 60 patients, if the outcome is pretty impressive, then it is an example perhaps for others too.
Yes, sir. Thank you.
Dr. Shibu.
No, just so it's interesting to see that WHP, Doctors for You, Alert, and HLPPT is doing multiple places, multiple geographies, and multiple clusters. Just wanted to understand whether your costing for these clusters varies, and if so, what are the components which actually affecting the variability? Probably NTSU can help, or STSUs can help in kind of coming up with variability as a kind of template tomorrow, that these are the cost considerations you need to think about when you propose a PPSA.
Sir, ma'am.
question. I was waiting that someone's going to ask this question. Yes, definitely, when we are implementing PPSAs in different geographies and clusters, the costing definitely varies. So there are a lot of criteria that impact the costing per patient that we come out with. So if we talk about Bihar or Odisha and Punjab that we are doing, there are a lot of things that we keep in mind. One is what's the TB incidence in that particular geography, population, number of private providers that are available, common private providers. So there are quite a list that is available depending on the criteria and where we do. And like Odisha, Sambalpur, the cost is definitely higher than what we are doing in Punjab and in Bihar because they're sparsely populated or the number of formal providers is very less. And how do you do the engagement? So there, and also there is a level where we look into urban and rural costing. So rural logistics is always very, very expensive than urban. So that is also kept in mind. So depending on that, we have a list and criteria on which the costing is done.
In whatever the number of patients, they are not less, but the death rate you are saying, if the fatality is 9%,
yes,
we need to identify the reasons. So have you already done that?
No, we haven't done that, but state is now preparing one document for this, for all the districts, not for PPSA, for all the districts of Punjab, that what is the this is, what is the reason for this. I think Dr. Pooja can add on this, because Dr. Pooja is working on this. So state is now planning to do the death audit in all the 22 districts.
That's true. Dr. Pooja will do, the state will do, but
yes,
since you are taking care of those patients,
yes,
you are reporting the outcomes,
yes,
and it is not very difficult to analyze.
Yeah,
so
we have all the data.
Ongoing process.
Yes.
And because we all know in the whole country, Punjab had the highest case fatality rate amongst the COVID patient. So we also need to see whether we can do the bidirectional screening and testing for COVID.
Okay.
These comorbidities are equally important.
Yes.
And second, I didn't understand what those barcodes were there on the stock registers which you showed. It looks interesting, so I would like to know more about it.
Sir, actually barcode was, that was the lab register, and barcode was the it was referring to the serial number of that test. As you can see in the lab, they are noting the patient name and they are giving the barcode to the individual patient. So barcode was referring to the blood samples also, because they are maintaining data on one register only, and we are taking the report from their register only. So barcode was referring to the blood samples.
Yes, ma'am. So in the treatment outcome, you have a very low loss to follow-up rates.
Yes.
So I just want to understand what are the processes that you have put in place, which has come to such a low loss to follow-up rates, and particularly when you are working in the entire district, so there will be patients who are notified from the city level, but who are residing in the villages, and there has always been a struggle, particularly in the private sector, to manage these patients.
Yeah. So for this, when we got notification from the any provider, so first our field officer called that patient, and if her number did not connect, so we did not enter the notification on the next day. We will only enter the notification on the next day when we will talk with the patient. So in that case, our LFU cases are really very less, because we are verifying our data on two levels, one at the FO level and then at the TC level. So we are not directly uploading the notification without the contact number and proper address. That's why our LFUs are less here. We are validating, first we are validating the data, we are calling the patient, and then we are uploading the notification on the next day. That's why our LFUs are less, because we are regularly coordinating with these patients.
Is there any percentage of patients who are, you got the information but you didn't able to contact them?
Yes.
And then you are not notifying?
Yes.
So what is that percentage?
Sir, it is less than 1 or 2%.
Okay.
Yeah.
Okay. So, thank you so much.
Thank you. Thanks a lot. Thank you all.
I think with this we are concluding the session 1. And so I'll ask Sandhya to.
Thank you, sir. Yeah. I extend my gratitude to Dr. Amar Shah for wonderfully moderating the session, and we'll now move to the next session, session 2, which will have different set of presentations from PPSA agencies from different states. So for moderator for this session is Dr. Bhavin Vadera, who is the Project Management Specialist Health USAID. So I'll request you, sir, to please take over. And the next presenter under session 2, the first presentation is on innovative model for drug distribution, learnings from JEET implementation, JEET 1 implementation. So may I know, Dr. Shamim is here with us. So, okay, so Mr. Manoj will present from WJCF. So I'll request Manoj to please come and make the presentation.
Good afternoon, all of you. First of all, thank you for giving us the opportunity to present our learnings and experiences of, partnering with a for-profit agency on some of the drug delivery pieces and also on PPSA implementation. Before starting the presentation, I would like to thank our donors for the Faridabad project. It was Global Fund through which we implemented this grant. On the 3-city pilot, we implemented because of the support of Gates Foundation. And obviously, due to the support of NTP and their readiness to take this up, we were able to implement. So thanks to NTP as well. And now let's move to what is the alternate model of drug delivery and PPS implementation we are talking about. It's implementation of, how can we get more for-profit organizations in this space? How can we make them more interested here? So to address this gap, and first of all, what is this gap? Let's try to understand the background of it. So I guess most of us know about what's already over here. 50% of TB patients reach out, more than 50% of the TB patients reach out to the private sector as first point of care. Private sector notification definitely jumped between the periods of 2017 to 2021. And the third reality is that in PPSAs, community-based organizations are mostly participating, which are local NGOs. But what's the problem with that? The problem is that due to the participation of community-based organizations, there is already an industry which is developing, which is, tech-based industry. I mean, I won't say tech-based industry, I would say there's a lot of innovations happening on, scheduling, route planning, follow-ups by the online players, by the e-pharma players, by the, door-to-door drug delivery players. So those access to tools are not present with us, which leads to inbuilt inefficiencies in deliveries. So can this challenge be offset by access to those technologies and partnership with these for-profit organizations? Similarly, home sample collections and drug delivery are services which a PPSA agency currently does not offer. We offer, let's say, from a facility sample collections, but is there an opportunity to enhance the scope and bring patient centricity to the core? So that was another problem. Can we address that? Again, the most important piece was when we look at the overall efficiency or cost effectiveness, where this overall model suits a for-profit player is, can he actually use his fixed cost, in a PPSA we use our full-time employees, let's say as a hub agent or a sample collection transport agent, or let's say a counselor. Can the already agents who are there at 1mg doing drug deliveries, can they also do drug delivery for us? Can phlebotomists who are going home to home, can they also collect, sputum sample? So to bring in more efficiencies with their existing demand, can they also cater to our demand? Where some of the questions that we look forward to, and where some of the questions that we wanted to dwell into. So what did this problem force us to do? Well, we implemented 2 pilots, and this pilots was specifically, we were trying to reimagine how a PPSA works, and get a for-profit agency into the whole network of end-to-end PPSA management, which is from sample collection, transportation, drug delivery, patient management, patient tracking. At the same time, we also wanted to check, is it possible to, make them own only a part of a PPSA, which is a drug delivery. So that ways 2 pilots were split. Faridabad pilot, we were not imaginative enough and came up with the name where this is being implemented. So Faridabad pilot, this is an end-to-end PPSA where all the function of a PPSA agency, which is notification, sample collection and transportation, end-to-end patient management, even HIV, RBS testing, patient follow-up, counseling, and outcome, entering the outcome in Nikshay was primarily the responsibility of the for-profit partner. Similarly, on the drug delivery pilot, the expectation was that end-to-end PPSA were being implemented across the 3 sites of Surat, Delhi, and Ahmedabad, and only the drug delivery piece was outsourced to this for-profit player. In order to check what is the difference, and while we were implementing, WJCF was implementing the JEET 1.0 grant from 2018 to 2021, we were able to, we had geographies in which we were delivering, when I say we, our SRs were delivering drugs from doctor's clinic. At the same time, we had the opportunity to see how a for-profit partner is doing and what is the, outcome, or how is the patient perceiving at both these services. Deep diving into this to understand in more. So, as mentioned earlier, end-to-end service delivery is what the bouquet of services that Faridabad pilot contains, which is sample collection, report delivery, data entry to Nikshay, post-confirmation of a TB patient. This is delivering FDC to patient RBS, HIV and RBS testing, counseling, and patient data entry to Nikshay. So these were the services, and how does our stats look? Again, this is, slightly dated data. We are taking till December and January of 2021 itself. We started around June of 2020, and in the 1.5 years of operations, we were able to notify around 3,100 cases. We were able to, get consent of more than 2,500 patients. for their, any of the services which may be counseling, CBNAT, FDC, any of the services. We we were able to collect samples for more than 650 patients. Patients who were initiated on FDC were around 850, counseled 1300, and dropouts of 183. But how is this patient snapshot looking at an overall level? We see that 53% of the patients who got services were males and 47% were females. What was astounding and the biggest challenge that we saw initially was, for this to seamlessly continue, a patient should have a smartphone so that he and she can subsequently request for FDCs in the upcoming months. We initially thought this is going to be a challenge, but what we saw is that 98% of the patients in Faridabad had access to smartphones, which made our life very easy because it was more seamless, drug delivery to patients' home. We also were able to, out of 848 patients, around drug deliveries were around 3,000 patients, around 28-26 medicine refills have been made. 651 samples have been collected of the request of 781, and again the fall is because of unable to produce sputum, consent withdrawal, standard reasons of drop-offs, and 1300 patients were given counseling. If we look at some of the trends, we see that over the quarters, what has definitely improved is FDC delivery, which was quite obvious. But if we start with the blue line, which is number of unique notifications, definitely from an average of 200 notifications, December 2021 or the quarter 4 2021 ended up with 481. That's a definite increase. But I think there are two charts that are overlapping. But nonetheless, the number of active providers definitely rose. And it rose to a level of 60 to 90 from where we started to 170 in the last quarter of 2021, we were able to have 120 active providers. The definition of active provider is anyone who is giving us either a notification or a service. So overall, when our ability to engage providers with the bouquet of services definitely improved. Now let's look at some of the TATs. The bottom left table showcases the overall TAT, and we have split across sample collection TAT, which is of the 650 samples, those were collected. 21 hours went by on sample collection, so a patient had to wait for 21 hours. Report delivery from the time of report release. There is one TAT that is not considered as part of this, is time in which we get the report from labs. So because at Faridabad there was capacity issues and we were having CBNAT reports in 4 to 6 days. And we wanted to focus on services, on how can we optimize the service by the agency, and that's why that's omitted. But if you look at the third TAT, which is how much time does it take for us from the soft copy of report generation to release it to patient, it was 10 hours. And the delivery of physical copies, some 72 hours. So those were the overall TATs. 86% we were able to collect samples of 86% of patients within 24 hours. Similarly, we have FDC TATs. We were decently able to provide FDC within 32 hours that's the average, and 75% of the patient got within 24 hours. So just wanted to focus on the quality of service, and not quality, but I would say some of the key KPIs of delivery. And why is it important? Because the pilot gave us the insight that these are the parameters to deep dive on, to look at, measure each and every step of the overall, drug delivery or a sample collection transportation. So we broke it to the last minuscule point and then went ahead. If you look at, we even went and said that patients who are not actually ordering drugs, what is my average days that a patient is going without medication? And these are some of the information that is currently not available in the other PPSAs that we are working on, because we did not have the data systems to capture some of these elements and optimize those service variables. So again, would not dwell a lot over here, but average days of medication when we started, we were able to reduce it to 1.2 and slightly it increased. There are specific reasons quarter-wise why it has increased. But the uber point is that ability to measure information definitely came. So what were our learnings from the Faridabad pilot? First and foremost, the feasibility of engaging a for-profit organization was established. There was a automation with respect to scheduling, calling, route planning. All of this, what did was patients were getting messages on, when they would be expecting their drugs. So patient convenience were foremost, and a lot of patients, again, a structured research has not been carried out, but definitely the patient convenience overall was far better than what we expected what we saw in PPSA. Overall, a more important point is from the sustainability angle, that we were using the compounders as a hub agent in the PPSA Global Fund grant. So these compounders, in lieu of incentives, which was nominal incentive of 100 rupees per notification, were actually sharing prescriptions of patient to the agency, due to which, and they were also registering the patient on the portal, due to which all further services were then catered to. So we think that's much more sustainable by using the services of compounders or receptionists who are already present. Again, we also hope that the field officer engagement, which is the doctor engagement front, could have been taken up by 1mg, but that was something that did not happen, and doctor engagement was something that CHAI continued to lead, while service delivery was something that 1mg team were taking it up.
Manoj, 15 minutes are over. 5 more minutes if you can.
Sure.
Thank you.
Okay, so what do we see on, as we all know, it was a outcome-linked variable payment. So payments to 1mg and 1mg team was basis number of sample collection, number of FDC delivered, number of counseling happened, which is physical counseling as well as telephonic counseling. All of these had a menu chart or a rate card basis which payment were supposed to happen. So it was an outcome-linked payment. What we also figured out was that the focus is the focus of for-profit players are more on, transaction completeness rather than patient holding. So that's a big difference between how a PPSA operates, which is patient is being taken care throughout 6 months by one person. Over here, different folks are delivering FDCs. That's one point. But at the same time, the benefit was that one counselor was holding the patient all across. So, transaction completeness was what we figured out was, due to the nature of the business, was something that 1mg team was focusing on. Last piece on this is longitudinal treatment journey management was not part of the CRM that was developed, and hence, we were doing that manually. We wish that such kind of system were developed. Quickly, I'll move up to drug delivery piece, which is a standard drug delivery by an online player. Will not go into detail. The moment a transaction or a request is received, a person is assigned that request with specific, address and drug name and drug quantity that is delivered by the 1mg agent. what do we see over here? Over 22,000 deliveries were made till December, and by the end of, we stopped taking new patient by January, and we were able to complete 29,000 deliveries in Surat, Ahmedabad, and Delhi. Those are the 3 cities for this pilot. What we saw is similar statistics of, 52% male, 48% female, with over 93% smartphone availabilities. Obviously, these are, capital and major cities. Number of active provider, the only metric, an important metric to measure our engagement, improved from 168 in Q3 of 2020 to 454 in Q4 of 2021. Quickly looking at delivery analysis, and the only important point is how many deliveries did we make within 24 hours. We were able to make 81% of deliveries within 24 hours. When I say we, it's the 1mg team. The average start of delivery stood somewhere around 30 hours. And, the drop-offs in subsequent refills decreased. Obviously, refill 1 is where the most drop-off happened, which is 83%, because a lot of patients were shifted from FDC to single molecules, or, due to ADAs and other features that happened. We did a quick analysis of, is this, how can we say that, we were doing drug delivery, 1mg team is doing drug delivery, who is better? Again, nothing to compare over here, but we plotted a pre-pilot state of, what were Ahmedabad, Surat before 1mg team actually started, implementing their services. We found that 45 to 50% of patients were on FDC, while we completed around 65 to 60% of folks were on FDC. So there was definitely an uptake in FDC, either, and most importantly, the doctor perceived as a value-add service to the patient, where a patient is getting drugs at his or her home. Obviously, there were challenges of privacy and other issues, but most of the patients preferred, who had disclosed their status to home, at home, preferred drugs receiving at home. Quickly on outcome comparison, if we look at patients who were on 1mg versus who were not on 1mg, again, this is statistics 101. We have reduced the bar, so it's 90% we got outcomes who were not on 1mg versus 96% who were 1mg in Ahmedabad. While in Surat, we definitely see a higher percentage of outcomes, successful outcomes of people who were on 1mg. Again, learnings quite similar. Patient convenience stands high. There are a lot of touch points that needs to be optimized in order to make this more seamless, and more importantly, on account of higher reminders and higher touch points, patients' adherence to doctor follow-up is high. Those are 3 key points. Okay, what are the next steps? Gujarat had budgeted for some home delivery in PIP. Let's see when that comes up. Again, there have been some talks of Haryana in domestic PPSA contracting. I don't know if this is going to be part of it or not be part of it. Again, the most important scale-up piece that we need to focus on is Union, through the Global Fund C19 RM grant, has got a grant to scale up the drug delivery piece. So that's something that will be interesting to know when this model is scaled up across many geographies, how this stems up. On some of the dissemination pieces, I would like to just call out 2 pieces. We are in different stages of impact evaluation with ISB in order to understand the economies of it and what was the per patient cost. At the same time, looking at patient convenience, where is it that this model rightly fits in. And apart from that, there are some papers that were written. Thank you for your patient listening.
Thanks, Manoj. Thank you so much. And pretty interesting one, as well as thought-provoking. Any questions from anybody? Okay.
Very interesting presentation. One thing I wanted to ask you, how did you maintain the loss to follow-up? I mean, this becomes the biggest issue with the patients.
Yeah.
Like in PPSA, we have counselors. We are continuously in touch with the patient through the call centers. So how do you ensure that in your case?
Sure, ma'am. So I'll start with the easier geography, which is the 3-city pilot. We had our own counselors over there because we were already implementing JEET, and we got the services of 1mg for only the drug delivery element. Coming to the other pilot, which is taking 1mg as complete PPSA agency, over there we had counselors. We asked 1mg team to hire counselors who were handpicked and trained by us. They did not, they had other projects running, but they did not have trained counselors. So this is a specific, cadre we asked them to hire, and we hand-holded them in managing the patients. So we used their IT backbone with programmatic know-how that we had while implementing our PPSAs in order to have counselors in Faridabad geography, ma'am.
Thanks, Manoj. Yeah, over to sir.
It is really indeed a very innovative model, and it just, we could not have thought of this. But my only concern is that in this kind of setting, somehow directly or indirectly, the patient gets geotagged. So was it done by your agency or was it done by Tata 1mg in this case? And was that future security and data breach was taken into concern? And third thing is that while delivering drugs, was it directly from a DTC or you were acting as a drug depot intermediary? And if that geotagging somehow happened, did you take into account spot mapping of the cases which were there? So I just wanted to know, because it is very curious kind of presentation made by you. Thank you.
Sure. So I'll start with the data privacy question. Any patient who was onboarded to these pilots were asked to sign specific clause regarding data privacy, that this information is going to be shared with an 1mg with a for-profit player, and if they are agreeing, then only they were being put on this pilot. So for all the patient, we had a written consent signed, and this was informed to the patient, while it was also informed the benefit that signing this agreement will bring. Second point on geotagging, I am not sure that patients were geotagged. While patients were visited and were delivered medicine at their home, we have the address and we can do it n number of times. We did not ask to geotag patients' home because at that point in time it wasn't required to geotag a patient's home. If it was a process of 1mg, I am not party to it. I don't think they also geotag. Ideally, what they correct is the address piece, so that subsequently they can make home visit, and it depends upon different e-pharma players and their IT platforms. So to be honest, I'm not aware of it. On your third question, how were the drugs being delivered? So drugs were actually given to us because 1mg was contracted out by WJCF. So drugs were received by the district authorities to us, and we were handing out to the 1mg team, and we were maintaining the per patient consumption list, which was ultimately being handed over to the district authorities. So we were acting as an intermediary in the whole process.
One more, right? Because this is in any case, you can have a more discussions. Can we have one? I mean, I'll just request. Oh, you wanted to respond to? Please.
So I just wanted to add. Thank you. I just wanted to add one thing. The biggest challenge in any intervention, be it in the public or the private sector, is to have access and to analyze the prescriptions. So even if let me start with the public sector first and be honest here. how many times do we really know that the prescription which is giving the private sector is being analyzed by all of us? So what usually comes in a prescription is maybe FDC3, FDC4, things like that, which is fair enough, good. But when it comes to engaging the private sector, the challenge is are you giving adherence to a wrong prescription or not? So those things get tied over here, because by virtue of these platforms, be it the one whom we collaborated with or the others of the same, all of them honor only the prescriptions which follow a standard format. Now, what is that standard format? That standard format which has been given by the Government of India. What is it? Like, at least you need to have those mandatory details. If you have a Schedule H drug, say for TB, it cannot be a 2-drug prescription. So things like that. Or maybe it is going with fluoroquinolone. So those checks are inbuilt, and as a result, what happens is once you have the know of your providers, you can target them better. In terms of just calling everybody for a CME, you really know who you should be targeting with, be it calling in a CME or maybe engaging with them through their the medreps. Thank you.
Thanks, Dr. Shami. Only last one. I mean, you can have further conversations during the tea break also. Why I'm saying that? Because we had allocated only 15 minutes and we are already passing to 20 minutes.
Thank you very much. My name is Blessina Kumar, probably only person in this room representing the other side, so excuse my questions. Very interesting presentation, thank you very much, but I wasn't clear which organization you were representing. My second question is, you kept referring to patients. It wasn't very clear from your numbers, are you even presumptive TB taking it as patients, was my next question. The third very interesting point you talked about was counseling, which I didn't hear at all from morning. I think this is excellent. Though in your presentation you mentioned about doctors' support and doctors' follow-up adding to adherence. I'm wondering how much does counseling contribute to adherence, because you seem to have a very good system of training counselors and hand-holding. That is something that could be a real good lesson for us to kind of learn. The other issue is with the data. You did say that consent, but how informed is that consent? How much are you explaining to people with TB about what is going to happen to that information? Because we already heard from someone this morning about the power equation. You are definitely at a higher power position. So in that case, how do you ensure that the informed consent is actually the right information that is going to them, and that they definitely have an option to say no? Is it linked to treatment? Are they afraid that if they don't give permission, that they may not get treatment or the other support? Thank you.
Thank you, ma'am, for your question. I'll try to address them in the order that you have asked. On the organization, ma'am, apologies, I am representing CHAI, Clinton Health Access Initiative. On the patient front, in the 3-city pilot, ma'am, we were working with DSTB patients. I assume that Jeet grant was known to all, but apologies there. Jeet was working with DSTB patient in Jeet 1.2 avatar. In the Faridabad pilot, we catered to both presumptive. Both in both the 3-city as well as Faridabad, presumptive as well as confirmed DSTB patient is what we had and whom we served. On your question on adherence, ma'am, adherence is a multi-variable, and it has so many different dimensions. Not to talk about the specific aspects that you've raised, definitely, the importance of doctor is doctor's every word is considered, gospel. It's as sacred. But at the same time, reinforcing those pieces to the patients are also important, because some of them definitely deal with a lot of behavior change variables as well. Alcohol, smoking, family background, nutritious food, a lot of different aspects. And there comes the role of counselors to be very, very important, where they not only make the patient aware of the disease and the subject that he's dealing with, but handholds the patient throughout the journey. So he's not the person over here with, generally a treatment counselor is from the community, and he's there. Some of them obviously have also recovered from their TB episodes. But I mean, these are people, those who know their area, know the community, and have the reach to patients. So yes, counseling is paramount in order to ensure that one is able to complete the treatment. And more importantly, from the doctor's follow-up perspective, how this project also helped is we were able to, not only look at the first prescription from the doctor, which Dr. Shmi mentioned, we had all the 6 prescription or all the 3 prescription basis the number of days with which the doctor has asked the patient to come back. So we were able to nudge the patient to go to the doctor at the right time, not be very late in order to miss the medication or early. So yeah, the technology as well as the counselor played a very important role. On your point on consent, all the patients who were taken consent were explained about what is it that they will be benefiting. Our focus was to in the 3-city pilot, we had the opportunity to say that if you do not want to get medicines at your home, you can get medicines at the doctor's clinic as well. We had the luxury of saying that because we had both the models running simultaneously. In Faridabad, we did not have the luxury. And we trained the compounders to give them the benefit that do they want to avail a home delivery of drugs. If they do not want to avail, same drugs is available at the DTC free of cost. This was part of the standard pitch that a compounder gave to patient. So we tried our best to get the consent of a patient without differential power dynamics, but from the front of patient's benefit and how is it going to benefit patients, ma'am. Thank you.
Thanks, Manoj. Thank you so much for putting all this together. Apologies for those who wanted to have more discussion. Please catch up with him during the tea break. Let's have a round of applause for the Let's move to the next agenda, the PPSAs you are listening to. And we have now from the state of Maharashtra, 3 organizations who are going to make presentation. I'll request Mr. Mahesh to come up on that and deliver the presentation on behalf of LRT. Government.
Very good afternoon, everybody. I hope I'm audible. Yeah. So, I'm indeed grateful to Dr. Rao for giving us this opportunity, and it's really overwhelming to see all our partners together, and definitely looking forward for a very enriched learning experience. And thank you to each of you present here and to add to our learnings. Thank you. So I'm presenting on behalf of Alert India. Alert India is an organization working, we are pioneers in the field of leprosy. And we've also we work for tuberculosis and HIV as well. And myself, Prabha Mahesh, I'm director for the health projects for TB, HIV, AIDS and community health. So Alert India has had a huge experience in the field of tuberculosis. We have been working beyond, like we established in 1978, and from we started off with leprosy, and from 1988 onwards, we have been working in tuberculosis control. So myself, I have been in Alert India for close to 2 decades and have experienced the evolution of TB work, and also experienced TB also in a very big way. And so we could just go ahead with the partnerships. We have had partnerships for strengthening health systems. So these are the various partners we have worked with, right from leprosy, TB and HIV as well, and community health. And these are the achievements in our leprosy control. So we have been active, we would say the pioneers of leprosy control. And we started off with the basic SCT pattern and moved towards the NLEP. So these are the achievements in leprosy control. So we worked on various strategies, and finally we have established a community spokesperson in the present slum communities of Maharashtra and other few states in India. So this has been the work that we have done in TB control. So as I said, we started off with basic support to National Tuberculosis Control Program, to supporting RNTCP schemes. So we have had linkages with MDACs, and we also have been very fortunate to be one of the organizations to have implemented the PPIA funded by PATH. And we have had nutrition support programs and various other tuberculosis programs by initiatives. Like we have had CSR initiatives who have funded us for various pilot projects as well in TB control. And presently the PPSA, we have been implementing PPSA in, we began with 7 wards of Mumbai. Presently we have 5 wards of Mumbai. So intervention in TB control in Mumbai itself is a huge challenge. So I'm not going into the details. All of us are aware, like Mumbai itself is a hot spot, and there are various contributors, contributing factors that has determined the high burden in these areas. So we started off with M East, M West, L, E, N and S, T wards of Mumbai. These are the 7 wards that we began with. Very interesting thing, as I said, that we started off apart from being partners, apart from implementing schemes of the RNTCP, we also, when we had implemented PPIA, so I just would like to give you a context, like where we actually started off our PPSA from. So the engagement that we had in PPIA was an interface agency. From PPSA, of course, it was a support agency. And the focus was on service delivery through private sector. So we engaged the private providers from health, various health facilities. And we had technical support from the experts. We had special field officers who handle the facility management and nurturance of the providers. Whereas in the PPSA, our focus is entirely on public. Initially, we didn't have a mandate on public health action, but the focus was on public health action at all levels, diagnosis, comorbidities, treatment adherence, documentation, NPOI, and outcome. And we had technical support, definitely. We had the DTO who was involved and who leads the initiative. And we have specifically appointed PPM to take over the role of FO, the field officer in provider management. And under PPIA, we had adequate staff strength, and the proportion was like we had every staff who could handle close to 120 to 150 patients. But here we have limited staff because it's based on the reimbursement that's available to us. So one person reaches out to 250 to 300 patients. So probably the kind of, you can understand the quality, when it comes to this limited staff. And salaries have been on time, of course, and salary structure is a bit strained because we cannot afford to give those salaries what we could give when we had the PPIA being implemented, and definitely payments were not made on time to the facilities especially. And funding, that was a private funding, so we were funded by the Bill Gates Foundation. We had, the invoices were directly paid. We had an established digital platform for payment, and definitely the scope for additional activities like, that activated the patient intervention, like we used to have FGDs, and then we had huge scope for trainings and capacity building, and of course CME for private practitioners. Whereas in the PPSA, it was limited, our activities were limited because it was based only on the budget, on the reimbursements that we received. And resources, we had very limited resources for training because we didn't have enough budget, and even for other intervention. And the validation process for invoice, it's very time consuming, and that had delayed payments. The resources under PPIA was unlimited because to some extent, it was heavily resourced, whereas under PPSA it is very much limited only to public health activity initiatives. Digital platform, yes, we had the UATBC, we had a call center based and also a manual program happening. And here it is the Nikshaya, which is also Nikshaya and also the manual basis. Diagnosis, we had an upfront gene expert and private labs under PPIA, and here we have all the tests are done in the public CBNAT sites. And treatment, private drugs from chemists, it was priced and it was reimbursed directly to the chemist, whereas here it is through the government FDC chemist incentive, FDC management, procurement, transportation, logistics and documentation. So nutrition was provided, actually during that time we also had a supplement being provided by another CSR initiative. J&J had provided nutrition supplements to all the patients, most of the patients under PPIA. And here it is again in the form of NPY by the government. So the present geography and the scope of work. As I said, we initiated, when we started PPSA, it was like 7 wards. Presently, we have these 5 wards of Mumbai: L South, L North, N ward, S ward, and T ward. All these wards are densely, they are all high burden areas for TB. So the scope of work is the PPSA scheme. We have this 2,350 rupees per patient, under which we have we have the private provider engagement, and we have informal doctors, formal doctors, chest physicians, hospitals, nursing homes, chemists, the facilities, then diagnostic linkages and sample transportation, patient management and public health action, linkage support and services for HIV, DM, DRTB, etc. So we also have the FDC management scheme. So FDC stock collection from DTC, transportation and distribution to chemist. So here the direct reimbursement is paid by the MDTCS. We also have outsourcing of X-rays for public and private sector patients. Under the scheme, it is priced at 300 rupees per X-ray. This is the organogram. We have a project director, operations manager, FDC manager, accountant, and so this is the entire structure of the human resource of our organization. So the network facility, very interestingly, you all may, I'm not really presenting a baseline data here because I don't think it's right. We have done enough work the PPIA, through PPIA, and there has been a lot of work already done. So even if I have to work on the impact, so probably I may not be doing justice to that. So I just listed out the facilities whom we had mapped, and we have mapped and tied up, and there are certain hubs which are active, and similarly with the formal providers and the informal providers. So you can see that out of the map, we had mapped 49, out of which 28 are tied up with us. And then you can see 24 hubs are active. So similarly, we have done totally we have had all these facilities whom we have actually mapped, tied up and engaged. So the partnership with NTEP, PPSA implementation, and we have seen since morning, so it has been very similar, the structure, the model has been not very different. And so we have a tie-up with the facilities, the hubs, and then we have registration. We have a hub representative who does the patient registration, and they are referred for X-ray. And then further to CBNAT, and the diagnostic also for the other comorbidities and diagnostic referrals. And then they are initiated on treatment-free FDC from chemist, treatment adherence with ICT monitoring, and then we also have Nikshay Poshan Yojana, and then there is a stakeholder management, of course, documentation and timely monitoring, and validation of invoice and reimbursement to the facilities. So this is the entire gamut of the PPSA project being implemented in Mumbai. So the X-ray services that are offered at both public and private. Interestingly, earlier when we had implemented the PPIA, it was only with the private facilities, and with the PPSA, we have also roped in the public sector. So the X-ray availability was like 35,000 per year for Mumbai, and we had developed 2 copies. So we had one for the lab and the CBO, for private and public, differently color-coded. So voucher placement at facilities with stamps of the attached labs in both public and private facilities. Voucher placement and management in public facilities and private facilities. And these vouchers are issued to the symptomatic and they report to the lab for diagnosis. And the lab copies are collected with the invoice and validated. So we tally the vouchers of the CBO and the lab to finalize and process payments to the facilities through reimbursement. And this is how the one you see in white is the private sector voucher, the public sector voucher, and the one you see the colored is for the private sector placed at the hub facilities. So the efforts made and observations in this X-ray service delivery. So we did a core group analysis of private providers yielding positivity in X-rays. So we found that 25% of the providers had shown high positivity X-rays, like their X-rays showed 50% positive and above. And we have the 7% of providers who had shown fair positivity, in the sense like 25 to 50% X-rays were positive. And then we had 22% of providers who had average positivity between 25 to 10% who showed positive, and we had 46% of the providers where we found the X-rays were 10% below positive, which was very limited. So what we did is we did this core group analysis, and then again following up with the providers and also bringing it to the notice of the DTO, and we ensured that those providers who were not high yielding, so we kept very limited vouchers to them, with them. Patients being followed up in private facilities to ensure voucher utilization. So the advantage in the private sector was we could actually follow up with those patients who are whom we could follow up and also ensure whether these vouchers have been utilized. So tie-ups made with labs in close proximity to the health facilities. So these are the very interesting part is because we had very limited amount in the reimbursement. So we had to, that was very difficult for us to identify the lab facility who would agree for a very less amount. And again, that has to be in close proximity to the health facility. Identified labs within the private health facilities for easy access. So we also ensured to tie up those labs which is within the private facilities so that the patient can have, the symptomatics can have an easy access. Voucher utilization tracking is much easier in public sector as complete details of patients are recorded in health post. So very interestingly, in the public health sector, the registration of the patient, the details is taken complete. We have complete details of the patient, so it is very easy for us to track those patients in the public sector. Whereas in the private sector, only in those hubs where our hub representatives were available. Our staff were available. It was easy to track those patients. But in many of the cases where the registration was not done by the PPSA team, so it was very difficult for us to get all the details of the patients. Voucher utilization is much higher in... Oh, I just started. Voucher utilization is much higher in public sector than private sector. Okay, so this is specimen collection. So I just want to say like the entire detail of how a specimen collection is done. We have mentioned that. And totally we have 24,226 samples which has been collected and transported since Feb 18 to June 22. And we had 5,250 EPTB samples being transported. So under the PPSA achievements, in phase 1, it focused on notification, and phase 2, we had all the indicators, it was made mandatory, and we have had a lot of efforts also contributed from the DTO, PPM, and the NGO staff, and there has been a constant nurturance of the providers as well from the PPSA. So this is the present achievement. So we have the target notification. You can have a look at it. So we have had in the achievement each phase, like we made it phase wise because of the geography that was shrunk. So out of 80% we have had in the first phase 87 and 75, and presently we had a much higher percentage. So this has been the PPSA achievement. And this is for the entire geography. And also I just want to make here a mention of the H1 data. So we could capture the details of the patient who are not registered in our from facility. So Mumbai has really worked very hard on capturing the H1 data. So we had 86 patients notified through the chemist from Jan 1 to June 22. Provider and facility management. So this is the entire flow of PPSA. So we sensitized and involved providers, nurturance, core group analysis we did for the providers for CBNAT as well, constant feedback. Facility management, we have kept a timely check on the invoices validated, and trust with the facilities for sustaining service delivery. And our reimbursement amount per month amounts to rupees 5.5 to 6 lakhs. So under patient management, we have had it's been a flexible approach, and we focused on treatment literacy. And we have had patients who showed adverse drug reaction. So for them also we have had consultations with the treating provider, then linkages. We have a dedicated counselor to intervene with family contacts, especially dedicated for contact adherence and also for contact tracing. Adherence and monitoring through counseling, and also we have intervention with families, motivated patients, ensured provision of prophylaxis, support to collect bank details, community interventions. So the journey is like, when we started a PPIA, we had announced UDST for all, gene expert being the upfront examination. So it was not so easy for us to, the paradigm shift was very, very tough for us. We had initial teething problems, and definitely because we did not have our gene expert tests were very limited, so J&J did come to our rescue. So we had adopted a cartridges sharing model where the cartridges were procured from the MDTCS and the reimbursements were made by J&J. And private providers, yeah, we still have a shortage of FDC sleeves, at least for 70% of the patients. And again, even for the chemists also, they were supporting, and we had prepared the issue note on real time, and they had to be sensitized for smooth process. And that again took 3 months time for us. And lab notification also is being done, but we are not still getting 25% of the notification reimbursement. So doctors are not following NTEP, as that's like, we have still patients who are beyond 6 months, given treatment beyond 6 months, and reimbursement delayed, and salaries difficult, low remuneration, expansion work, and quality gets compromised. Verification process takes time, to the average 3 months, and high value deposits. This is very, very important point, because of these financial constraints, experienced organizations like us miss out on even applying for bidding for further PPSA in other geographies. So strategies to overcome. So we did a lot of work. I was telling Dr. Shibu in the morning, it's literally like a saga for us because of the kind of volume of work that has gone in. So we did train lab technician from NGO because initially we did not have, we had very limited CBNAT facilities. So we even ensured that we had a night shift. Especially MSF was ready to give that, spare that CBNAT for us. So we even appointed somebody for the night shift services and then daily tracking sample mechanism for transport. So we had a tracking sample, we tracked the sample mechanisms and discussions with CTO for flexibility in transporting samples. So there was a lot of flexibility that was, we had it at our advantage. And also we had opportunity from J&J for cartridge. Then we advocated we had advocated for decentralization of FDC services, so that was really effective for us. And then we had developed issue note, and patients who are experiencing ADR, they were provided with loose drugs from Shivri Hospital, and CTO had totally supported us for that. And medicines were available, those facilities where we had problem, pharmacists, we appointed dedicated staff at 2 hubs where medicine could be dispensed. Then due to shortage of FDC sleeves, we also collected toll-free number from various sleeves and we shared that number with the patient for adherence marking. So we also created a adherence marking calendar for regular follow-up of treatment. So creativity and innovation to accelerate better performance. We have digital platforms such as we have created WhatsApp groups of patients, social media to create patient support group. So we have engaged 36 champion TB survivors and performance indicators mechanisms. So we have random checks by senior management where we just keep calling the patients to ensure quality is being maintained, and we have involved champion providers to sensitize the private providers. So we have something called the Employee Star of the Month. So during our review, we congratulate the person who has, we don't have the money to incentivize, but we do it with our own reinforcement mechanisms. Training need assessment, yeah, we conduct a regular training need assessment with a limited budget and the funds. So we identify the barriers and bridge the gap. We design training module, capacity building of the team. And we have also had success stories in for better adherence, CSR initiatives for awareness programs. We have reached out to organizations and we conducted a small pilot on family nutrition, very interesting, but no time for me to explain this, where we literally observed the 3 indicators we observed by giving nutrition to the entire family in Govandi, because you have more than 2 TB cases at least in those houses, where we gave this for the entire home, where we found that number 1 is the frequency of falling ill during that period for the entire family was very, very less. Second is definitely there was a weight gain not only of the patient but also in the others. And third is the immunity. There was no other TB patient, at least till this patient completed the treatment, which we felt that probably has improved the immunity status of the other family members as well. Reimbursement process and payments. So this is the present condition. So we still have 58,75,530 is the amount still yet to be received. And so this is a process, and just a suggestion, we need to develop a financial monitoring system. We have to appoint dedicated personal staff only for data verification at the CTO level. It will be nice if there is an advance payment to facility and staff on a regular basis. Pay at least 50 to 70% after the bill is submitted by the NGO, and probably the final payment can be made after the finalization of the validation part. So be different to be successful. So we have a voucher utilization analysis that we do. We analyze the unutilized vouchers and follow up to identify the reasons why the patient has not reached the diagnosis. Pre-test counseling consciously done even before the patient is sent for testing, like what happens with the ICTC. Similarly, we try and work out with the symptomatic as well. There may be a stigma even to undergo testing, initial risk assessment. We mark indicators for non-adherence. We have coded it, like once the initial intake is very important. When we are actually interviewing the patient, we come to know whether the patient is a potential defaulter. So we color code. So we have a black in case we are sure that the patient is going to default, and we have a red code where if at all we feel that the patient may interrupt, and we may have a green sticker where we know this patient is very cooperative and has a high potential for adherence. And we have appointed 2 dedicated calling staff only for public health action. We have done a patient profiling as we creating profiles of patients. We have identified even the potentials of patients. If the patient is, what are the capacity that the patient has. And community interventions, TB is more seen in the clinical perspective, but how do we actually address the social determinants by involving the community, create spokesperson in the community for TB control, incentives for referrals and confirmed. This is just a plan. If we have a minimal amount of something like 25 for every referral and 50 for every confirmed cases, probably we can involve the community workers and creation of common platform. And these are the experience that we have had in creating a gateway for better insights. And of course, here I want to make an acknowledgement and credits to the efforts of the CTO and the NTP team. They have been a tremendous pillar for support in hand-holding us, receptive to the ideas. They have always involved us and also given us opportunities for suggestions. They involve the NGO partners in developing tools for monitoring process, voucher mechanism, capacity building of the staff. They have taken the responsibility of capacity building, especially Nikshaya process and other documentations, initiative towards strengthening various stakeholders, CSR, private and public health sectors, partnership and monitoring in all aspects. They have provided a platform to voice the barriers, tremendous support in bridging gaps. We have had continuous meetings, quarterly reviews with the DTOs in respective geographies, effective coordinated efforts of the NTP team in all PPSA. So this is how the process, we visit the doctor, there is a symptomatic registration, then you can say X-ray lab, then specimen collection, CBNAT report submission, FDC logistics, and you can see the drug distribution from the chemist to the patient and counseling, and home visit counseling, active case finding, nutrition distribution, and we also felicitate patients. Special thanks for making that big difference in many lives. Definitely the Central TB Division and the NTC, the National Tuberculosis Elimination Program, Municipal Corporation, Bill Gates Foundation, they have actually created that foundation for us, PATH, and of course J&J. A last point here, when he said, what would you actually desire? You asked us to mention about what exactly we want to desire. One is we have already looking at it as a public health initiative, and then how do we actually, I want to see a day where the private sector themselves take the onus upon them, and then they come out with the initiative as to how they can improve case notification. So what can be done to transfer the onus in amongst them? And then also the patient, how can we strengthen, how can this entire thing strengthen the patient so that they take it up, because they are equal partners here. So what interventions and social mobilization we can do for them should also be a part of our agenda. And the PPSA implementing agencies, what I'm seeing, noticing in every place, in every geography, is that we don't look at us as allies, or we are not in a race here, but how we can come together and strengthen this and work towards it as being inclusive. Thank you so much.
Thank you, Prabha. I can understand, a journey from PPIA and PPSA to squeeze within 20 minutes is not easy. But thanks for putting all this together. Now let's open for the questions. First of all, from the jury. Yes?
Just one comment. I think you have the advantage of full-term normal delivery with a good parenting from the municipal corporation. So rather than others are a kind of low birth weight baby, I would say, a neglected parenthood. And most of your innovations are actually founded and grounded. And you had actually beyond PPSA a lot of innovations you are planning. I just want to understand how many of that innovations being attributed to you as alert versus attributed to MCGM. Because I know that this extrapulmonary case diagnosis has been a separate scheme, which is not coming up well in the presentation. And also some of your activities, you have done the groundwork. So you don't need to do a mapping again. So probably you might have dedicated your time for actually organizing the CSR initiatives using that kind of time, because that is, you have to clearly explain that to the larger crowd that this, when we actually reach a optimal point, probably you can explore more to expand the organization, and also a good thing to the patients. One, just comment on your X-ray voucher utilization. You said that there are disparities between high yielding versus low yielding.
Exactly.
You probably need to look at your public sector in the same area. That will give you a benchmarking that how we can actually look at, rather than actually discontinuing with the providers which is low yielding, or kind of encouraging with high yielding. Thank you.
Thank you so much, Dr. Shibu.
Thank you. Yes, sir.
Then 10% positivity you called as a poor positivity. And at some of the places it was as high as more than 50%. Were these 50% positivity cases were confirmed microbiologically?
So this is an X-ray.
Okay.
X-ray.
Okay. But what about the treatment part?
Yeah, I said, so there is no upfront gene expert. So first they have to be initiated, right? I mean, they have to be tested, diagnosed through X-rays. And then once the X-ray is confirmed positive, then they'll go for gene expert. But now we don't have that. Now directly they are also tested for biological testing is done.
But more than 50% positivity means selected.
No, I meant to say, like, we go and place the vouchers in one particular with the provider. Suppose we have placed, suppose that person has referred 100 symptomatics. Out of that, so that is the percentage I'm talking about. So suppose he has referred 100 referrals, he has given 100 referrals. Out of them, there is only 10 patient symptomatics who have had symptoms, actual symptoms. So basically we want to say that it's not that it's just given casually or randomly to anybody, just because some service is available.
Ideally, positivity should not be more than 10% in any case. If it is, whether this is X-ray or, pardon sir?
X-ray positivity.
Same I am saying sir. तो मैं यही पूछ रहा हूँ कि क्या रहा उनका? You are saying 50% positivity for tuberculosis or for something else?
There is a data slide if you want to answer.
Yeah, I will. No, I will.
I am asking.
No. I will answer him separately. Maybe because of time, because I have to explain other context also.
Okay, sir. So, ma'am, will respond to this question later on.
One more comment, ma'am. If we ask 100 patients to got examined, 50% will not get any type of shadow. Forget the tuberculosis.
No, I was just sharing an analysis.
Yeah. 50%, more than 50% patient getting any type of shadow means you are doing X-rays of only selected.
Yeah, selective.
Already confirmed cases.
Got that.
Then no need of doing X-ray if you are already confirmed.
This is only to ensure that the service that is given is very genuine. That's what.
Okay, ma'am. This is last question. We will then. Is there any online question?
Thank you. Very nice presentation. Just I want to know, since you have been, as our jury member also said, having an experience of interface agency to support agency. So how do you look at your paradigm shift? Is it from a positive to negative way, or it's good to bad, or
Interestingly, when we started, I said when we had the teething problem, so we thought it is as worse as from a right to left hand drive. But later on, when things evolved and we understood, we struggled definitely, but for a very, very initial period. And when we thought that the resources are so much present within, like I talked about how we manage the, ensuring that exploring other CBNet sites, training someone, and ensuring that, the person was working on a night shift, so that from the existing resources, how we could optimize that. So the journey was initially difficult, but we thought it went off pretty well, and we've had a very positive side to it.
funding source? Like it was funding agencies or it was coming from the...
Yeah, as I said, it was...
How do you feel in that? Like, because you are now working in this and grant into
Yeah.
domestic funding, is it...
Basically, it was a totally...
It's becoming easy for you.
Yeah, it was totally a different currency altogether.
Yes, that's right.
That answers all your questions. Thank you.
Thank you so much. Ladies and gentlemen, round of applause to ma'am. One of the oldest PPIA/PPSA in the country. Thank you so much. So I'll now request Dr. Shankar for making a presentation, and he will save me of not getting disqualified from the moderator. So please stick to your time of 20 minutes. Yeah, second way. So thank you.
On a lighter note, I would also request the people who are asking questions to be very to the point so that it saves some time.
So thank you, Bhavin. Very good afternoon to all. And thank you, CTD, for giving this opportunity and National Technical Support Unit. So I'm Dr. Shankar. I'm presenting on behalf of Disha Foundation. I'm an independent public health consultant. I support Alert India, HLPPT, and Disha for a PPS implementation in different states. This is specific for Maharashtra. So Disha Foundation is an NGO based in Nasik district of Maharashtra, and it's implementing in 6 districts. Its implementation started from some districts, it's in February, March 2021, some districts June, July. So as I mentioned, I'm supporting different organizations, so I requested it should not get kind of a same message. So HLPPT, Dr. Sangeeta discussed about some of the additionalities to this PPSA model. And I'm focusing specifically on what Nikshay Mitra model been implemented in these states. So it's almost similar in all the states with some geography-specific different changes been made. It started from Nagpur in 2017. So we had a UATBC project running on along with the PPI in Mumbai, Patna, Mehsana. And there we started, we should have some person at every health facility who will work as a hub agent, but we don't have that much funding. So it's limited, and with very limited funding, Nagpur Corporation has started this. And they are giving 100 rupees per patient to the Nikshay Mitra, which we have identified there. Then we got opportunity and applied in Jharkhand, got the chance to implement there in 2019. It was very successfully implemented initially. And then we expanded it in Maharashtra, Goa, and HLPPT is implementing in Chhattisgarh, Odisha as well since 2021. So altogether, we moved from, we adopted hub and spoke model and moved to the all hub model. So we call it kind of all health facilities are hubs for us, and we have a Nikshay Mitra there. So what is Nikshay Mitra? So Nikshay Mitra are a nodal person at every health facility that we have identified, who is responsible to do all NTP related activities which are expected from private health facilities. Those are the existing staff of private health facility, which are designated by doctor himself as Nikshay Mitra to undertake these activities. Who doctor feels he can do it better way, they should be a kind of a tech handy. They should have a Android mobile phone and able to use a Nikshay app. That was the kind of a conditionality. We build their capacity on TB, on NTP, Nikshay, with counseling, not very hardcore counseling, but light counseling, and all recording and reporting. And incentivize them. So that was the motivation for them to take up the activity and to provide it support to supervision, monitoring, and always there for solving the problems. So Nikshmitra can be any person at private health facility which doctor can think can undertake this activity. It can be a compounder, it can be a receptionist, can be a nursing staff, can be a lab technician, pharmacist. So whichever the person who is suitable to undertake these activities is been designated as Nikshmitra. So what they need to do? They need to do a notification of TB case. So as soon as TB patient is diagnosed, doctor refers that patient to the Nikshmitra who is sitting next to the, preferably next to his OPD itself, where patient can find himself. He needs to notify that TB case in Niksha app, provide a basic counseling, health education to the patient and family, collect bank account details for NPY, enter it in Niksha, collect a specimen for UDST, and coordinate with the dedicated specimen transport agents for transportation, getting tested at labs, CBNAT labs most probably, and report it back. And once the report is available, they enter the result in Nikshay, do a contact tracing. It's an institutional contact tracing which we have adapted. FDC offer, so we keep FDC at private health facility. Most probably it's pharmacies associated with them, or if doctor is willing, they can keep it themselves. So they offer FDC to the patient as well. HIV diabetes testing, so all patients who are diagnosed as TB tested for HIV diabetes, either if that facility has in-house lab, it is tested there only, or if they have linkages with the other private labs, they have been offered testing there. Even in some places we have explored that doctor himself do a blood sugar test with the glucometer, and HIV testing by whole blood test. So they are coordinated and kept whole blood test kits at the private health facility itself, and trained Nikshmitra to do that testing. So they track adherence of the patients, so they have a follow-up table for that patient where they keep the record of the patient follow-ups and monitor the refills. At the end of treatment, once patient is declared successfully treated, what are the outcome? They record the outcome, take a doctor's signature on that, and a stamp as well. And all Nikshay recording is being done by Nikshmitra itself. So why do they do this activity? So we incentivize them, and incentives are given for each set of activity. So what are the incentives? So we have devised or segregated the incentives activity wise. So it's in same proportion of the cost which PPSA is going to get. Similar proportion cost is given to the Nikshmitra for undertaking these activities. So notification of TB case, DBT bank account details, UDST, HIV diabetes testing. Once the patient is diagnosed and notified, immediately they need to undertake this, and they will be given a 300 rupees for completion of all these activities. Adherence support, they need to follow up the patients and keep the record of it. 200 and treatment outcome 100. So it's a 300. So it differs from state to state as well. Maharashtra, it's per patient 600 rupees given to the Nikshmitra. So any health facility, suppose it's XYZ, Nikshmitra is working there, and they have notified 20 cases in that particular quarter. They get 2,000 for a notification of TB case. So this is just to demonstrate how activity-wise incentives been given. If they have done 17 patients' bank account details validated, then 850 rupees they get. Similarly, for UDST, HIV, adherence support treatment outcome. So for 20 cases, if they do this kind of activities, so they get around 10,000 rupees. So that's a substantial amount for that Nikshmitra. So it's a big motivation for them, and the experience is that they keep everything and they want to do all the activities for each case. So there are no missed cases as well. So we give them these details. Okay, this quarter you received this much amount in your account, and this is for segregated this activity wise. So if you would have done all patients' bank account details validation or DST, then you would have gotten a bigger sum. So that's motivation. They keep on improving. So almost now one year has gone, And we see it's a substantial improvement in their attitude and their record keeping as well. So all Nikshamitras means I've never imagined that even in public sector we don't keep that systematic recording. I don't know, means I've visited many states during CIEs or IEs. So we don't find all records of TB patients with the private health facility or even public health facility. So here they are keeping all the records of the patients. So this is a TB card which captures the basic information. Definitely it's been entered in Niksha, but for a validation purpose we have kept the hard copies as well. They attach their Aadhaar card to the TB card available at their facility. This is a CBNAT report, this has also been attached, bank account details, other HIV report, diabetes. So all these records are available at the health facility with the Niksha Mitra. So it's helpful for validation, means anybody can enter anything in Niksha, right? So it's a payment that finances are linked. So we need to validate and then make the payments. Or even when we are claiming, we should be sure all the activities been done. So this is for validation purpose, and it's been very well maintained at almost all health facilities now. So model, it's mentioned at the core is a doctor at Niksha Mitra. So field officers of PPSA engage private health facilities, identify Niksha Mitra in coordination with them, build the capacity of Niksha Mitra to undertake all the activities which are expected. We have a specific sputum transportation agent dedicated mostly in urban settings. Where there is a less work, we have leverage the existing labs, sputum transport people like in Goa, in rural Maharashtra as well, where the existing mechanism where a specimen been transported, so we have leveraged them and incentivized them and getting the activities done by them. So they do sample collection from the health facility, get it tested at the lab, report it back. And FDC has been offered to the patients, mostly at the private health facilities only. If patient demands for home delivery, then our FDC transport agents do the delivery at the patient house as well. Specifically during COVID time, we needed to undertake that activity. So organogram, mostly at state level, we have 6 cadre of staff, almost project lead. There is a project manager who do manage all the day-to-day activities, admin officer, accountant, data managers. So data managers are mostly for data validation. Telecounselors, so patients need some counseling as well, regular follow-up, so that is done by telecounselor. Project officers at district level, and at field level, field officers, there are SFT agents, specimen and FDC transport agents, and Niksha Mitra at private health facilities. So in these 6 districts of Disha, there are around 675 people. Definitely mostly a chunk, 649 are the Niksha Mitra at private health facilities. So these are the people which are working in the for PPSA implementation. So almost all private health facilities having TB cases at their are having a nodal person, a person from NTP, a Niksha Mitra, who is working for the NTP. So this is trained in the TB case notification. So we started somewhere in first quarter 2021. And you can see almost double the number of notification in these 6 districts. So in the table, if we compared July to June 2020 to 2021, then there is 86% increase in 2021-2022. So 1 year after the PPSA started in all the districts. And it's a 104% achievement against the target. All indicators, so JIT was being implemented, and most of the indicators are quite fine in Maharashtra. But still we are able to improve that further. And most importantly, these are validated indicators. If we are saying 75% bank accounts are validated, so we have a record of it. If we are saying 52% are being tested, we have a DST reports of it. Similarly for HIV, diabetes, so it's not just entered, but it's a validated data that we are presenting. Around 32% patients are put on FDC, so that is in process, and we expect this year we will improve that further. So what innovations? So I'd say the whole Nikshimitra model itself is an innovation, as it's mostly incentive-based model. It's a use of existing health facility staff, so cost-effective and more sustainable. And most importantly, it is making a big behavioral change, not only among doctors, but private health facility staff as well. So now they are taking the ownership of their TB cases. So that was not present before. Now they are notifying, doing all public health actions by themselves. Our team is there only for supervision and monitoring and supporting them if they are facing any issues or problems, mostly NICSH-related, app-related issues. Telecounselors, so we have it's not a kind of a very big call center, but we have a couple of telecounselors in each state where they give a call on behalf of a doctor only. So whenever they call patients, so they mention that we are calling on behalf of a doctor, definitely after taking consent from doctor itself. We do a daily tracking of the performance, so that has really helped to identify the poor performance early. And as Dr. Sangeeta did mention, we have a PPSA mobile app, which is being used for not only our staff monitoring, but data validation. So we have one session tomorrow on data, how we are using this app for data validation, so that we are 100% sure whatever the line list is going to NTP for invoice generation, that's a well-validated data. So lesson learned, use of existing private healthcare workers is a cost-effective, it's sustainable, easily replicable. So we have demonstrated it in most 4 or 5 states we are implementing now, similar model with some state-specific tweaks. And it produced a quick result. We started in Jharkhand, and within the first quarter itself, all indicators been achieved, the targets given, it's achieved there. And even though we have payment-related problems, not able to make salaries of staff or Nikshimitra incentives, we are getting the similar results. So still they are hoping, and they are doing their work as expected. It's more accessible and acceptable to the patient as well, and affordable to PPSA agency, as it's a lesser capital cost requirement, less number of HR, and it's a whenever we get a payment from NTP, we pay it to the Nikshimitra. So it's not a much burden on PPSA agencies. Still, staffing is required, and that burden continues. It improved recording, real-time reporting, so that is a very important quality indicator. So we just analyze for Maharashtra, so the duration from diagnosis to reporting, notifying a case is reduced to 1.8 days median time. So that's a very quick and decentralized reporting, we can say. And mostly it helped a smooth and centralized validation. So many PPSs say, specifically Mumbai ones, validation leads to delay in payment. But that is not the case with us. The validation process is very smooth. So we have all the records with us in our laptop for all TB cases. And it's there in the private health facility as well. So whichever the cases they want to verify, they just go and visit private health facility and check it out. It's readily available. And even we can do a centralized validation as well, because it's there in the PPSA app. So that validation is very easy and smooth for us. And so as the payments, specifically in Maharashtra, it's happening timely. This is very crucial, timely payments to the staff. Before that, PPSAs, staff, Nikshimitra, is the crux of matter, and that's kind of very important for keeping motivation and getting the results. And the most important thing which I want to mention here that this is a platform been set. So now we have a one person, nodal person from NTP side or government side who is working for us for some incentives, but we can just pitch in what are the activities we want to get it done from private health facility. If we want to streamline the notification of other cases, we can just add on some notification incentives and get that done. So it's a dengue, malaria, what are the information we want from private health facilities which we are struggling, a government is struggling to get information from. So that can be pitched. So it's very easy for a horizontal expansion, we can say. Challenges, it's already discussed, SEBINAT. We did achieve up to around 65% during initial second quarter of implementation, but then it's dipped, and it's kind of a backlash we are getting from private providers. Okay, you say at the start you advocate, but then there is issues when you deliver. So now we can't go and do a forceful advocacy with them for UDST specifically, but we are asking them, it's important, but it's get done. So from anywhere, if you want from public, we can facilitate whenever there are facilities available, or you can do it from private as well. FDC supply mechanism was an issue, so we discussed that with the district and states, and we are streamlining that as well. Nikshay mobile app issue, so sure, done. Nikshay Mitra app issue, so whole this data recording, reporting of PPSA depends on Nikshay app only. So many times the app was not working well for private health facilities, and the kind of notification getting hampered. So that needs to be streamlined. It's a big dependency for us. And PPSAs are expected to undertake any activity from specifically on district. So whatever the activity comes in, they ask PPSA to do it for private sector. It's not possible because there is a limited budget for a different set of activities, and we can't undertake X number of activities being asked within that available budget. So conclusion, so we are in Maharashtra, we are able to achieve the notification target given, and most of the targets given for other key indicators of the program. There is a very proactive support from state and district NTPs in Maharashtra. So I really like to applaud State TB officer sitting here and their team, WHO consultant and State Technical Support Unit, which are supporting the PPSA implementation on day-to-day basis. Though there are some districts which are still an issue for payment processing. Issues like CBNAT, FDC, which we are have highlighted at state level, and resolving in collaboration with the state team. So though payment mechanism is well streamlined, but it takes a lot of energy to get payments from districts. So we are requesting state to make it a state level payment. We have all data at state level as well. If you can select and want to validate at state office itself, we can give that data to you. So it will be helpful. Thank you. That's it.
Thank you, Dr. Shankar. A very interesting presentation. I just want to have kind of your thoughts about you and Dr. Ravikant, if he is still around. You both of you are giving two divergent models, all right? One is a highly empowered, field staff. Yours is more of a labor-intensive field staff. Now, how do I hybridize these two? I mean, I'm asking both Ravikant and you to explain.
Shankar is my junior, sir. Today only that he's so active in work process. I hope tonight we'll
develop a strategy for payment facilitation. So, sir, I think our model is not much staff or resource intensive. It's very light on that mode. It's almost 95% of our staff are kind of a part-time and incentive-based. So it's not much labor incentive. Their model is they're having hub agents, their own staff as hub agents, and I think that leads to a good substantial sum of going to the human resource salaries and other things. That's the question, right?
No, my question was that that particular staff that Rekant mentioned as it's a multitask-oriented individual, right? In your case, it is a very simple task-oriented. So the question is about where do I find the best or optimal solution among these two?
Sorry, still I didn't get the question, but Nikshay Mitra are doing multitasking. They are doing all TB related activities. They are facilitating.
That's the point I was talking about. That technology enables more patient-centric in terms of diagnosis and discharge. In your case, it is much more of a, if I were to say, kind of a coordination work that your Nikshay Mitra does.
It's patient-centric as well, because patient don't need to go anywhere. It's health facilities there, only all services been provided. Sorry, I'm not able to clarify. We can discuss it later.
So I just want to add one thing, sir. If you consider India, is not one country. Even in one state, every district is different. So what model, even in Doctors for You, what model we are following in M Ward, Mumbai, is very different from what we are following in Betia district or Siwan district of Bihar. In Betia district, even with so many staff during monsoon and even before monsoon, few areas are so cut off that providing them medicine or getting their test done is extremely difficult, and in fact I am ready to accept that we have to ignore some patient. We can't reach there. So what model Shankar has, see the easiest place to implement the PPSA is urban area, the area where so many patients are connected. It's cost effective also when you have bulk of the patient. So if you ask me कि रविकांत तुम मुंबई में जो है 2000 में PPSA कर दो, और if you ask me to do PPSA in Manipur or Nagaland or in Bihar, even in 5,000 rupees, it's a very difficult, sir. Like in Mumbai, we never थिंक अबाउट कि एक्सरे कहाँ से कराना है, एक्सरे तो होगा ही होगा. बिहार में एक्सरे तो सर नोज इट्स वेरी डिफ़िकल्ट. पिछले साल से सरकार जो है वो बोल रही कि नया मशीन लगेगा, टेंडर होगा. एक मशीन है, 2 मशीन है पूरे मेडिकल कॉलेज में, एंड देयर इज सो मच रश of other patient also. उसी में TB patient को भी fight करना है. So and in rural area the most challenging is traveling. Whether it's a movement of sputum or movement of the field worker, sputum collector is very difficult. So cost वहाँ पे कहीं ज़्यादा होता है मुंबई से compared to any urban area compared to rural district. So this is I think the major.
So in fact, this is mostly urban settings. Now Maharashtra is going for rural areas as well in next PPSA tender. So there the staffing requirement, travel requirement will be much more compared to the yield of the cases. So the per patient cost is definitely going to be higher in those clusters.
Yeah. No, thank you so much, sir, putting this question, because in general also we wanted this flavor of variations. And I think this PPSA conference has a good mill-up of the junior and senior. Probably, in the evening, it gets hybridized. We get one model, which will be useful for all of us.
There's two clarifications. Yes. One is I assume all the Nikshay Mitra have a login ID to Nikshay. You mentioned about the challenges, but I'm just assuming that that there's a mechanism. If we streamline Nikshay, some of this thing will get further streamlined. Second thing is that, is there an occasion there, because of number of footfalls in an increased facility, in a facility where there is number of footfalls are high, you have 2 Nikshay Mitras?
Yeah. So each Nikshay Mitra has access to the Nikshay using doctor's user ID and password, which has been generated when patient doctor is registered in Nikshay. So they use that user ID password only and do all the activities of recording patient details in Nikshay. Definitely, we in some places where there is a lot of cases, TB cases, either we adapted to have a dedicated who will be a person from their health facility itself, who will be staff of their health facility only, that will be dedicated for TB work, because the amount of incentive which he'll be getting will be more than the kind of salary doctor will be giving. So there are incidences where we have a more number of Nikshay Mitra as well. Morning shift there is one Nikshay Mitra, evening shift there is another Nikshay Mitra. Thank you.
Thanks. Dr. Kiran.
So, Professor, if you don't mind, I would like to extend the discussion further related to the question. We had to start somewhere, and that's why we focused mainly on notification as a starting point. But it is equally important that at what point of time in the journey of the patient, right from his first symptom till the point of time we catch him, that is very, very important. It's very logical and natural that we get the catch hold of the health facilities, and then we try to diagnose and bring them in the cascade of care. But it is equally important that the infectiousness duration needs to be reduced. We call it early diagnosis, but it doesn't happen, or the current mechanisms, not all, some of the PPSs are doing well. Two suggestions: unless and until we reach out to that particular stage wherein we also involve the spokes of the informal or formal providers who are feeding as a starting point, so that we catch them early without disturbing the equilibrium, of course, and also linking it with the community screening. Community screening doesn't mean that the patient ultimately has to go to the public sector only. And unless and until we do that, the total delay in diagnosis is not going to reduce drastically. We will be happy with the numbers, and that is the very important indicator. Unless and until we quantify notification, of course it will be difficult to manage the transactions and the payments against the work done. But these two things are very crucial, and we need to also think about how to include them in future actions.
Right. So initially in first year we concentrate on formal providers. Now we are reaching out to the informal providers. Those will be our kind of spokes, and they will be channeled to the formal providers.
Also the community screening, because that's where the action needs to start.
Okay, you. Last question.
Yeah, I just want to answer Dr. Venkat question. Sir, I would see that both combination of both field officer and compounder is necessary, because in our program also we are paying compounders. It is same as we can call it Nikshay Mitra. And initially they were not agreeing, but slowly now 50% of the work is being done by them. So slowly the field officer role is getting down. So we have to see both combination, means incentive plus field workers here.
Yeah. So.
Just last comment to this. Perhaps I did not phrase my question properly, which perhaps we can discuss it during the coffee time, all right? From a CTD perspective, from a policy perspective, from a guidance perspective, I am looking at whether there is an evidence to suggest your model to be, I am looking at it as a business model. Is your model more effective than the model that Ravikant is presenting? So that's what I'm looking at an evidence. Both seem to be working well. But can I incorporate such a kind of a flexibility to give these extremities of possibilities into my guidance document? And if that can happen, then I need that kind of evidence. And that's what we are looking for. So the reason for PPSA meeting for today and tomorrow is primarily to generate these kind of evidence, so that more flexibility can be built into in the future. That's the purpose of asking them.
Sure. So Thank you for the question, and I can't say my model is better or Ravikant's model is bad, but I definitely say it's a less resource incentive. It's a definitely more sustainable. If tomorrow there is no PPSA, but that behavioral change which we have already created among the private doctors or Nikshay Mitra, that will remain there. So if NTP just adopt that 500, 600 rupees incentives, activity-wise incentives which PPSA giving, there's no need of PPSA. Then NTP itself can give the incentives and they can sustain that. So sustainability is, I think, one of the crucial aspect which is easy with this model, and the cost effectiveness which we can say. And specifically affordability for the PPSA agency as well.
Thanks, Dr. Shankar.
Thank you all.
Thanks for generating so much of interest. Round of applause for Shankar. I request Dr. Vaishali from Dr. Suryu, and 20 minutes to go for you. Okay, so now not only Dr. Neeraj and the team that is going to disqualify me, you all guys are going to disqualify me because there is no tea break. Please take the tea in the room and have a working tea. Okay? I'll request Dr. Vaishali to stick to the time. Otherwise, I will be kicked out of the room today. Okay, so thank you so much.
Good evening, everyone. I will try to stick to the time, so I'll quickly start. So, Doctors for You, again, 25 states, 3 union territories, working with NTP since 2012. We have been working as a PPSA agency in 4 states and total of 33 districts. Active case finding project has been happening in Madhya Pradesh. Sputum transportation services are being given in Madhya Pradesh Rewa division. Capacity building of the public sector related to the PMDT guidelines in 2 states, that is Bihar and Assam, Meghalaya. DRTB center in Mumbai, the tribal TB project with ICMR. With respect to NTP in Mumbai, we are having a DOT center which we had established in 2012-13. After that, sputum microscopy lab has been set up in Mumbai. In PPSA agency, we've been working since 2019, and also we have set up 2 comprehensive community-based urban DRTB centers in Mumbai. PPSA is one of the, in Mumbai, it's one of the mostly densely populated city with a population of 20 million. Poor housing conditions like horizontal and vertical slums without any direct sunlight, which leads to increase in the spread of disease. It has the largest number of MDR cases, around 5,000 per year, nearly 15% of the all TB cases. DFI started working in 3 districts, that is M East, M West, and Centenary. The total population of these 3 districts is 1.3 million. Nearly 80% and 60% of the population in M East and M West resides in slum. The scope of work: the mapping and engagement of the private providers by field officers by obtaining the list from the IMA, NGO, and the local search. The notification of the TB patients, providing the free diagnostics like X-ray, HIV, and DM, linking of the patient with the diagnostic services of the UDST and the Nikshay Poshan Yojana benefits, ensuring treatment adherence through regular calls and home visits, contact tracing to reduce the TB burden, documentation validation and monitoring evaluation of the program. The time trends, in the left we have the year-wise private provider engagement. Here we can see gradually from 2019 till date we have the mapping of total 600 plus providers has been there. The yellow, which is the engaged, the difference between the mapped and the engaged is because the mapped can be an informal provider as well, but the ones who are engaged are only MBBS and above, because of which the number difference is there. Or out of the engaged, active are around 500. On the right, we can see the year-wise trend in the notification number of the different sectors. It can be seen here that in the private, ever since the PPSA agency has started working, there has been an increase in the notification. So total is here, yeah. In the PPSA performance in the various indicators, in the graph we can see that it has been clearly shown that after 2019, when the implementation was started, in fact, there was a time when the comorbidities of 100% of all the notifications, the comorbidity testing was done. Even the UDST, like initially till at around 82% is what we had started in 2019, and now it is around 74 is what the percentage is. The DBT, again, it's a very good number, which we had around 94% is what we had achieved right now. You can see that the numbers are a little less because it is just, we've not yet, it's half year completed, and although the estimations have been done, but still it is seen at 81%. And the last is the Nikshay Poshan Yojana, which is a little lagging behind in this year. Nearly 12 to 15% of the patients are reported to be MDR-TB. The turnaround time for the UDST is approximately 1 to 2 days due to the sputum transportation services which are available. Approximately 90 to 95% of the patients take the FDC. 60 to 70% of the private providers are informal providers which refer the cases to the MBBS. Successful outcome is remained between 70 to 75%, except in the period between April to September 2020 due to the pandemic. Here is the modus operandi. First, the patient seeking the care comes to the private sector where the practitioner who is MBBS or above is sitting. That area is called as the hub. Here the hub agent is sitting. After the patient has been referred to the hub agent, the details in the Nikshay are added and also in the hub register. From there, he collects the vouchers for the X-ray, where he does the free X-rays. The sputum, the falcon tubes are given, and then the sputum samples are collected. The sputum transportation agent transports this sample to the government CBNAT sites. The reports are then submitted by the sputum boy to the hub agents again, who then gives the report to the doctor and to the patient. The hub agent notify, facilitate and counsel the patient for free FDC from the nearest empaneled chemist. CFR, patient follow-up for all the public health action, free diagnostics and DBT document collection and the treatment here is done. The FDC flowchart. First, the doctor initiates the treatment on FDC and refers the patient to the empaneled chemist. From there, the patient visits the chemist with his prescription and collects the FDC. The chemist documents this in the FDC register and stock register and prepares an issue note for every patient every month. Daily basis it is done. Then DFI collects this consumption report from the chemist, compiles it on a monthly basis, and then gives it to the FD, the district office. And then from there, all these checks are done. So the doctor's view collects the FDC form from the DTO office and distributes the drugs amongst the empaneled chemist and maintains the stock register. The patient visits the chemist every month to refill the FDC doses depending on the treatment phase. Based on the FDC and the stock register, issue note is received from the chemist, which and then prepare the consumption note and share with the DTC on a monthly basis. After validation, the consumption report and issue note, a release of ₹100 per issue note is being done by the DTC. So all the activities are done on a monthly basis, and the reimbursement from the district comes approximately quarterly. The HR structure, program director, senior program manager. We also have a central PPSA training team and also finance officer and HR, program manager, district supervisors, data entry operator, the community field representative, and the sputum collection agent. The lessons learned, providing the free diagnostics like X-ray, HIV and diabetes helps reduce the delays in treatment. Well-trained staff for conducting the HIV and diabetes helps to give smooth free diagnostic activities. Tie up with the banks for the DBT camps for opening the accounts for the patients. Regular CMEs and conducting the nodal training for the private providers helps in the good licensing and the better private provider engagement. Timely payment to doctors increases participation. I would request SGO Sir to give his comment on this after the presentation, because we've got a very good response in Mumbai. Right now it's August, till July, almost all the incentives for the doctors have been released. So we've got a very good response and good participation from the doctor side. It's been a very good process because the participation is suddenly increased and it shows. Awareness activities like walkathon, rallies increases the visibility of PPSA amongst the public and builds trust, assigning higher targets to the notification to the field staff, and also giving them incentives after the achievements is done. And all the districts have a well-functioning UDST system, which helps in reducing the turnaround time. Challenges in the initial hiccups were there when we had taken up the project in 2019. The reason being that in the few states where we are working, we have been given a list of the private provider is being given. So it kind of is a good template to see whether all those practitioners are there on your mapped facility. So this was not there initially, but yes, then the DTO and the PPM were very cooperative and then kind of were with us on the field when these meetings were done. During the pandemic, of course, there was a decrease in notification, poor outcome of the patients were there because the major hospitals in Mumbai, all of them were converted to the COVID care facilities. During this time, we had set up medical mobile units, which had a doctor, a nurse, counselor, wherein the patients were given the medicines, follow-ups were done for ADR, counselings were done. So this kind of helped us during the COVID pandemic. The current challenges are that, yes, the number of pediatric cases are high, but the number of pediatricians who are actually giving the TB notification is low. Despite of good contact tracing, refusal from the private providers to initiate the INH prophylaxis is another challenge that we are facing currently. Conclusion, free diagnostic X-rays is very helpful. Advance paid by the state, around 10% of the annual we had received as the payment. That kind of helped us in initiating the capital investment for the program was helpful. The chemist incentive for the FDC distribution helps in notifying and ensuring the treatment adherence. The DRTB center, which is run by Doctors for You, has a chest physician, counselor, and the whole DRTB treatment, medical team is there. So this kind of helps us to provide services to the patients who, if at all, because of certain if at all the regular OPDs where they're going, if that is not open, or they can always come here. Also, in our facilities, we have other public health, like the immunization is happening, ANC, PNC, all of that happens. So it kind of gives a very comprehensive care to the patients. That is why the acceptance of the center is very high. Then infrastructure support to the district, CBNAT cartridges, again, the support was done through other donor agencies. Weekly meetings with the district help us to monitoring and finding solutions. Providing incentives to our team to achieving the targets keeps us motivated. These are a few of the photographs. Here on the top left, you can see the DRTB clinic. Again, the ECG is being done. The samples are being collected. Then again, the right side, you can see the vaccinations which are done. Again, the child is being given a vitamin A deworming, So, and here street plays are also, the photographs are also shown. So this kind of, comprehensive kind of thing is there, because of which we have a good response of PPSA in Mumbai. Thank you. One last thing. We've got the X-ray for the demo. If at all I can have to, end of the day. All right, sir. So that's it. Thank you from my side. I hope it was within 20 minutes.
No, thank you so much. I would not have used stopwatch. I did not use this time. Okay, any questions from jury?
Thank you for that presentation. Just one question. You mentioned about DBT camps for account opening. So what proportion of patients do you think need these camps? And is it more for account opening, or that their account details are not available with the program?
Yeah, so the challenges what we were facing is that the bank account details were given, but which bank is being validated in Nikshay, that was a little issue, because most of them had bank, the cooperative banks accounts, which were not being accepted in the Nikshay portal. So we had then, with the Indian Postal Bank and also few private bank, we started conducting camps For example, on 15th of every month, we used to keep these camps at our health center. When we used to tell these patients, your account, आपका जो account है, is not being accepted by the government, तो आप जो है यहाँ पे आइए, हम आपको नया account खुलवा के दे देंगे. So this kind of helped us because when we were earlier just telling every month 500 you'll get, and they used to not get it, they used to get really frustrated at us that you are just lying and not going to give us any money. This kind of helped. And also what happens is that Govandi is a very densely populated, and as Prabha mentioned, like almost every second house has 1 or 2 TB patients. So when the initial few camps were conducted and they started receiving money, then that trust kind of built on, and that really helped. And also one more thing was that whenever these camps were there, we always used to request the DTO staff to kind of come and sit with us, because then kind of helped in the that trust factor kind of doubles.
You said that 100 rupees per voucher and payment for X-ray is released by DTC. So is it outside the PPIS budget or including that?
So I think when the morning presentation was going on, this we had not included in that. So with the NTP, Doctors for You has an MOU of around 220 rupees. To be very precise, we have an MOU with the local private labs for various amounts, which is like, between maybe 150 to 220, so something like that. So this is how our internal MOU happens. Okay. Yes, so it is separately.
That means NTP got budget in 2 heads, one for PPSA and other which will be released directly from the DTC.
Yes. Yes, 2350 is for the PPSA.
Plus 100. That means total budget will be more than 2,500 per person. Okay, thank you.
And the rupees 100 which I mentioned was for the chemist.
Thank you, Dr. Vaishali. I just wanted to ask you that you mentioned that 10% amount is received by NHM. Was it a part of the contract process?
Yes. So, for example, say on 1st of August, we got the agreement signed with the NTP. On the very, maybe within 10 to 12 days, we received the first amount of 10%. So it was on a pro rata basis. So, for example, say we had the target of around 3,000 for those 3 wards. So out of the 3,000, according to 300, whatever the amount would have been, that much amount was given as advance to us. So for the initial capital setting.
Okay.
Dr. Ravikant wants to comment something.
Thank you very much.
Yes. In the states where we are working is what he meant. Mishra sir, sorry.
जब तक ये सब नहीं करेंगे ना तब तक we are very very lucky God
Exactly. I wanted to tell us sorry even before he finished the statement.
Usually my comments are very acrimonious, but this time I will be, I'm also looking forward to meet in the evening session. Okay. We all are living in India, and a part of India lies inside our heart also. So these are the new areas, and the flexibility he was talking about, Dr. Venkat, about the flexibility, and freedom. So the flexibility means not to, or freedom means not to, freedom to do the correct thing. Flexibility means that how system is ready to acknowledge the mistakes and to correct it on time. So even it was projected by the World Health Partner and Doctors for You that they are supporting the laboratory. So there are modules damaged. If it's your laboratory, then you should repair your CBNet modules. Do the calibration also. There are many things that the government owns. It's not like that. So we have changed, and I have no hesitation. The only right point is that Dr. Kiran Rade was saying about the community. So more earlier we engage with the community, we will catch the patient earlier. Second thing is the end point, the chemist. We missed at the community level, we missed at the private sector level, government system, but in the private sector the patient finally takes the medicine from the chemist. So how much we are ready to engage with the chemist? I could not see that clarity that this PPSA is doing. So maybe that 10 districts tender will be finalized by the mid or before the end of the August. But in that, you will not be able to do the call center only, because screening of the family contact, household contacts is there. We have given the liberty to add the cost of the X-ray. This time the facilitate the X-ray done in the private lab, and you are blaming me that the X-ray is not there. So this time you can add the quote the X-ray cost also. So we are learning from our experience. So I will expect that all these presentations, the discussions should be on the TB, PPM learning network, and that should be used very frequently, because the physical meetings have also their constants. I'm feeling very cold here. So it would have been virtual better. Thank you so much for giving me time.
Thank you so much, sir. And frankly speaking, even Mumbai, is the first place where the PPSA domestic budget started. And so they have also learned over a period of time, right?
Yes.
So all this, the best of the things that you are seeing, it's all after making a lot of mistakes and learning from there. So I'm sure, we are moving and progressing the same way in other states as well. So congratulations,
I have
thank you so much.
I have just two comments. So as sir had mentioned, what are the desired things that we would want to see? So one is that when a patient is going from one district to another, there is a system in place wherein the patient can be transferred out, or we can get in touch with the respective location DT office and get the coordination done. But then working in Govandi, we do have patients who are there from Bangladesh who are TB positive, where this system kind of doesn't work out. They start here and then they don't kind of follow up. Similarly, in other states where we are working, we get patients from Nepal as well. So this is like one problem which is there, which we have to find a solution for. Second thing is a little ambitious, but then during COVID, we had all given quarantine period for everybody who's positive. So during the TB active phase, at least if we can ask for, because what happens is that majorly a patient fears losing his job. The source of income is not there. That is why the reason he kind of tries to hide that, that he is a TB patient. So if at all, at least till the active phase, if at all there can be some system in which quarantine period or maybe some medical sick leave can be given, it will be a changer is what I feel. So thank you. Thank you.
Thank you so much. I'll hand it over to Sanjay.
May I add something regarding quarantine? Sir, once a patient is infectious, one should not go to work. But in NTP, we are doing system examination only at the end of IEP, that means 8 weeks. But generally, patient becomes infectious after 3 to 4 weeks if treatment is effective. That means if our diagnosis is correct. So I propose sputum examination at the end of 1 month, especially in cases who are smear positive to start with, and those who want quarantine, especially who are going to some work at some workplaces, some factories or office. So this is my proposal, to keep them isolated in their own home at least for 1 month till their sputum becomes negative. And sputum examination at the end of 1 month along with at the end of 2 months. Thank you.
Dr. Kuldeep is there. He is one of the guys, one of the persons who was instrumental in bringing out the policy or some kind of regulation related to workplace TB related conditions. Dr. Kuldeep is here.
Not there, but I can respond. But frankly speaking, this is not related to PPSA per se.
No, this is not related, but as Madam raised the question.
I can respond to this. This was discussed in detail.
Thank you, sir.
Yeah. Thank you, sir, and thank you, Dr. Bhavin, for so effectively, moderating the session. So, because we are having a working team, so we'll proceed with the next 3 presentations. These are the continuation of Maharashtra PPSAs, and there'll be presentation on innovation on call center from World Health Partners. So before we begin with the next presentation, I would like to just announce also that our ACSM team since morning is tweeting on CTD Twitter handle about the event to propagate the event. So the Twitter handle is @TB division. So you all are requested to retweet it and follow the tweets. And also we are going live on Facebook. The Facebook page of CTD is TB Mukt Bharat. So you're requested to kindly share and like the page. We will move towards the next 3 presentations, and these presentations will be moderated by Dr. Sandeep Bharaswadkar, who is the consultant BMGF. So moving towards the next presentation, so I'll request Dr. Neeta Jha to please ma'am come over and make your presentation on call center innovations. So this is part of WHP PPSA only. It's that they are explaining it in detail and elaborately. Yeah, over to you, ma'am.
Good afternoon, everyone. It is basically continuation of Bihar PPSA presentation, in which I had shown that call center plays an important role in the PPSA model, and why call center, there is a need of call center and how we work. I'm going to show by a few slides. It is a short presentation. So why there is a need for call center? Because large caseload makes monthly household visit very difficult, and 25% of the patient are out of district patient, which complicates the matter further. So in the large program where there is huge caseload, we thought that a need for call center is required. Counseling and adherence tracking over phone provides an effective alternative. Since 60 to 70% of the calls are productive, field personnel physically visit the remaining unproductive calls to the household.
So combination of call center contacts, physical visit provides a result with financial efficacy. So we have 8 counselors in our call center, and primary responsibilities are counseling new patients, monthly tracking of adherence. In each month there is a call to the older patient for adherence, and then final call for the treatment if they have completed the treatment or not. And all these are also updated on the next year. So how do we coordinate among our call center, our management information system, and treatment support team who visits the field household? So these 3 units combine and coordinate among themselves. Like manage our MIS persons generate consolidated weekly notification report of new patient and adherence list of old patient, which is sent to the call center for counseling. And call center each month give the counseling. Calls the new patient and give them the counseling, and then they do the adherence counseling of the old patient, and they update on the next year. And then again the unproductive list is sent from the call center to the MIS person, and unproductive list could be unanswered, switched off, wrong number, etc., which is shared with the field team for household visit. So household visit, the list is taken from MIS for unproductive calls, which is around 32%, and then they also give the list for the missed refill, the patient who has left the medicine or not taken the medicine for last 1 month, and for if they have completed 6 months, then those unproductive calls are also shared to the household team for their household visits. Some list of DBT rejection and update list is also shared with them for household visit. So if you see here how it is going in the direction, like list share with call center of the new notified patient, then call center calls the patient for counseling. 68% of the calls are productive. Then unproductive call, which is 32% unanswered, switched and wrong number, is given to the household team for visiting their household for counseling. Similarly, with the adherence outcome calls are answered around 68%. This unproductive calls list is sent to the MIS. MIS again updates this with, they also match with the 6 voucher refill. If the patient has taken 6 voucher refill, then the outcome is also taken from that, which I will talk in the next slide. And it is, if the 6 voucher is taken by the patient and it is confirmed by the also call center that they have taken the 6-month drug, then it is in the outcome. It comes in the outcome list, and unproductive calls are then visited by the household team. So this is the photograph of our adherence calling updating on next year. So reporting of our outcome is through 3 methods. One is call center reported data. Call center reports that they have taken medicine and doctor has said that now your treatment is complete and he has closed the medicine. Second is the voucher refill data. If they had taken 6 months or 7 months refill voucher is there, then that is matched with the MIS person, and that data is again confirmed through the call center, and that is taken as for the reporting of outcome. And third is the rest unproductive calls are visited by the household team, and they go and then confirm the outcome. So these are the 3 methods through which we report our outcome. So our call center cost with these 8 counselor is around 42 lakhs with 42 lakhs around, and per month recurring cost is around 3 lakhs. And in this they will do around 24,000 calls they have to do per month, 3,000 of the same month, and last 6 months around, because we notify around 2,500 to 3,000 patients per month, so 21,000 calls of the last 6 months for the adherence calling. So what lessons we have learned? So call center is required to run large scale program smoothly and at low cost. Home visits to all patients every month is almost impossible due to high number of patients for follow-up. Patient location also being scattered, some being rural, there is limited number of home visits which can be done per day. Maximum they do 8 to 9 visits per day per person, whereas 120 outbound call can be handled by one counselor. And many patients also refuse to for for home visit due to stigma. They say the field officer to come outside at the park or some at the road side so they can meet them. So it is better they are called through a calling center. Thank you.
Thank you, Dr. Neeta. I think call center has become one of the important interventions that many PPSAs have deployed to improve the follow. So let us open for discussion. Any comment from jury? Any comments or questions from audience? Yeah, please.
I think this call center, if it is more local, it has more context and they know what's happening. And that is good, and we can see the contribution, especially in the PPSAs. A recent example, everybody knows in the country that in last 1 year, at least for 6-7 months, there were no payments of DBT happening. The reason was known, because of SNA. But the National Call Center kept on calling the patients and telling them that no, you should get it. If you have given the bank details, you must get it. Go and ask your staff. And some of the places, the staff were abused, alleged that you have eaten up our money. So just a contextual thing that whatever is happening within the program, if there are minor requirements in terms of tweaking or modifying the counseling component, it should be included, otherwise it can be a boomerang.
Yes.
Just one clarification, Dr. Neeta. Just one clarification, Dr. Neeta. Dr. Neeta, this side. Shivu.
Okay, yeah.
So just one clarification. So I mean, we are aware that you are also running multiple health programs. Are you leveraging this call center for other diseases?
No, this is only for PPSA, yes, exclusive. Yeah.
Okay. So I don't see, yeah, please.
One more question on the call center. So you mentioned that it has helped reduce home visits, right?
Yes.
You don't need to, all staff don't need to visit all patients. But do you have an initial home visit as a part of the PPSA?
Yeah, so because number is so huge that all patient cannot, if you take Patna, so we have 1500 notification per month. So we can't visit every household and 25% being outside of district Patna. It is not possible, all the home visits. So we thought that it's better it is called and then subsequently the unproductive list should be visited. But like you take a smaller district like Saharsa, when there is 100-150 notification, then there is a home visit.
So, yeah, please, Dr. Shankar.
So, just a comment, like Dr. Kiran has mentioned, local context is very important. So it's experience from our side as well. So we don't have call center as such, but we keep maybe a couple of girls as for telecounseling. And they sit with the whole program team at cluster level. So it just, not just help us to give the local context, but also solve the problems of patients. That is a number with the patients, and they, if there is any EDR, they just inform the call center people. And then there is a good communication to the field staff as well. Okay, such patient is, so the problem solving is done immediately. That kind of connect is there, which might not be possible with the national.
Yeah, true.
So it's a local is definitely better.
Great. Thank you, Dr. Neeta.
Thank you.
So let us proceed with the PPSA presentations. So may I request Mr. Akbar Syed to kindly present the PPSA work of Maharashtra Jan Vikas Kendra. So as we know that MJK has been one of the very old agencies who has been supporting PPSA work in Mumbai since last 4 years, more than 4 years. So it would be good to hear some of the good work being done.
Good evening everyone. I am representing Maharashtra Jan Vikas Kendra MJK, myself Akbar Ali Sayyed and my colleague Sadashiv. So Maharashtra Jan Vikas Kendra, the NGO, we started in 1996. So basically first we are working in health, education and vocational training. Now basically our focus on tuberculosis and we are working in Mumbai, Mira Bhayandar, Thana, Vasai Virar Corporation. So we had now working with the NTP scheme from last 20 years. So those schemes में जो थे schemes treatment adherence, sputum collection center, LT scheme, sputum transportation जो अभी भी NTP के साथ मुंबई डिस्ट्रिक्ट टीबी कंट्रोल सोसाइटी और पेरी मुंबई के जितने भी सोसाइटी है वसई विरार मीरा बहंतर उनके साथ हमारा कंटिन्यू है। उसके साथ साथ PPSA जो एक्टिविटी है वो हम 16 डिस्ट्रिक्ट्स में इम्प्लीमेंट कर रहे हैं 2018 से। उसके साथ साथ टीबी कंट्रोल प्रोजेक्ट जो हमें मुंबई और वसई विरार एरिया में है हम लास्ट 20 ईयर से कर रहे हैं। उसमें हम टीबी सोसाइटी को सपोर्ट करते हैं कलेक्शन वगैरह के लिए, सैंपल ट्रांसपोर्टेशन के लिए, न्यूट्रिशन सपोर्ट्स के लिए। उसके साथ साथ हमने 2003 में एक्सटेंडेड पब्लिक प्राइवेट मिक्स प्रोजेक्ट किया था जिसमें वो प्राइवेट मेडिकल प्रैक्टिशनर को RNDCP में रिफ़र करने के पेशेंट को रिफ़र करते थे। उसके बाद अर्बन डॉट्स प्रोजेक्ट था। अर्बन डॉट्स प्रोजेक्ट में हमने इवनिंग डॉट सेंटर वगैरह इंप्लीमेंट किए थे ऑल ओवर मुंबई। उसके बाद 2014 से हमने PPIA पाथ के साथ इंप्लीमेंट किया था 16 डिस्ट्रिक्ट में। उसके बाद हमारे दूसरे प्रोजेक्ट है लाइफ फर्स्ट जहाँ पे हम टीबी पेशेंट को टोबैको कंट्रोल के ऊपर काउंसलिंग करते हैं। DRTB लिंकेज है, कैपेसिटी बिल्डिंग प्रोग्राम था महाराष्ट्र में, जीत प्रोजेक्ट था और ECG डोनेशन प्रोग्राम जो हमने JNJ के साथ किए थे। तो ये है हमारा जोग्राफिकल एरिया जो है मुंबई में। टोटल हम 16 डिस्ट्रिक्ट में काम करें तो इसको जो डिस्ट्रीब्यूट किया गया है वो 2 क्लस्टर में किया गया है। क्लस्टर 1 जो आता है वो साउथ मुंबई का आता है जिसमें टोटल 7 डिस्ट्रिक्ट्स है और टोटल जो पॉपुलेशन कवर होती है वो राउंड अबाउट 30 लाख होती है। और टोटल जो नोटिफिकेशन था 2021 में 11,000 था और अगर देखा जाए तो पर लाख पॉपुलेशन जो है 367 पर लाख पॉपुलेशन। और जो क्लस्टर 3 है जो नॉर्थ मुंबई है टोटल 9 डिस्ट्रिक्ट्स है, वहाँ पे टोटल पॉपुलेशन जो है 55 लाख है और जो प्राइवेट नोटिफिकेशन 2021 में था 9,600 था और पर लाख पॉपुलेशन जो है 173। यहाँ पे मैं थोड़ा आपको हाईलाइट करना चाहूँगा जो ये जोग्राफिकल जो एरिया है मुंबई का, अगर आप ये देखेंगे पर लाख पॉपुलेशन तो ये बहुत ही ज़्यादा डिफरेंट है। अगर आप जी नॉर्थ में देखेंगे, जी नॉर्थ जो धारावी का एरिया है दादर, यहाँ पे हिंदुजा लैब्स वगैरह, तो यहाँ पे जो पर लाख पॉपुलेशन जो है वो 1200 के राउंड अबाउट है। यानी मंथली जो नोटिफिकेशन जो है दादर जो एरिया का है वो डिस्ट्रिक्ट का वो कुछ राउंड अबाउट 1500 के ऊपर होता है। और जब आप देखेंगे यहाँ पे जो वैरायटी हो रही है पर लाख पॉपुलेशन का, यहाँ पे कुछ 1200 पर लाख पॉपुलेशन है, कुछ जगह पे 93 पर लाख पॉपुलेशन है। तो ये जो वेरिएशन है ये आप पूरे ओवरऑल और जो 16 डिस्ट्रिक्ट में आगे की सभी स्लाइड्स में आपको ये रिफ्लेक्ट होगा और ये जो वेरिएशन है इसकी वजह से बहुत सारे इंडिकेटर पे परफॉर्मेंस होता है। जैसे यहाँ पे अगर आप डी वार्ड में देखे जाएंगे तो यहाँ पे FDC इंटेक भी जो है हमारा वो भी बहुत ज़्यादा वेरिएशन है। कुछ डिस्ट्रिक्ट में अगर हम देखेंगे डी वार्ड है, कुलाबा है, यहाँ पे FDC इंटेक जो है वो 2% या 3% है। लेकिन वही हम अब आगे के एरिया में जाएंगे नॉर्थ साइड में तो ये P नॉर्थ वगैरह एरिया में है, H ईस्ट में है, यहाँ पे FDC इंटेक जो है वो 80% के ऊपर है। तो सिर्फ बताने का यही था कि ये जो 16 डिस्ट्रिक्ट मुंबई के है यहाँ पे हर डिस्ट्रिक्ट जो है 4-5 किलोमीटर का रेडियस है, लेकिन यहाँ पे जो वेरिएशन है वो बहुत ज़्यादा देखने मिला और हमारे लिए वही सबसे बड़ा चैलेंज है। वो हर स्लाइड्स में मैं आपको इसके बारे में बताऊँगा। तो ये टोटल जो है 16 डिस्ट्रिक्ट में हम काम कर रहे हैं मुंबई में PPSA के लिए। तो जो PPSA का स्कोप वर्क है, जो प्राइवेट प्रोवाइडर एंगेजमेंट है फर्स्ट, और ये प्राइवेट प्रोवाइडर एंगेजमेंट है, ये हमारे लिए बहुत ही मैं कहूँगा बहुत ही ईजी, इतना बड़ा टास्क नहीं था, क्योंकि ये हम 2014 से पाथ के साथ कर रहे थे, और वो टाइम पे हमको बहुत ही सपोर्ट था पाथ का, क्योंकि पाथ के फील्ड ऑफिसर थे, पाथ की पूरी टीम थी, और ये एक्टिविटी शुरू करने से पहले 2014 में हम लोग ने मैपिंग किए थे। उसके बाद आता है एक्सरे आउटसोर्सिंग। एक्सरे आउटसोर्सिंग भी ये न्यू एक्टिविटी नहीं थी, 2014 से कुछ लैब्स हमारे टाई अप थे, 100 के ऊपर 93 लैब्स थे। जब PPI शुरू हुआ था वहाँ पे फ्री एक्सरे सर्विस ऑलरेडी अवेल थी, सिर्फ ये जो है जब PPSA में मर्ज हुआ तो ये एक्टिविटी जो है ऑन गोइंग है। डायग्नोस्टिक लिंकेज एंड सैंपल ट्रांसपोर्टेशन, टोटल जो 16 डिस्ट्रिक्ट्स हैं यहाँ पे हम लोग मंथली जो है राउंड अबाउट 12 to 300 सैंपल ट्रांसपोर्ट्स करते हैं डेली बेसिस पे। और ये जो सैंपल्स है ये हम जो हमारे हब है या फिर डॉक्टर्स के क्लिनिक है, कुछ प्रॉब्लमेटिक एरिया में पेशेंट के घर से हम सैंपल कलेक्ट करते हैं, और सैंपल कलेक्शन बॉय जो है वो डेटा सैंपल कलेक्ट करने के बाद आईपैक लैब में लेके जाते हैं, और जो भी लैब्स है वो भी सब NTP नेशनल TB प्रोग्राम के ही है, प्राइवेट लैब्स नहीं है, वहाँ पे वो सैंपल रन होते हैं, और रिपोर्ट्स वो जब भी सैंपल लेके जाता है कलेक्शन एजेंट प्रीवियस डे के वो रिपोर्ट्स कलेक्ट करता है, और फिर वो नेक्स्ट डे जाके रिस्पेक्टिव जो भी लैब है, हब है या क्लिनिक्स है वहाँ पे वो सबमिट करता है। पेशेंट मैनेजमेंट एंड पब्लिक हेल्थ एक्शन, पेशेंट मैनेजमेंट के लिए हमारे पास फील्ड स्टाफ है जो निक्षय में एंट्री करते हैं, हमारे पास जो पब्लिक हेल्थ एक्शन जो एक्टिविटी है वो एक्टिविटी करते हैं, उसके साथ साथ हमारे पास अलग से एक टीम है जो सिर्फ ट्रीटमेंट अडेरेंस के लिए कॉल करती है। ऐसा कॉल सेंटर जैसा नहीं है, लेकिन वो हर एक पर्सन को एक डिस्ट्रिक्ट असाइन की गई है, वो पेशेंट को कॉल करके उनका अडेरेंस अपडेट करते हैं, और अगर ट्रीटमेंट आउटकम रहेगा तो वो ट्रीटमेंट आउटकम अपडेट करते हैं। FDC मैनेजमेंट का भी जैसे मैं बताया कि पहले की भी डॉक्टर प्रेजेंटेशन में प्रभा ने और वैशाली ने बताया FDC इंटेक। तो FDC मैनेजमेंट में क्या होता है कि हम जो भी डिस्ट्रिक्ट्स है वो डिस्ट्रिक्ट से FDC मेडिसिन कलेक्ट करते हैं, और जो भी रिस्पेक्टिव केमिस्ट जो हमने टाई अप किया हुआ है वो केमिस्ट के पास वो FDC मेडिसिन रखते हैं, और कुछ डॉक्यूमेंट्स है वो आगे के स्लाइड्स में आपको शो करूँगा। वो जो डॉक्यूमेंट्स है वो केमिस्ट जो है अपडेट करके रखता है, और उसके बिहाफ पे केमिस्ट को जो है हर एक पेशेंट के हिसाब से हर ट्रांजेक्शन के ऊपर उसको 100 रुपीज़ जो है पे किया जाता है। सिर्फ मैं ये बताना चाहूँगा FDC मैनेजमेंट के लिए हमारे पास थोड़ा एक ये प्रॉब्लम था कि बहुत सारे मेडिकल कुछ मेडिकल ऐसे थे जो एग्री थे कि नहीं हम हमारे केमिस्ट में FDC रखेंगे, लेकिन FDC रखने के लिए क्योंकि ये फर्स्ट टाइम हुआ था 2018 में 2020 में, तो इसके लिए जो भी केमिस्ट था उसको अलग से एक FDA अप्रूवल लेना पड़ता था मुंबई से। FDA अप्रूवल अगर वो आ जाता है उसके बाद ही वो FDC मेडिसिन रख सकता है, विदाउट FDA अप्रूवल वो FDC मेडिसिन नहीं रख सकता है। वो FDA अप्रूवल लेने के लिए बहुत ही वो लंबा प्रोसीजर था। वो प्रोसीजर जो है मुंबई डिस्ट्रिक्ट की तरफ से डॉक्टर सपना करते थे, वो फॉलोअप करते थे, और ये एक ऐसा नहीं होता था, ये ऐसा होता था पूरा बल्क में। देखिए कितने आ रहे, 80 केमिस्ट आ रहे, तीनों NGO के, वो सबके डॉक्यूमेंट कंपाइल करना, फिर वो डॉक्टर सपना जाके FDA के ऑफिस में सबमिट करते कि इनको FDA अप्रूवल चाहिए। वो थोड़ा लंबा प्रोसीजर था, उसकी वजह से बहुत सारे केमिस्ट जो है वो विलिंग भी थे, लेकिन उनका FDA अप्रूवल आने के लिए 6 महीना लगता था, 8 महीने लगता था, बहुत डिले होता था। इसकी वजह से जो है केमिस्ट चाहते भी, हम भी चाहते हैं कि केमिस्ट कुछ बढ़े FDC डिस्ट्रीब्यूशन के लिए, लेकिन वो हो नहीं पा रहा था। लेकिन होपफुली अभी कुछ लास्ट वीक में ही अप्रूवल आया है FDA का तरफ से कि अभी FDC मेडिसिन रखने के लिए अलग से कुछ अप्रूवल लेना नहीं पड़ता है। तो होपफुली नेक्स्ट 1 और 2 मंथ्स में जो केमिस्ट है, केमिस्ट का जो नंबर है वो थोड़ा इंक्रीज होगा। दूसरा है पेशेंट अडेरेंस एंड फॉलोअप। पेशेंट एंड अडेरेंस फॉलोअप के लिए हमारे पास, मैं जैसे पहले बताया, अडेरेंस के लिए एक टीम है, वो अडेरेंस कॉल करती है। बहुत से टाइम पे ऐसा होता है कि हर एक स्टाफ है वो 50 to 60 कॉल करता है, कुछ कॉल उनके लगते हैं, कुछ कॉल नहीं लगते हैं, तो उस तरह से वो एक अपडेट कर देता है कि आज मेरे 40 कॉल लगे हैं, 40 कॉल नहीं लगे, 10 कॉल्स नहीं लगे। और ये जो भी लिस्ट वो निकालता है वो निक्षय में जो टास्क लिस्ट है, टास्क लिस्ट में 15 डेज के अबाउट जिनका भी अडेरेंस पेंडिंग है उसके ऊपर ही वो कॉल करता है, उसके ऊपर ही वो लिस्ट से लेके कॉल करता है। फिर जो पेशेंट का फ़ोन नंबर नहीं लगा है, क्योंकि वो अगर फ़ोन अडेरेंस अपडेट नहीं हुआ तो वो टास्क लिस्ट में शो होता रहेगा, तो इसीलिए जो भी पेशेंट का फ़ोन नहीं लगता है, कुछ प्रॉब्लमेटिक है, तो वो पेशेंट स्टाफ जो है वो पेशेंट का निश्चय आईडी और क्या प्रॉब्लम है वो नोट डाउन करके वो रिस्पेक्टिव डिस्ट्रिक्ट के सुपरवाइज़र को दे देता है, ताकि फिर वो सुपरवाइज़र उसका आगे फॉलोअप लगे कि उसका फ़ोन नहीं लग रहा है। क्योंकि अभी जियो का आने की वजह से ऐसा हो गया है कि रिचार्ज करना ही पड़ता है, रिचार्ज नहीं करेंगे तो इनकमिंग भी बंद हो जाता है, पहले तो वो नहीं था। तो ऐसा तो वेट करते 4-5 दिन, हाँ चलो रिचार्ज हो गया होगा पेशेंट का, अगर नहीं होता है तो उसका सेकंड नंबर पे कॉल करते, अगर वो भी नहीं हुआ तो फिर जो फील्ड स्टाफ है उनको दिया जाता है कि वो जाके होम विजिट करके देखे कि अडेरेंस अपडेट क्यों नहीं हो रहा है। तो ये पूरी इस तरह से स्कोप ऑफ वर्क है। मैपिंग एक्टिविटी, जैसे मैंने पहले ही बताया, ये जो बेसलाइन डेटा मैं बोल रहा हूँ, लेकिन ये बेसलाइन नहीं है। 2014 में भी एक मैपिंग एक्टिविटी हुई थी, 2017 में भी मैपिंग एक्टिविटी, लेकिन ये PPSA की तरफ से नहीं थी, ये पाथ की तरफ से हमने एक्टिविटी किए थे। और ये एक्टिविटी करने से पहले 2014 में जब हम लोग शुरुआत कर रहे थे तो बहुत ही बड़ा कन्फ्यूज़न था कि एक्चुअल में कितना प्राइवेट मेडिकल फैसिलिटी का लोड है एक डिस्ट्रिक्ट में, वो पता चले। और वो पता करना बहुत ही ज़्यादा डिफिकल्ट था कि वो डेटा कहाँ से कलेक्ट करे, MOH ऑफिस से कलेक्ट करे, वार्ड ऑफिस से कलेक्ट करे, या इंडिविजुअली PHC से जाके कलेक्ट करे और उसको कंपाइल करे कि कितना डॉक्टर का लोड है, कितना मेडिकल है, कितना केमिस्ट है। बहुत ब्रेनस्टॉर्मिंग करने के बाद फिर पता चला कि ऐसा किसी के पास भी कंप्लीट डेटा नहीं है। फिर डिसाइड ऐसा हुआ कि हम जाके इंडिविजुअली एक एक लेन में मैप करेंगे। तो इसमें यही है कि जो फर्स्ट हमने कलेक्ट किया सब डेटा पब्लिक हेल्थ डिपार्टमेंट से, हेल्पोज से, और फिर उसके बाद हमने सोचा कि एक एक लेन में जाके मैप करेंगे। लेकिन ये भी एक बहुत बड़ा चैलेंजिंग था कि अगर इतना बड़ा मुंबई एरिया है, अगर एक भी लेन छूट जाए तो किस तरह से किया जाए। तो मैप करने के लिए हमने फिर क्या किया, जैसे एक एक डिस्ट्रिक्ट है, एक एक डिस्ट्रिक्ट मुंबई में देखा जाए तो उसको बोलते हैं एक एक वार्ड, और हर वार्ड में 10 से 12 PHC है। तो हम एक एक PHC में जाके वहाँ का मैप कलेक्ट किए। तो उससे पता चला कि ये एक पर्टिकुलर डिस्ट्रिक्ट में कितने PHC, और हर एक PHC का अलग अलग मैप है, उसकी एक अलग अलग बाउंड्री है। वो मैप PHC का समझने के बाद उसके बाद फिर फील्ड स्टाफ जाता था, एक एक लेन में जाने के बाद फिर वो डॉक्टर से क्लिनिक देखता था, क्लिनिक देखने के बाद वो सब फॉर्म था, फिजिकली फॉर्म वो नोट डाउन करता था, फ़ोन पे उसका फ़ोटो खींचता था। जब भी गूगल में था कि आप वो फ़ोटो खींचेंगे तो जियो टैगिंग लोकेशन आ जाता था। तो इस तरह से वो एंड्रॉयड फ़ोन था, उससे हम लोग पिक्चर्स क्लिक करते थे और फॉर्म वगैरह फिलअप करते थे। तो ये जो पूरा हुआ वो लेन बाय लेन हमने किया है, और कोई लेन छूटे ना, इसलिए हम लोग क्या करते थे, केमिस्ट के पास जाके पूछते थे कि भाई ये लाइन में हमने 4 डॉक्टर्स किए और कोई डॉक्टर छूट गया है क्या। तो इस तरह से हमने लेन बाय लेन ये 2017 में एक किए थे, 14 में किए थे एक्सरसाइज, और एक रिवाइज 2017 में किए थे। और हर एक डॉक्टर्स के लिए, हर एक मेडिकल फैसिलिटी के लिए एक यूनिक ID जनरेट किया गया था, क्योंकि हर एक डिस्ट्रिक्ट को एक यूनिक कोड था, उसके सीरियल के हिसाब से हर एक डॉक्टर को एक एक यूनिक कोड डिस्ट्रीब्यूट किया था, और वो एक एक्सेल शीट में मेंटेन होता था। मैं वो एक एक्सेल शीट आपको यहाँ पे मैंने अटैच किया हूँ। तो आप यहाँ पे देखेंगे, जैसे अभी ये ओपन हुआ है, इस तरह से हमने प्रोवाइडिंग ऑर्डर को डिस्ट्रीब्यूट किया था, प्रोवाइडर, लैब, केमिस्ट, हॉस्पिटल। तो जैसे ये प्रोवाइडर है तो आप यहाँ पे देखेंगे तो पहला कोड आता है 06। ये 06 ये वार्ड जो है F नॉर्थ का है, सायन डिस्ट्रिक्ट, तो उसका एक यूनिक कोड था 06। उसके बाद जो भी डॉक्टर्स इसमें इनरोल हो गए सबको एक यूनिक नंबर 1 से लेके जनरेट होता था। हर और डॉक्टर के आगे फिर उसकी डिटेल से मैप कब हुआ था, डॉक्टर का नाम, फुल नाम, फॉर्मल, इनफॉर्मल, उनका फिर एड्रेस क्या था, टाइमिंग क्या था, हर दिन के हिसाब से ये पूरा हमने एक डेटा मेंटेन किया था 2014 में भी और 18 में भी। ये उसका पूरा डिटेल था कि उसका एड्रेस क्या है, कौन से डिस्ट्रिक्ट में आता है, कौन से हेल्प पोस्ट में आता है, इस तरह से ये पूरा एक्सेल शीट मेंटेन किया गया था। तो ये बेसलाइन डेटा हो गया। और 2017-18 तक जो PPSA जब PPI था, PPI फर्स्ट जो 2014 में शुरू हुआ था 2016 तक था। 2016 के बाद इसका नाम चेंज हो गया था PSI, पब्लिक सेक्टर इंटीग्रेशन। वो टाइम पे जो नोटिफिकेशन था क्लस्टर 1 और क्लस्टर 2 के कुछ 5763 नोटिफिकेशन थे, पर लाख पॉपुलेशन जो नोटिफिकेशन थे 63। ये निश्चय के डेटे हैं, बहुत सारे पेशेंट जो थे जब ये एक्सेल में हम डेटा मेंटेन करते थे तो ये निश्चय का डेटा जो है मेरे पास अवेलेबल है। लेकिन जब पाथ का हमने प्रोग्रेस रिपोर्ट बनाए थे उसमें डेटा जो है वो थोड़ा इससे इंक्रीज है कि बहुत सा जो डेटा माइग्रेशन है वो निश्चय में हुआ नहीं था। ये अभी के करंट सिनेरियो है। तो मैपिंग एक्टिविटी जो है ये एक ऑनगोइंग प्रोसेस ही है अभी, क्योंकि हमारे पास 14 का भी डेटा था, 17 का भी डेटा था, तो ये ऑलरेडी एक ऑनगोइंग एक्टिविटी हमारे लिए हो गया है। और जो भी हम एंगेज डॉक्टर है उनको निश्चय में एंट्री की है, अगर वो लैब है या फिर हब हॉस्पिटल है तो उनके साथ एक MOU साइन किया गया है। और डे टू डे डॉक्टर्स को एंगेज करने के लिए सेमिनार होते हैं DTO के लेवल पे। अब ये एक थोड़ा इंटरेस्टेड चीज़ है, ये उसके ऊपर ये हमारे लिए बहुत बड़ा चैलेंज भी है और हमारे लिए बहुत हेल्पफुल भी है। ये जो लैब डेटा आता है हमारे पास मुंबई में, अगर जो हम क्लस्टर में काम करें वहाँ पे 35% जो नोटिफिकेशन है वो लैब नोटिफिकेशन होता है। तो लैब नोटिफिकेशन है, लेकिन मैं बता देना चाहता हूँ लैब नोटिफिकेशन का पेमेंट हमको रिसीव नहीं होता है। नहीं तो आप लोग सोचेंगे ये बहुत ही इजी हो गया है कि लैब नोटिफिकेशन का 35% नोटिफिकेशन है तो उसका पेमेंट होता रहेगा। लैब नोटिफिकेशन का NGO को पेमेंट नहीं मिलता है। तो ये जो लैब नोटिफिकेशन आता है तो ये हम लैब नोटिफिकेशन देखते हैं, हिंदुजा है या सबर्बन लैब है या SRL लैब है, फिर हम वो लैब डेटा से हमको समझ में आता है कि कौन सा डॉक्टर वहाँ पर ज़्यादा रिफ़र कर रहा है पर्टिकुलर डिस्ट्रिक्ट से, जो शायद हमसे मिस आउट हो गया रहेगा। तो वो लैब डेटा से हम वो वेरीफाई करते हैं और फिर ट्राई करते हैं कि वो डॉक्टर को इंगेज करे। अगर एक पर्टिकुलर गोरेगांव में पकड़ लूँ कि SRL डेटा से हमको पता चला कि ये XYZ डॉक्टर्स है, उनके 12 पेशेंट और हमने देखे कि ये हमारे पास अब टाई अप में नहीं है, तो हम वो डॉक्टर को कांटेक्ट करते हैं, फिर उनको हम इंगेज करते हैं। तो ये लैब डेटा जो है हमारे लिए एक बेनिफिट पड़ता है। इसी तरह से हमने अभी H1 डेटा के लिए भी जो केमिस्ट का आता है उसके पर भी हमने इसी तरह से काम करने लगा है, क्योंकि जो भी H1 डेटा आता है आज की डेट में हमारे पास जो भी H1 डेटा आता है हम उसको पहले वेरीफाई करते हैं कि वो जो डेटा है ऑलरेडी निश्चय में एंटर है कि नहीं, नाम से, फ़ोन नंबर से, वो सब VLOOKUP मारने के बाद फिर पता चलता है कि अगर हमको एक 100 पेशेंट मिले तो उसमें से ऑलरेडी 60 का निश्चय ID ऑलरेडी क्रिएट किया हुआ है। बाकी के जो 40 है उनको फिर हम कॉल करते हैं, कॉल करने के बाद उसको निश्चय में एनरोल करते हैं। फिर वही डेटा से हमको और समझ में आता है कि कुछ डिस्ट्रिक्ट में कुछ PHC के पास कुछ डॉक्टर्स आए हैं जो एनरोल, उनके नोटिफिकेशन बहुत ज़्यादा है लेकिन वो हमारे टाई अप लिस्ट में नहीं है। तो इसी तरह से H1 डेटा जो लैब से आता है, सस्पेक्ट डेटा, और H1 डेटा केमिस्ट से आता है, उसकी जगह से उससे हमको हेल्प होता है कि न्यू जो डॉक्टर्स आते हैं उनको हम टाई अप करते हैं। और डे टू डे जो रेगुलर फील्ड विजिट में जब स्टाफ जाते हैं उससे भी उनको पता चलता है कि कुछ नए न्यू डॉक्टर्स आए हैं या कुछ न्यू नर्सिंग ओपन हुए हैं या न्यू पॉलीक्लिनिक ओपन हुए, तो उनको हम टाई अप करते हैं। तो इस तरह से ये मैपिंग एक्टिविटी जो है ये ऑनगोइंग प्रोसेस है जो चल रहा है। ये नोटिफिकेशन का हमारा परफॉर्मेंस है। 2018 में टोटल 12,500 नोटिफिकेशन हुए थे, उसमें जो टारगेट जो था उसका हमने 36% अचीव किया था, और UDST जो था 8,000 के आसपास था, 65% था। 2019 में टोटल जो नोटिफिकेशन हमारा 16 डिस्ट्रिक्ट में था। तो 2018 और 19 में देखेंगे तो आप बहुत ज़्यादा डिफरेंस है, क्योंकि 2018 में जो भी ये डेटा है वहाँ पे लैब नोटिफिकेशन का डेटा नहीं है, क्योंकि वो टाइम पे जो हिंदुजा थे, SRL थे, वहाँ से जो सस्पेक्ट रजिस्टर होते थे या वो जो टेस्ट करते थे उनका डेटा हमको कलेक्ट नहीं होता था। तो ये 2019 से हमने स्लोली स्टार्ट किया। तो 2019 में देखेंगे तो जो नोटिफिकेशन है वो 19,400 है, और टोटल टारगेट का हमने 91% अचीव किया। उसमें से UDST जो है 13,000 है और UDST जो है वो 16% है। 2022 कोविड के टाइम पे टोटल 14,000 नोटिफिकेशन हुआ, जो ईयरली टारगेट था वो हमने 61% अचीव किया। 14,000 में से 10,000 जो UDST थे, मतलब 72% हमने UDST अचीव किया।
जी, अपने पास 5-7 मिनट और है।
ओके, ठीक है। हाँ, ये पब्लिक हेल्थ एक्शन है जो ऑलरेडी सब आप देखेंगे सभी जगह पे, तो ये 70-80% जो इंडिकेटर है, जो टारगेट है उसके पे अचीव किया है। इसमें सिर्फ मैं ये बताना चाहूँगा जो DBT 84% है, वो DBT 84% में एक बहुत बड़ा है जो फॉरगिव है, जो नॉट इंटरेस्टेड है। और ये जो फॉरगिव का जो परसेंटेज है वो डिस्ट्रिक्ट वाइज मैंने पहले ही बताया था, बहुत वेरिएट है। अगर आप साउथ मुंबई का देखा जाएगा तो फॉरगिव का जो परसेंटेज है वो 40-50% के आसपास है, लेकिन जैसे नॉर्थ में जाएंगे थोड़ा वेस्टर्न साइड में तो फॉरगिव का जो परसेंटेज है वो 10 या 20% के आसपास है। तो ये जो 84% जो DBT अपडेटेड है उसमें फॉरगिव भी ऐड है। ये PPSA का हमारा मॉड्यूल ऑर्गेनोग्राम है। एक फील्ड कोऑर्डिनेटर, ऑपरेशनल कोऑर्डिनेटर, एक लैब कोऑर्डिनेटर है जो टोटल 16 डिस्ट्रिक्ट का मैनेज करता है, कितने कलेक्शन आ रहे हैं, कहाँ पे जा रहे हैं, रिपोर्ट्स किनको मिल रही है टाइम पे, वो पूरा मैनेज करता है। एक FDC कोऑर्डिनेटर है और एक अडेरेंस कोऑर्डिनेटर जो उनको उस तरह से पूरा देखता है। इसी तरह से क्लस्टर वाइज देखा जो हर डिस्ट्रिक्ट के लिए एक एक सुपरवाइजर है। उसके बाद कम्युनिटी फील्ड स्टाफ है जो फील्ड विजिट्स वगैरह करते हैं। सैंपल कलेक्शन एजेंट है, हब एजेंट है। हब एजेंट जो है जहाँ पे मैक्सिमम डॉक्टर्स है और हॉस्पिटल जहाँ पे बहुत ज़्यादा नोटिफिकेशन वगैरह आता है, या एक हॉस्पिटल में बहुत सारा डॉक्टर्स की क्लिनिक मल्टीपल टाइमिंग पे चलती है, तो वहाँ में हमने स्टाफ बिठाया, उसको हम हब एजेंट बोलते हैं। हब एजेंट है। अडेरेंस स्टाफ है जो कॉलिंग करता है, और MIS और अकाउंटेंट है। तो टोटल 114 हमारी जो है PPSA के लिए टीम है 16 डिस्ट्रिक्ट के लिए। ये सर्विस मॉडल है। तो अगर आप देखेंगे तो प्रेजेंटिव ओपन है, तो प्रेजेंटिव ओपन या तो हब में या हॉस्पिटल है या पॉली क्लिनिक में जाता है या स्टैंड अलोन क्लिनिक में जाता है। स्टैंड अलोन क्लिनिक में वहाँ पे पहले उनको एक्सरे वॉचर दिया जाता है, एक्सरे वॉचर वो लेके लैब में जाता है। और हमने अभी कंपलसरी किया है ये ईयर से कि जो भी एक्सरे पेशेंट के लिए जाता है टेस्ट करने के लिए, उसको निक्षा ID रहना कंपलसरी है, क्योंकि निक्षा ID है तो उसको हम आगे भी फॉलो कर सकते हैं। तो ये जो है क्लिनिक का टाइमिंग है, ये बहुत ही ज़्यादा अलग अलग है। जो पहले मॉर्निंग में क्लिनिक शुरू होता है वो 8:30 को शुरू होता है, और रात में जो लाइफ केयर धारावी में है वो 12:30 को बंद होता है रात में। तो वो टाइम पे कभी स्टाफ प्रेजेंट नहीं रहता है, तो डॉक्टर्स, इसीलिए हमने वॉचर से मेंशन किया गया है कि अगर निक्षा ID नहीं है तो फैसिलिटी को भी बोल दिया कि आप एक्सरे मत कीजिए, लेकिन पेशेंट को वापस मत भेजिए। वहाँ पे जो स्टाफ का नंबर है उनको दे दीजिए, वो उनको कॉन्टैक्ट करके निक्षा ID जनरेट कर देगा, ताकि हमको श्योर है कि जो भी पेशेंट का एक्सरे होगा उसको निक्षय में एनरोल किया गया है। तो इसी तरह से एक्सरे होता है। एक्सरे करने के बाद उनको CBNet के लिए रिफ़र किया जाता है। CBNet जो है वो पब्लिक ही लैब है। पब्लिक लैब से वो सैंपल कलेक्शन एजेंट जो है सैंपल लेके जाता है और रिपोर्ट्स लाके फिर हब में देता है। और अगर कंफर्म TB केसेस है तो वो पेशेंट के लिए अलग अलग ऑप्शन है, या तो वो सेल्फ ट्रीटमेंट ले सकता है या वो FDC ले सकता है। और अगर RR पेशेंट अगर आता है तो उसको हमारा जो CFR है, जो फील्ड स्टाफ है, वो पब्लिक में लिंक करने के लिए उसको हेल्प करता है। अगर FDC पेशेंट को शुरू होता है तो वो फिर से स्टाफ को कांटेक्ट करता है। स्टाफ उनको बताता है कि कहाँ से नियर बाय केमिस्ट है जहाँ पे उनको ये FDC मिल जाए। वैसे ये आउटसोर्सिंग का है। अगर किसी भी पेशेंट को एक्सरे वॉचर इश्यू हुआ है तो उसको निक्षा ID नंबर रहना बहुत ज़रूरी है। विदाउट निक्षा ID उनका होगा एक्सरे होगा नहीं। यहाँ पे मैं आपको सिर्फ जो डॉक्यूमेंट हम अपडेट करते हैं वो मैं आपको बता देता हूँ। इस तरह से ये रजिस्ट्रेशन पेशेंट का रहता है। हर एक पेशेंट का रजिस्ट्रेशन एक फॉर्म रहता है जिसमें एक प्री प्रिंटेड केस ID लिखा रहता है, निक्षा ID, पेशेंट का पूरा डिटेल्स रहता है, नाम, एड्रेस, फ़ोन नंबर। ये एक रजिस्ट्रेशन फॉर्म है, मुंबई में हर पेशेंट के लिए हम लोग फिलअप करते हैं। उसके बाद ये एक्सरे वॉचर, जैसे प्रभा ने भी बता चुके हैं पहले, ग्रीन कलर का पेपर वॉचर रहता है, उसके साथ साथ ये एक्सरे रिपोर्ट। तो ये तीनों भी चीज़ जो है हम लोग हमारे पास डॉक्यूमेंट मेंटेन करते हैं, इसकी एक लाइन लिस्ट बनाते हैं, और ये मंथली बेसिस पे हम जो डिस्ट्रिक्ट है वहाँ पे सबमिट करते हैं। वो वेरीफाई होता है PPM कोऑर्डिनेटर के थ्रू। उसके बाद फिर हम लोग सेंट्रली DTC में चिंचपोकली में MDDCS के ऑफिस में सबमिट करते हैं पेमेंट के लिए। वैसे ही FDC के लिए भी सेम मैकेनिज्म। कंफर्म TB पेशेंट रहा तो उसके पास करंट प्रिस्क्रिप्शन रहना बहुत ज़रूरी है, और निक्षा ID अगर उसके पास नहीं रहेगा, क्योंकि बहुत से पेशेंट, कुछ पेशेंट ऐसे भी है जो हमारे वहाँ पास से इन्वेस्टिगेशन कुछ नहीं कराते, एक्सरे भी नहीं कराते, CBNet उन्होंने ऑलरेडी पहले किया रहेगा, डॉक्टर उनको डायरेक्टली FDC शुरू कर देता है जिस दिन वो फर्स्ट डे रजिस्टर हुए। तो वो टाइम पर अगर स्टाफ नहीं रहा, इवनिंग का टाइम है या लेट नाइट का हब है, और वहाँ पर निक्षा ID जनरेट नहीं हुआ और वो पेशेंट FDC लेने के लिए गया, तो उसको FDC वहाँ पे नहीं मिलेगी। यहाँ पे भी सेम उसको स्टाफ को कांटेक्ट करना पड़ेगा, तो स्टाफ उसको निक्षा ID क्रिएट करेगा। यहाँ पे एक अलग टाइप का हमारा डॉक्यूमेंट होता है, इसको हम बोलते हैं इश्यू नोट। ये इश्यू नोट जो है केमिस्ट फिलअप करता है, जहाँ पे हमारे हब एजेंट है वहाँ पे हब करता है, और ये केमिस्ट जो है ये इशू नोट पूरा फिलअप करता है। आप देखेंगे पेशेंट का नाम, निक्षय आईडी सब है, रेफरिंग डॉक्टर, उसको क्या मेडिसिन दी, इस तरह से ये सब लिखा रहता है। इसमें पेशेंट की सिग्नेचर रहती है, और जो पेशेंट रिसीव कर रहा है उसकी सिग्नेचर, जो करंट उसका प्रिस्क्रिप्शन है उसका एक जीरोक्स रहता है। इस तरह से डॉक्यूमेंट करते हैं, और मंथ के बेसिस में ये हमको प्रोवाइड करते हैं। हम इसकी फिर से लाइन लिस्ट बनाते हैं, लाइन लिस्ट बना के ये हम डिस्ट्रिक्ट में DTO के पास सबमिट करते हैं, लेकिन इसका जो पेमेंट है वो डिस्ट्रिक्ट से DTO की तरफ से हो जाता है, और हर ट्रांजैक्शन के लिए 100 रुपीज़ पे करते हैं। PPSA चैलेंज हमारे लिए ये था, जब शुरुआत हमने जब ये किए थे तो डॉक्टर्स को बताना FDC ट्रीटमेंट लेने के लिए, क्योंकि इस 2014 से 2017 तक जब PPI प्रोजेक्ट था तो वो टाइम पे डॉक्टर प्रिस्क्रिप्शन लिख के देते थे, और वो पेशेंट लेके जाके केमिस्ट से जो भी मेडिसिन लेता था 183, 184 जो डॉक्टर प्रिस्क्राइब करते थे वो केमिस्ट से ले लेता था फ्री ऑफ कॉस्ट, और जो PPI से हम उसको पेमेंट कर देते थे। लेकिन जब ये FDC आया है तो डॉक्टर को कन्विंस करना कि FDC भी जो है अब अच्छी मेडिसिन है, वो ऐसा कुछ मतलब वो समझाना बहुत हमारे लिए चैलेंजिंग था। उसके लिए बहुत सारा सेमिनार हुआ, DTO लोग ने भी बहुत हेल्पफुल किया उसके लिए। उसके बाद जाके थोड़ा FDC का इंटेक जो है वो बढ़ता गया। और दूसरा चैलेंज इनकम्प्लीट इनएक्यूरेट डेटा केमिस्ट, और तो केमिस्ट से जो हमको H1 डेटा आता था तो वो बहुत हमारे लिए डिफ़िकल्ट होता था। लैब से जो डेटा आता था कि शुरुआत जब हमने लैब को टाई अप किया, जैसे हिंदुजा लैब को हमने टाई अप किया, उनको बताया गया कि आपको निक्षय में हर एक पेशेंट जो भी आपके पास प्राइवेट से आएगा वो इनरोल करना है निक्षय में, उनको निक्षय आईडी दिया गया। तो उनके लिए ऐसा है कि यार ये हम क्यों करें, उनके लिए उसको अलग से कुछ पेमेंट नहीं है। 2018 में हमने जब शुरू किया और ये कंपलसरी किया गया, तो वो जब एक्टिविटी वो करते थे तो उनका ऐसा था कि डेली उनका 3 बजे या 4 बजे एक कुछ 100 पेशेंट का जो है रिपोर्ट रेडी हो जाता था, और उनको ऐसा था कि वो साइन होने से पहले उसको निक्षय में एंट्री करना है। अब 100 पेशेंट 150 पेशेंट को उनको निक्षय में एंट्री करना है। हमने उनको रिक्वेस्ट किया हम आपको मैन पावर देते हैं, हम लोग निक्षय पे एंट्री करेंगे, लेकिन निक्षय पे एंट्री करने के लिए वो बहुत ज़रूरी है पेशेंट का पूरा डिटेल में एड्रेस रहना, रेफरिंग डॉक्टर का नाम और पेशेंट का फ़ोन नंबर, तो वो वैलिडेट करने में बहुत टाइम लगने लगा। तो हिंदुजा ने वो चीज़ के लिए हमको रिफ्यूज़ कर दिया। तो शुरुआत में वो क्या करते थे, जो भी पेशेंट है, हाँ दादर में रहता है, दादर में ओपन किया निक्षय में एनरोल करने के लिए, जो पहला डॉक्टर दिखा उसको असाइन कर दिया और दादर लिख के छोड़ दिया। फिर हमारे लिए वो बहुत चैलेंजिंग था। वो निक्षय में एनरोल होते थे रोज के 100-150 पेशेंट, उसका हम फिर डेटा निकालते थे, उसका एक्सेल मेंटेन करते थे, पेशेंट को कॉल करके उनका डिटेल एड्रेस लेते थे, फिर वो कौन से डॉक्टर ने उनको रिफ़र किया है, उस तरह से डेटा लेने के लिए हम लोग पूरा इस तरह से एक्सेल एक मेंटेन करते थे और हर एक पेशेंट को कॉल करते हैं। और उसके बाद उसका क्या रिमार्क आया, जैसे आप इधर देखेंगे ये पेशेंट है केस डुप्लीकेट आईडी, ये बहुत ही ज़्यादा होता था डुप्लीकेट है, क्योंकि जो पेशेंट हिंदुजा में जाता था सैंपल लेने के लिए तो वो डॉक्टर का नंबर रहता था या कलेक्शन सेंटर का नंबर रहता था, तो हमको फ़ोन करके पेशेंट को पूछना पड़ता था आपका फ़ोन नंबर क्या है, आपने वो जो हिंदुजा हॉस्पिटल में नंबर दिए थे डॉक्टर का नंबर है ये वाला, कि कलेक्शन सेंटर का नंबर है, आपका नंबर क्या है। फिर पेशेंट बताता ये मेरा नंबर है, फिर वो नंबर से हम निक्षय में सर्च करते थे कि कोई पेशेंट डुप्लीकेट है या नहीं। अगर वो डुप्लीकेट है तो इस तरह से हम मेंशन करते थे। और ट्रांसफ़र होने के लिए भी हम इसी तरह से करते थे। ट्रांसफर आप देखेंगे, ट्रांसफर 1 बार हुआ है, 2 बार हुआ है, मल्टीपल बार पेशेंट ट्रांसफर हुआ, उसके बाद फिर वो ट्रांसफर एक्सेप्ट हुआ है। उसमें भी एक चैलेंज ये रहता था कि अगर वो पेशेंट का डिटेल पूरा एड्रेस है, जैसा अभी मैं एक एग्जांपल दे रहा हूँ, मीरा भाईंदर है, मीरा भाईंदर पैरी मुंबई से लग के ही है, हमने एक पेशेंट वहाँ पे ट्रांसफर आउट किया, वो पेशेंट का एड्रेस पूरा नहीं है, तो मीरा भाईंदर वाले उसको एक्सेप्ट नहीं करेंगे, उसको रिजेक्ट कर देते कि इनकम्प्लीट डेटा है। लेकिन वो पेशेंट को कॉल करेंगे, उसका सब डिटेल्स लेंगे और वो अपने आईडी से लॉगिन करके न्यू नोटिफिकेशन करके एनरोल कर देंगे। तो इसमें क्या होता है, ये ऑलरेडी डायग्नोस किया हुआ है और हमने ट्रांसफ़र किया, लेकिन वो ट्रांसफ़र अगर हम वो एक्सेप्ट भी करते हैं तो वो उनके बकेट में नहीं दिखेगा डायग्नोसिस। तो इसके लिए जो पेरी मुंबई के कॉरपोरेशन है वो ऐसा करते थे कि वो पेशेंट को डिटेल्स लेने के बाद, कॉल करने के बाद उसका नया निक्षय आईडी जनरेट करते थे और इसको रिजेक्ट कर देते थे। तो ये भी बहुत केस हो रहा है, इसलिए हमने डुप्लीकेट आईडी वगैरह इस तरह से हम पूरी एक्सेल शीट एक मेंटेन करते हैं। और इसमें हम देखेंगे तो हम इस तरह से एक समरी जो है वीकली बेसिस पे डीटीओ के साथ शेयर करते हैं कि हर मंथ, जैसा अभी रिसेंटली मैं देखूँ मई में टोटल पेशेंट जो केस रजिस्टर हुए 534 हुए, इसमें से ट्रांसफ़र डन कितने हुए, 405 ट्रांसफ़र डन हुए, 14 अभी भी ट्रांसफ़र इन प्रोग्रेस है, ट्रांसफ़र रिक्वेस्ट रिजेक्टेड 44 है, डुप्लीकेट आईडी 1 है। अगर आप देखेंगे शुरुआत से तो डुप्लीकेट आईडी का जो सीरीज़ है वो कम होते जा रहा है। ये इसीलिए कि डॉक्टर्स को हमने जितना ज़्यादा पता चला कि ये डॉक्टर से पेशेंट आ रहा है उसको हमने टाई अप किया, तो ये डुप्लीकेट वहाँ से बनने आ रहे निश्चय आईडी, तो ये डुप्लीकेट जो कम होते गए। आईडी नॉट फाउंड, नो टीबी, कुछ जगह पे पेशेंट ऐसा होता है नहीं मेरा रिपोर्ट जो है नेगेटिव था, वो रॉन्गली एंटर हो गया था, पेशेंट डाइड। तो इस तरह से ये हम एक पूरी समरी बना के रखते हैं जो भी लैब नोटिफिकेशन, क्योंकि हमारे मुंबई में जो 16 डिस्ट्रिक्ट हम कर रहे हैं वहाँ का 35% जो नोटिफिकेशन है वो लैब नोटिफिकेशन है। चाहे हमको उसका पेमेंट नहीं मिले लेकिन वो हमको करना पड़ेगा, क्योंकि अगर टीबी कम करना है, नहीं तो ये 30% जो केसेस है ये ऐसे ही रह जाएंगे, उनका कुछ फॉलोअप नहीं होगा। नो पेमेंट, लेस पेमेंट, डिले इन पेमेंट, डीबीटी और पीपीस, ये हमारे साथ बहुत हो रहा है, क्योंकि अभी लास्ट 6 मंथ से जैसे सर ने बताया, किरण सर ने, डीबीटी नहीं हुआ। डीबीटी के लिए हमको बहुत अलग अलग कॉल आए कि एक तो पेशेंट ऐसा हुआ डीबीटी दिया, सर मैं अभी एटीएम के बाहर खड़ा हूँ, मेरे अकाउंट में पैसा डाल दो ना, मैं अभी निकाल लेता हूँ। पेशेंट रात को 12 बजे फ़ोन करके 11 बजे, सर मुझे थोड़ा राशन लाने का, आप मेरा डीबीटी का पैसा डाल दो। तो ये बहुत ही चैलेंज हम पेशेंट को समझा रहे हैं कि आपका कुछ भी पैसा जो है वो जाएगा नहीं, सरकार की तरफ से है, लेट होगा आपके ही अकाउंट में आएगा, 6 महीने का है, अगर आपको 7 महीने भी पैसे नहीं आए तो वो सब इकट्ठा आपको आ जाएगा, आपका पैसा कोई भी खा नहीं सकता है। ये हम पेशेंट को बहुत ज़्यादा इरिटेट, क्योंकि जो अडेरेंस स्टाफ है वो डेली कॉल करते हैं, तो उनको पेशेंट यही पूछा, अरे मैडम आप हर 15 दिन में कॉल करते हैं, पैसा कब आएगा, पैसा कब आएगा, तो उनको समझाना पड़ता है कि नहीं ये प्रोसेस में है, टाइम लगता है, आपका पैसा जो है पूरा आएगा। तो ये डिले जो है डिमोटिवेट होता है पेशेंट भी और जीपीज भी और हम एनजीओ भी। अभी जो डिले वेरिफिकेशन है जो मुंबई में, ये थोड़ा एक मैं ये नहीं बोल सकता हूँ कि ये प्रोसेस नहीं, क्योंकि सही बात है, इतना बड़ा अमाउंट अगर हमको सरकार से लेना है तो विदाउट वेरिफिकेशन तो ये पॉसिबल ही नहीं है। जैसे यहाँ पे मैंने एक एक्सेल एंटर किया हूँ, अटैच किया हूँ, ये हमने फाइल कब सबमिट किया, ओहो हाँ सर ओके सर, तो ये फाइल हमने कब मेल किया, सीटी, ये सैंपल फाइल थी, इसीलिए आउटकम की फाइल, जैसे ये गूगल शीट पे हम मेंटेन करते हैं कि सितंबर में हमने वो फाइल सबमिट किया, पीपीएम की से रीवेरीफाई होती है, फिर वो वेरीफाई सीटीओ में होती है, फिर सीटीओ लेवल पे वेरीफाई होने के बाद फिर वो वापस पीपीएम के पास जाती है, पीपीएम से वापस वेरीफाई होती है। मीन्स मेरा वो कहने का सिर्फ यही है कि डिले है पेमेंट में, लेकिन यहाँ पे 100% वेरिफिकेशन जो है वो डिस्ट्रिक्ट पीपीएम कोऑर्डिनेटर की तरफ से होता है, और मुंबई जो है टोटल 24 डिस्ट्रिक्ट्स है और सीटीओ एक है हमारे पास, तो टोटल 24 वो फाइल्स जो है वो प्रोसेस होती है पीपीएम कोऑर्डिनेटर की तरफ से, लेकिन वो आके सब ट्रैफिक लग जाता है सीटीओ ऑफिस पे, क्योंकि सीटीओ ऑफिस एक ही है, वहाँ पे प्रोसेस करने वाला आदमी एक ही है। तो प्रॉब्लम हमारा वही है, मैं इसलिए बोल रहा हूँ क्योंकि एसटीओ सर महाराष्ट्र के भी इधर ही बैठे, तो ये शायद सर प्रॉब्लम सॉल्व कर सकते हैं कि वो फाइल पीपीएम कोऑर्डिनेटर से बराबर जा रही है, लेकिन वो सीटीओ पे आके रुक जाती है, क्योंकि सीटीओ में 1 या 2 ही पर्सन है जो पूरी फाइल वेरीफाई करते हैं 24 डिस्ट्रिक्ट की, और वो जो वेरिफिकेशन है वो 20% होता है। और स्मॉल चिल्ड्रन से जो कॉन्टैक्ट ट्रेसिंग के लिए जो है आईएनएस जो है वो अभी भी हम लोग उसके ऊपर वर्क कर रहे हैं, वो अभी भी लेकिन इम्प्लीमेंट उतना नहीं हो पाया है। एक लास्ट स्लाइड है, बेस्ट प्रैक्टिस। जैसे मैंने बताया एज लैब वगैरह के, तो डेटा के ऊपर हमने बहुत काम किया और वो बहुत इम्प्रूवमेंट हो रहा है, और वो सच में हुआ भी है, और उसकी वजह से हमको जो इंगेजमेंट है करने में हमको बहुत हेल्प हुआ कि उससे पता चला कौन कौन से प्रोवाइडर है। फॉलोअप ऑफ माइक्रोबायोलॉजी नेगेटिव पेशेंट, ये बहुत ही इंपॉर्टेंट है। ये हिंदुजा में अगर हमारे लैब है, या हमने जो अब कुछ अभी डिस्ट्रिक्ट है कांदीवली, मलाड, वहाँ पे हमने ये शुरू किया है। प्राइवेट लैब्स को हमने कांटेक्ट किया है जो हमारे साथ टाई अप है, उनको बोला कि आपके पास हमारे पास तो हमारे वॉचर लेके तो पेशेंट आते हैं, और भी कोई पेशेंट अगर आपके पास डॉक्टर रिफ़र करते हैं, उनका एक्सरे की लाइन लिस्ट हमको शेयर कीजिए। तो ये हमने अभी कांदीवली में, मलार में शुरू किया है, और इवन हिंदुजा और SRL लैब में जो प्रेजेंटिव ओपन केसेस रहते हैं, वो भी नंबर बहुत ज़्यादा है, 1000 में रहते हैं। हम उनको कॉल करते 1 महीना 2 महीना टाइम के बाद कि आपने ये टेस्ट कराया था, आपका रिपोर्ट निगेटिव हुआ था माइक्रोबायोलॉजी, आपने कल्चर कराया था, ये इस तरह, तो अभी आपका कुछ ट्रीटमेंट चालू है क्या एक्सरे बेसिस पे, उसके बाद डॉक्टर ने और कोई टेस्ट कराया है क्या। तो इसमें भी हमको एक 22 से 3% तक केसेस मिलते ही है माइक्रोबायोलॉजी। और वैसे ही जो लैब है, जो प्राइवेट लैब्स है, उनके पास अगर कोई जो नेटवर्क में डॉक्टर नहीं है वो रिफ़र करते, उनको भी हम कॉल करते। अगर उनको टीबी नहीं भी है तो भी हम उनको प्रेजेंटिव करके ऐड करते हैं और उसको नो टीबी करके आउटकम दे देते हैं। FDC, DBT जो है हमारे लिए भी, ये भी एक चैलेंज है, क्योंकि जैसे मैंने बताया कि 30-40% नोटिफिकेशन है लैब का, वो हमको मिलता नहीं है। लोग वो पेशेंट हमको फेस टू फेस हर एजेंट को मिलते ही नहीं है, या हमारे स्टाफ को नहीं मिलते, तो फ़ोन पे DBT लेना वो भी मुंबई की पब्लिक से बहुत डिफिकल्ट है। तो उसके लिए हम लोगों ने क्या किया कि पेशेंट फ़ोन ही कट कर देता, मैं तुम्हारा पुलिस में कंप्लेंट करूंगा, कहाँ से बोल रहे हैं आप, बैंक डिटेल क्यों मांग रहे हैं। तो इसके लिए फिर हमने क्या किया, व्हाट्सएप पे जाके, क्योंकि हर एक निक्षय में ये एक बहुत बेस्ट थिंग है कि विदाउट नंबर सेव किया आप व्हाट्सएप पे क्लिक करेंगे तो आप डायरेक्ट व्हाट्सएप भेज सकते हैं। तो निक्षय पोषण योजना क्या है वो उनको बताते हैं, उनका निक्षय आईडी क्या है वो पेशेंट को बताते हैं, ताकि वो पेशेंट को थोड़ा भरोसा है। उसके बाद फिर वो पेशेंट जो है अपनी बैंक डिटेल वगैरह व्हाट्सएप पे शेयर करता है। वो अपडेट करने के बाद रीवेरीफाई करने के लिए हम उनको स्क्रीनशॉट भेजते हैं। उसी तरह अगर वो पेशेंट फॉरगिव है, अगर वो नहीं इंटरेस्टेड है, तो पेशेंट को हम लोग बोल देते हैं कि साथ में हम लोग आरोग्य साथी का लिंक भी शेयर करते हैं। अगर आप हमको बैंक डिटेल नहीं शेयर करना चाहते तो आप खुद से ये लिंक है यहाँ पे आप अपडेट कर दीजिए। और इसी तरह ये फॉरगिव का है, उनको पूरा डिटेल शेयर करते हैं। और अगर पेशेंट नॉट इंटरेस्टेड बोल रहा है तो उनको हम बोलते हैं हम प्लीज़ आप रिप्लाई कर दीजिए, ताकि आपको इसके लिए दोबारा कॉल नहीं आएगा। अगर आप रिप्लाई नहीं करेंगे तो हर 4-5 दिन में कोई ना कोई आपको फ़ोन करके पूछेगा कि आप बैंक डिटेल शेयर कीजिए। तो वो बताने के बाद फिर पेशेंट बोलता है ठीक है अभी मुझे और कॉल नहीं आना चाहिए, इसलिए वो लिख देगा नॉट इंटरेस्टेड ये। तो ये स्क्रीनशॉट मार के हम फाइल प्रिंट निकाल के DTO के पास रखते हैं। तो इस तरह से ये व्हाट्सएप पे हम पेशेंट का अगर वो नॉट इंटरेस्टेड भी है तो उसका रिप्लाई ले लेते हैं। उसके साथ हमने ये ट्रीटमेंट कार्ड भी बनाया है। ट्रीटमेंट कार्ड पे भी हमने लिखा है निक्षय पोषण योजना क्या है, और एक फ़ोन नंबर है, वहाँ पे भी वो व्हाट्सएप पे शेयर कर सकते हैं। अभी जो न्यू ट्रीटमेंट कार्ड प्रिंट करेंगे उसमें TB आरोग्य साथी का हम लिंक शेयर कर देंगे, ताकि वो पेशेंट भी खुद से अपडेट कर सके। अडेरेंस टीम है जो अडेरेंस करती है, रेगुलर सेंसिटाइजेशन फॉलोअप है केमिस्ट का। अभी हमारा आगे का प्लान यही है कि जो केमिस्ट है उनको थोड़ा फोकस करना है, और उनसे ज़्यादा से ज़्यादा केमिस्ट से हम H1 डेटा कलेक्ट करने की कोशिश करेंगे, ताकि ज़्यादा से ज़्यादा डॉक्टर से जो है उनको इंगेज कर सके। थैंक यू।
So, thank you, Akbar. You nicely described the entire processes related with mapping, with processes for service delivery. So let us open for discussion. Any comment or question from jury?
I have only one comment, and that is for not only to this group but also to the entire rest of the groups which are going to make presentation. Please mask the patient identity, even if it is a matter of presentation here, because the entire details are known, including telephone numbers. Right? We are all conscientious people, no worry about that. But that invades the privacy of a patient.
Okay,
so
sir.
Please mask it.
So, any comment or feedback from participant? Yeah.
Yeah.
Because FDA is not Indian.
No, FDA फूड ड्रग्स एडमिनिस्ट्रेशन से मुंबई के लिए अगर केमिस्ट में रखना था तो उसके लिए हमको अप्रूवल लेना था, ये कंपलसरी हुआ था और ये कमिश्नर की तरफ से आया था, तो उसको हम फॉलो कर रहे थे।
No, I understood that,
Yeah.
but I think the agency name, FDA at least, I don't know if it is called FDA in Mumbai, but FDA is a US thing, so I'm not... Okay, that's what I wanted to check. Fine.
Yeah, please.
Thank you for this wonderful presentation. And I'm sure a lot of hard work would have gone into mapping the private sector. You have a rich data source of private players. Do you have any suggestions or plans to share this data with the general health system, maybe district health officer?
नहीं, ये जो भी डेटा है मैडम, ये CTO लेवल मुंबई के पास अवेलेबल है ऑलरेडी, और उनके साथ हमने शेयर भी किया है। और हमारे शेयर करने से पहले 2018 से पहले जो भी एक्टिविटी हम किए थे पाथ के लिए किए थे, तो पाथ ने ये डेटा जो है शेयर किए थे ऑलरेडी। थैंक यू।
Great. Please.
I think he already has a plan in place. Lots of PPSAs are doing private sector mapping. I'm just following up on what Vijayashree mentioned. In our country, we have very limited information about the private sector in terms of individual practitioners or the diagnostic labs or hospitals, etc. So if all the PPSAs can do the geotagging of all the private providers, and it can become a national, repository or some kind of a live registry. So the TB program, CTD, can facilitate with the Ministry of Health in terms of actually updating or increasing the database of the private providers. So I'm sure he is already on to the job. So I'm just requesting him to integrate this.
So it's already happening. In 2018, through the NHRR, there was a nationwide mapping of both public and private health facilities, and then that was shared with all the districts and the states, and the regular updation of that, and making sure that the people or the facilities which are diagnosing cases and who are either having lab or it had both all the chemists, labs and all those things. So all those things are updated in NICSHE, and it's something which is an ongoing process. So the PPSAs are not working in isolation. The database that they are having is in NICSHE only. So even though Akbar is maintaining separately on Excel, but the entire database of all those cases as a new person is identified gets into NICSHE, because a case has to be notified. So if there is a doctor which is first time notifying a case, first his HFID is created, it's registered and it's on. So definitely it's something which is ongoing, and I'm sure all the states and the PPSAs as they go on implementing the projects, they'll keep on validating the database that is there in NICSHE and keep on refreshing it as required. So that's something that's already happening. Yeah, thanks. So thanks Akbar. Actually, I would appreciate, I would request all of you all to give a good clap for Akbar.
Thank you. Thank you.
Because we both started our career 20 years back in the slums of Mumbai with private sector, and reaching out, getting labs on board, and all those things. So he's grown a lot after that, and I'm sure the good work that he's doing is going to show good results. Congratulations, Akbar.
So good news is that we are proceeding with the last presentation of the day. So actually Nagpur has been one of the oldest PPSA implementing district, and that has seen the transition amongst amongst domestic PPSA. So may I request Trela and Neeraj Pathak to present the work of HLF PPT in Vidarbha region. So we have I hope we can stick to the time.
He has also got to home.
About the experience and the almost
lot of things has been covered, so I will not focus on that. I will not elaborate that thing. And first of all, I will thank you CTD and NTSU for giving this opportunity to present our work. So here there was discussion, we are learning, as Misra sir has focused on the we are learning. We are also learning a lot of things. So we'll discuss that what learnings we got from this PPSA program. Actually, HLPPT is implementing this program in 5 states. We start our intervention from the Maharashtra, then we start our program in Chhattisgarh, Orissa, and UP recently we started, and then thereafter we are going to start our program in Gujarat state. So this is our intervention area where we are covering approximately 81 lakh population, and the notification target is 9,400. Here, as one learning I can share with you that when we were ideally discussing about the coverage population of 1300 Akola MC, it says that the population is reside in the Akola Municipal Corporation area. But the fact is different, and it's vary from district to district. Akola Municipal Corporation is having a 1300 population, and our experience is registration is approximately 5% patient from the other districts is covering the Akola district. Similarly, this situation when comes to the Nagpur, it's a quite different situation. We are catering a 37 to 40% population from the other district. It's based on the services available in the Nagpur district and from the other district. Even if you say the other state also, Nagpur is bordering to the Madhya Pradesh, and so we are also getting the patient from the other state as well. So we are having in 5 districts this program in Akola, Amravati, Nagpur, Chandrapur, and the Pune rural. We signed the contract in Jan 21, so we cannot say it's a much experienced in PPSA program. We have more than 1 year experience in this PPSA program. We signed our MO in 15th Feb, and then thereafter the complete the process, hiring of staff and the training of staff, and we start the mapping for all 5 states. Then this is our achievement that we compare the before PPSA intervention and the after PPSA intervention. Slide has been changed, like it's a 2020-21. Our achievement from the March 21, you can say that before PPSA intervention it was 66%, and at the end of December it's a 90% achievement we got in this. This current year's achievement, we have a significant improvement in our like notification achievement. You can see that where in Jan 2020 is a 79%, where we have reached in June 2020 115%. So there was certain area, since we are implementing program from March 21, we were continuously identifying the area where we need to focus, what are the area we look into this. So accordingly, we continuously doing exercise, meeting with our team and reviewing the data, what is working well and what we need to focus. So that district-wise analysis is also help us to analyze the data. It's a 91% achievement is Nagpur Municipal Corporation, 99% achievement is the Chandrapur. So overall achievement, if I would say, it's a Pune rural achievement is 121%, and the overall achievement is 102%. So notification somehow we have achieved. Nagpur is the area where we are still focusing. It will be go more than 100%. So what process we adopted, that is discuss a lot about the universal mapping. So initially we receive a list of 5,597 private providers from the CTO office. Then we added approximately 860 private provider in. So total the mapping universe is 6,457. And out of this, we found that 892 are the providers who is providing TB related service. So this we did an intensive mapping exercise. We'll not go into Excel as well. That we identify the universe of all private providers who are involved in the microbiologist and pathologist, radiologist, pulmonologist, pediatrician, and thereafter we focus whosoever is giving the services related to TB. And this exercise also help us in the developing the linkage for the EPTB cases. How we can link our EPTB cases to the specialist private providers. This service model has been spoken, so we will not discuss about. We are covering the entire spectrum of services like related to the patient sputum transportation, and then collection of reports sent back to the private provider, and the contact tracing. Contact tracing specifically, we could focus on the patient residing within the district area. Specifically, if we are assigned to the municipal corporation area, then the other district area, we are doing the institutional based contact tracing. And then we are also focusing on the chemist shop. You will see in the next slides. So model has been discussed. It's a Nishchay Mitra model, and it has also discussed how we are engaging the Nishchay Mitra. We are first informing, sharing this information, what incentive we will give to the Nishchay Mitra. Nishchay Mitra is incentivized for the each step of activity, like starting from the notification and the further public health action, starting from the UDST, then DBT and HIV, diabetic, and finally at the last is a treatment outcome. For the treatment outcome, we are submitting is a documented evidence. We are taking a private practitioner signature and completely signed and evidence-based document we are collecting for the treatment outcome reporting purpose. Similarly, for the each and every public health outcome, we are having a document and evidence related to that particular notification. This is the treatment card where we are capturing complete information of the patient. This single card gives you the complete information of the patient that related to the treatment follow-up and the what kind of patient registration information, and also how we have a wider number of Nishchay Mitra in the Maharashtra in 5 districts. So there is approximately 500, more than approximately 600 number, 561. 561 Nishchay Mitra are there, and they are connected with our each field officers and the sputum collection agent. So there is a common group. Whenever the patient is reported at the Nishchay Mitra, it's immediately informed, and accordingly our team is active and they are reaching for the further notification and the further follow-up of the patient. This we can say is a best practice. Our team has discussed and did the advocacy with the drug controllers, and based on this drug controller, why this we say that we are not getting a data from the H1 data from the chemist. So drug controller has issued a directive to all chemists. Accordingly, we discussed with the NTP team also, and this is in the close coordination of NTP staff. So NTP developed a common email ID where the all chemists has started reporting the H1 data, and this data is being analyzed even in the it's a fortnightly and weekly meeting at the CTO and DTO office, and accordingly we are focusing on the missed notification. We are matching in the all notification, and we are focusing on the missed notification as well. Similarly, that this data is also that district-wise they have developed an anti-TB drug sales group, and this chemist is also reporting, and that particular group that they have sent this data to the email through the email communication, and you can verify the same. And then accordingly, our field officers start visiting to these particular chemists for verification and further detail that after matching the missed notification, they have started reaching that from where this patient has reached to the chemist and how this data is coming from the chemist shop. That impact of this data surveillance is that patient on TB treatment collected from the line list from the H1 data from all chemists, and we could identify few hospitals where we are missing the data. So there are some hospitals like BIMS, Kingsway Hospital, Alex Hospital, Bocard Hospital, Sunflower Hospital, where we are missing some data which is being actually referred to and they are taking a ATT direct from the chemist shop. And we also cross-check this H1 data and data from the labs, OPD, IPD, MRD. These are the bigger hospital where the OPD data somehow we are getting, but the IPD data is missing. So with this H1 data, we at least reach to the notification which is missed from our area. And the significant number of patients has been identified from this exercise since Jan 2022. This is that increasing notification. We are also in close coordination with the NTP staff. We are reaching to the Ayush providers and putting our IC material. And in Maharashtra, we can say as of now, it's a huge number of Ayush provider. We could leverage 8% of Ayush practitioner who is actively referring the presumptive TB case, and we could also get the 15 to 20 new notification from these Ayush practitioner. This is also, we could say, it's a best practice. As in previously mapping slide, I also said the lab surveillance. So we engage the pathologist association for directing lab to share the monthly data on the test done for. Accordingly, district PPM coordinator and the PPSA Nagpur MC created a common email ID. This also works well because we are working in the close coordination of NTP staff. So we are getting this information in that common email ID, and where we are reviewing this data, and that 15 to 20 labs share their monthly data for patients who have visited their labs. Accordingly, we check from who is the referring facility for this patient, and we could actually identify the missed TB case notification through this lab surveillance data. This is a lab engagement. We also face some cartridges problem, shortage issue we face in Maharashtra, specifically in Nagpur, even on other districts as well. So we discuss with the CTO office, and accordingly, what we could discuss, we have put in this in our ROP, like Suvishwas lab we have identified for this purpose, and the cartridge-based model we have put in, and hopefully this will be approved. Then we will be able to increase our UDST number, which we are still facing a difficulty in specifically Nagpur district. Then patient bank detail collection drive for the NPY. We are analyzing our data for the Maharashtra state for these 5 districts where we are lagging for the 2 specific indicator. One is a DBT, second one is a UDST indicator. For UDST, we have proposed a cartridge-based sharing model, and for DBT, we itself took initiative. We found there are certain problems we are still working on. There are certain areas where the Maharashtra, you might be aware, is a number 1 state having a highly cooperative banks in Maharashtra state. So that cooperative bank issue is one issue, but somehow that patient from the other state are covering, and from the other district we are not getting data. So we discuss within the team. Accordingly, we download our notification register, and we start a calling drive, and we our field team contact the more than 900 patient, and we sensitize the patient about the Nikshep Poshan Yojana. Accordingly, we send this communication and ask them to share the NPY benefits detail, and we share this Nikshep Poshan Yojana of government and sensitize them, and then ask them to share the bank detail for the benefit of this Nikshep Poshan Yojana. And somehow, if somebody is not willing, we also ask them, if you are not willing, you send your consent to one particular, respond to our WhatsApp number. So, I think number is missing. So, approximately more than 900 patient we reached, and more than 200 bank detail we got. Out of 900 calls, we got a 200 bank details of the patient, where that bank detail we received, and when we try to update this, we found there are duplication in the bank detail. We go into that, what is the duplication. We also get the consent for the forgo patient. That number is not reflecting in this PPT. I don't know how come it's missing, but it is there in the number. And there are certain patients where we could not reach, and we also came to know there are certain patients who have been died after registering and notifying the patient. So with this complete information, we update this information in the Nishchay, and accordingly we could increase our DBT component. Here, this is a one incident of the WhatsApp where some patient has sent that मैं अभय एम काटेदार आपसे नम्र निवेदन करता हूँ कि सरकार की ओर से मिलने वाली 500 रुपये सहायता राशि मुझे नहीं चाहिए. So like this is an example of a 4G patient. So this issue we want to highlight and like support from the CTD also. When we are updating the patient detail, one pop-up is reflecting a beneficiary with the account detail is already exist. But we are not able to identify from which ID this patient is registered. If we got this ID, then we can also cross-check and immediately update this information in Nishchay. So this will help us to identify the duplicate patient entries, and accordingly we can take a resolution for this against the DBT cases. This we are plugging the gap as we discussed, like there are two challenges related to. One is a UDST. For UDST, we visited a lot of private provider and we sensitized the private provider. There are certain private provider, they don't want to listen to PPSA also. So where in that case we discuss with our CTO office and we visit again along with the CTO, and somehow some provider are not convinced with the CTO. Then again along with the associate professor from the Maharashtra Nagpur Corporation, we visited to somehow that some providers has been convinced. Now we are focusing or some CMEs for the all private provider so that we can overcome from this situation. So whosoever is convinced, we are putting our Falcon tube at that their practitioner place, and accordingly our sputum collection agents are collecting this sample from this private providers, and it's a 24 within the 24-hour time we are transporting this sample to the lab facility. Similarly, it's a home-based facilities also. We are focusing our patient home-based and sensitizing them to the phone calls for the UDST. And if at some point of time, if it is a support required from the home-based sample collection, our team is reaching to the patient home as well. This organogram, we have our 561 Nishchay Mitra at the private health facility. We have our telecounselor also, who is putting effort from the state level. We are continuously analyzing our data, where is a notification and what are the status of public health outcome. Accordingly, our telecounselor is putting their effort related to the document and getting information. And this additional position is a lab technician we have put in Nagpur. So this lab technician is supporting to the means that he is working in that particular Sadar lab, and he is also facilitating and supporting for the testing of the private sector notification. These are the very few challenges. So the duplication I already discussed. This is one challenge. It needs support from the CTD. And another samples extraction for the EPTB cases for the UDST, where in Maharashtra we have approximately 45% cases for the EPTB and 55% cases for the pulmonary cases. So we need support for this, like sample extraction for the EPTB, because it's a costing and somewhere provider as well as the patient is avoiding for this sample extraction for the EPTB cases. Then we also face a irregular supply of CVNet cartridges. It was issued in February, even in April, and we can say as and when we are facing this supply, though we have proposed is a cartridge-based sharing model, probably we will be able to overcome with this situation as well. And we also face a technical issues of Nishchay app when we are updating this data. This was the previous 2-3 months we face as a frequent issues related to the Nishchay app. And hopefully it's the last slide. It's a lesson learned that universal mapping exercise is helpful for the categorization of private provider, and this will also give us a scope for the coverage of program activity. Then significant achievement in notification by adopting the strategic intervention like Nishchay Mitra, H1 data surveillance, lab data surveillance, and the engagement of iOS practitioner. We have reached to the 8% engagement we have completed, and we are still focusing on the engagement of iOS practitioner. Then building linkages for the diagnostic service using dedicated HR that we have put in, and we saw that significant improvement for this HR, we have put it a lab technician in the already lab. Then intensive drive for create awareness of Nishchay Poshan Yojana and DBT is a help us lot to collect the bank account. Thank you so much.
So thank you, Pathak ji and Strela, for discussing all the components, be it H1 surveillance, be it Ayush provider involvement, be it strengthening diagnostics. So let us open it for discussion. Any comment or questions from jury? Any comments or questions from audience? Or all are exhausted?
Seems to. Hopefully, I will not miss the opportunity.
So great. Then back to Dr. Sandhya.
Thank you so much.
Yeah.
Thank you.
Dr. Neeraj, please.
Okay, so I think that's the last presentation. We have a small demonstration here from Doctors for You. Like they had informed earlier, they have got their handheld X-ray device, digital X-ray device, which they are willing to demonstrate. So it will take them around 10 to 15 minutes to set it up. So that's a team from Doctors for You and Lab India. So they will take around 5 to 10 minutes to set up this, and I think there might be some cross-learning over here. So please go ahead, set it up. So one important thing which I wanted to discuss with you. We could demonstrate today varied models of implementation of PPSA. So this is an open offer to you. If you require any support, let's publish this. You know, that people do not know what is happening in India is, for me, unacceptable. So we, the NTSU team, all the TSU, together with you, are willing to sit with you, handhold you and curate your data. If you want, we can come down to the field, help you curate the data and help you in writing it up, so that, you know, a lot of publications can come out of it and people know what is happening, and, you know, this dissemination happens actively across the globe. Then there is no, you know, that you have some, you know, this visibility across the globe, that this is the unique model which you have done. This is the call center. What is the economic analysis of it? How you did it? You cannot do justice to what you have done in 20 minutes, right? This is just to give you a flavor of, you know, people are interested in. Yeah, this is a platform for you. But now, I think one take home, you can take some guidance from Professor Venkat and other over here and try to bring out, you know, these things, and let's write it up, let's publish it.
So, good evening, everyone. I think I started and I'll only end. So, probably it's my day. So, why we wanted to demonstrate this? We are actually running few of our active case finding projects in the tribal areas, Madhya Pradesh and various other tribal areas. We have our mobile vans with an X-ray fitted machine in that. The problems we were facing were like, when you take the van to such areas, it's very difficult at times because the terrain is bad in tribal areas, roads are bad. Thirdly, electricity is not there. So you have to run the machine with the support of the electricity. You don't find it many of the places. Then that machine requires a stabilizer. Then it is difficult, you know, to carry such a heavy machine with lot of transportation which is required to go in such places. So we were facing a lot of challenges, and we were actually looking out something, you know, which can innovate and which can help us out to provide a solution for such tribal areas where we can diagnose and do the X-ray there and then and give the results. We then had a word with ICMR. We are also, you know, we'll be working in a few days. We'll be starting the projects in other tribal areas in the ICMR, with the ICMR in 11 sites in different tribal areas of India, like in Kerala, Tamil Nadu, Andhra Pradesh, Madhya Pradesh. So various other areas where we'll be using this machine definitely. And the whole idea is to see how this small portable 1.8 kgs machine can be carried by a single person in a backpack and the X-ray can be done there and then, definitely support for the radiologist is required to read the X-ray. But then it has an inbuilt technology that it can be connected to a laptop, and you can send the X-ray through online, and the results can be given within a day. So let's see that. Can you please demonstrate?
So the whole product is before you. Now this is the X-ray generator or the source. This weighs only 1.8 kilograms. This looks just like a DSLR camera. Now the whole concept of bigger X-ray machines has changed and made very compact. So the X-ray generator you have seen, and this is the largest by far, the X-ray detector. This is a digital panel detector capable of storing 100+ images also, and this is able to bear the weight of any patient, almost 400 kilograms directly over it. So we have the acquisition laptop and software ready to take the X-ray now, just for the demonstration purpose. So for us to be able to do it, we will volunteer ourselves. My colleague Santosh is also here. So since the X-ray being very safe, in fact the safest that is available in the market, one dose of X-ray, chest X-ray, is almost 0.0021 millisievert. So that is very, very less, and according to AERB approved certifications, we have no necessary civil infrastructure needed for this X-ray. So this can be very well taken by one person in 2 backpacks, carried in motorbikes from one place to another place, and take the X-ray in camps, and it can be used for screening programs. Yeah. So yes, we have to compare the doses exactly. So any normal X-ray that is installed in a hospital, that is ranging from 100 milliamperes to 150 milliampere machines. So the radiation dose in those machines is approximately 0.1 millisievert, and the total output of this machine, the radiation is 0.0021 millisieverts. So that is almost 100 to 1000 times lesser than what we get from conventional machines. So that is how safe this machine is, and that is one of the USP of this machine, is being very light and being the safest machine that is available.
The plate is of which company?
So the plate is LG made, and the acquisition laptop and software is LG made, the very company that we have been relying upon since many, many years. And the X-ray source or generator has been imported from Korea.
So which is more costly, that camera or this plate?
So the both company has actually MOU signed between them. So the whole configuration comes all together. It does not come separately till now. So we cannot actually bifurcate. So that is actually, it comes all together in a single configuration. So the companies, so the costing will vary depending upon different configurations and the volumes required. Anywhere that can go beyond anything. Okay. So the ranges will start from anywhere between 34 lakhs. It can go up to 48 lakhs.
Battery, you can take the machine on field and it